Hello, good morning, everyone. Am I audible?
Yes, you are.
Okay. So, a very good morning to everyone. It's great to have you all here. Myself, Dr. Priyanka Kamble. I'm an assistant professor from ACPM Dental College and Hospital, which is in Dhule, Maharashtra, India. I would like to thank the organizers at UCG, the 12th Emirates Pathology and Digital Pathology Utilitarian Conferences for letting me to chair the sessions. So it's a pleasure to be a chairperson. And now we will begin the day 3 online session. I would like to introduce our first speaker of the day 3, Dr. Sharon Shin Lin Lee from Australia. I'm passing her the stage to deliver the speech on a single center audit repeat preoperative colonoscopy. Over to you, Dr. Sharon.
Great, thank you so much for the
Kindly
introduction.
share your screen.
Can everyone hear me? Sorry, I'm quite terrible at technology.
Yeah, you're audible. You're audible.
Great. Let me just share my screen.
Yeah.
No.
Visible.
Okay. All right, great. So good morning, everyone, or good afternoon if you're like me in the Southern Hemisphere. My name is Sharon Lee, and I'm one of the colorectal registrars at Northern Health in Australia. And I'd also like to thank the organizing committee for selecting us to actually present our research, which is looking at a single center audit, looking at the repeat preoperative colonoscopies at our center. So as we know, colonoscopy is the gold standard for diagnosis and surveillance of colorectal cancer. And a repeat colonoscopy, either preoperatively or intraoperatively, may be required for accurate tumor localization, with the reported rate as high as anywhere between 31 to about 40.5% of repeat colonoscopies. However, they in themselves do have an inherent risk and an inherent cost to them, and may be associated with a delay to that definitive treatment. So why do we do these repeat colonoscopies? The most common indications are it's an unclear anatomical tumor location. Sometimes it's to go back and tattoo a lesion that was initially omitted if there are any insufficient biopsies. If it was poor prep, and so then you had to go back for a incomplete colonoscopy, and to evaluate any synchronous lesions that may occur. So some studies actually report tumor localization error rates anywhere between 4 to 20.8% during that initial colonoscopy, which decreases to about 2.6% after your repeat colonoscopy. And so then accurate tumor localization, which is the first common indication, is of the utmost importance, especially with this trend of going towards laparoscopic management for our colorectal cancer patients. And that's because we lack that tactile sensation that we get back when it's via a laparoscopic approach. And so these errors in tumor localization can actually have quite dramatic clinical consequences, including intraoperative changes to a surgical plan, the need for an unplanned intraoperative colonoscopy, and the complications arising from an acutely dilated bowel, for example, when you're filling it with air, conversion from a laparoscopic to an open approach, and in extreme circumstances, some have reported actually removal of the incorrect segment of a colon. And then going to the next indication, tattooing of the lesions. So tattooing of lesions suspicious for malignancy helps in two ways. So it helps facilitate that localization intraoperatively during the operation, or for endoscopic follow-up post. And so there is really a lack of consensus regarding these two. So the tumor localization documentation, as well as a tattooing technique. So what did we do? So we actually conducted probably the first Australian and New Zealand study, which actually aimed to evaluate that subset of patients that require that repeat colonoscopy, and to determine what the indications for that repeat colonoscopy were. We also reviewed the quality of that initial colonoscopy and its impact on the clinical outcomes post. So what was our study? So we conducted a retrospective study of colorectal cancer resections during a 5-year time period. So from January 2016 to January 2021. And we included all colorectal cancer resections at the Northern Hospital in patients who had had a colonoscopy prior to their colorectal resection. And so therefore, we excluded any emergency colorectal cancer resections because they didn't have a colonoscopy prior to that, or we excluded patients who didn't have an operation at all. So they also weren't included. The patient demographics, the colonoscopy findings, the operative details, as well as all of the complications that the patients had were retrospectively retrieved from our national database, which is called the Binational Colorectal Cancer Audit Registry, as well as the local hospital records. And so we defined the initial colonoscopy as the endoscopic procedure that's leading to that diagnosis of the index colorectal malignancy that is subsequently resected. And so therefore, any repeat colonoscopy was any endoscopic procedure that followed that initial colonoscopy, but was prior to their operative management. The colonoscopy reports were also reviewed to determine the indication for that repeat colonoscopy and to identify whether any of the tumor locations were actually revised because of that second colonoscopy or third colonoscopy, and whether any synchronous tumors were present. And when we're reporting our results, it's important to note that we defined the tumor localization or the tumor location as the one that was reported in the intraoperative location that was dictated by their op report, so their definitive surgical management. And all analysis was done on SPSS. So we'll go through the results real quick. So the first one is on the patient demographics. So in total, we had 339 patients who had a mean age of 67 and 58.4% of them were male. So these were the types of operations that we perform at our center, and this was the number that we performed over that 5-year period. So predominantly we do quite a lot of right hemicolectomies, followed by the high anterior sections and the ultra low anterior sections. So we do anything between open to laparoscopic, but we don't offer robotic surgery at our institution. Okay. So what this is showing is that the total cohort from BCCA, so that 553 that's recorded there, is the total number of patients at our hospital that were diagnosed with colorectal cancer in that 5-year period. So that's from the registry, the national registry. So as I said before, we excluded any emergency cases that didn't have a colonoscopy prior and any non-operative cases. And by that, I mean any patient who was already diagnosed, for example, with quite advanced stage metastatic disease that didn't require an operation. So they were excluded, which left our total of 339, as I said before. So they were split into surgeon endoscopists and non-surgeon endoscopists. And by that, I mean that surgeon endoscopists encompassed any surgeon who performed that colonoscopy, compared to the group called the non-surgeon endoscopists, which included both our gastroenterologists and our nurse practitioner endoscopists as well. And so as you can see there, about 28.6 or 94 in total underwent that second colonoscopy. And the initial colonoscopy performed by a surgeon group that required a rescoping was 29.6. So that's that 45 out of the 152 that were initially done by surgeons, compared to the non-operating endoscopist group, which was 26.2% that required rescoping. So that's the 49 from that 187 that's reported there. But it's important to note that even with these numbers, they weren't statistically significant. So the p-value was 0.46. And then in terms of the repeat colonoscopies, 64 in total were planned preoperatively, 21 were planned for on-table, and 9 in total were unplanned intraoperative colonoscopies. And out of all of these, 3 other patients underwent a third colonoscopy. And so what were the indications for our second colonoscopy? The primary one was that we needed to confirm the tumor location. Either there wasn't a tattoo available or there was a discrepancy between where it was tattooed and what was documented on the colonoscopy report. The second most common one in our planned group were those who didn't have that initial lesion tattooed, so they had to go back for a tattooing. And then the third most common was that there was a suspected synchronous lesion, either documented on a CT or it was poor prep and required rescoping. And then the indications for an unplanned second colonoscopy, so those are the ones that are done intraoperatively, was that we needed to confirm the tumor location, or the tattoo just wasn't seen intraoperatively, especially when we're doing our cases laparoscopically. Those are the rest of the numbers if you'd like to have a look. And then the indication for a third colonoscopy was one of our patients, one didn't have the lesion tattooed, and it was inaccurately documented on the colonoscopy report. So it was to go back, tattoo the lesion, rebiopsy the lesion, and then assist in terms of which operation we were planning to do. The second patient needed a rebiopsy, and they actually tried to do an EMR, so that's the endoscopic mucosal resection for that. And then the third patient who underwent a third colonoscopy was that we were unable to find the tattoo intraoperatively. And so what were the clinical outcomes of having that second or third colonoscopy? So we actually found that 6.5%, so 22 out of that total of 339, actually had their tumor location revised after that second or third colonoscopy. And so you can see the ones initially done by surgeons were 40.9 compared to the non-operating endoscopists, which were 59.1. But our numbers are small, so it wasn't statistically significant when we did the analysis with a p-value of 0.67. And importantly, actually 4 of our patients had a revised operation because of that revised tumor location. So as listed there, the first patient, initially we thought it was a descending colon tumor, but on rescoping, we found it was a splenic flexure. So instead of getting a high anterior section, they ended up getting a subtotal colectomy, compared to our second patient, who initially was documented as a sigmoid colon tumor, but was found to be splenic flexure. And so instead of a high anterior, underwent a splenic flexure segmental colectomy. Our third patient, instead of the sigmoid colon, was also in the splenic flexure. So instead of a high anterior section, they underwent a left hemicolectomy. And our fourth patient was, instead of the descending colon, it was actually in the splenic flexure as well. And so then instead of another high anterior section, the patient ended up having a left hemicolectomy. And I think the most important finding that we found was that there was actually quite a significant delay between the colonoscopy and when you actually had your definitive operation. So we found that from the day, if you only have one colonoscopy, from the day that you were diagnosed to the day that you had your operation was 60.3 days, compared to if you required more scopes, then it could be pushed and delayed back to about 73 days. And that was quite statistically significant. So there's a lot of results that I've just talked about, and these are the key ones. So our overall localization error rate was 6.5, which is quite similar to the current literature, which was anywhere between 4 to 20.8. And the important thing is there was no difference in the initial colonoscopy localization error rate between the surgeons, which were 5.9, and the non-operating endoscopists, which were 6.95. And thus, there was no real difference in the repeat colonoscopy rate between the surgeon, so that's 29.6, and the non-operating endoscopist, which was 26.2. And I think the reason behind that is because in Australia, we have quite a standardized accreditation board and training. And so that could probably explain why there's no discrepancy between surgeons and non-operating endoscopists. What we did find was that there was quite a lack of standardized documentation in the actual colonoscopy report in terms of how they described the tumor location between both surgeons and the non-operating endoscopists. And the key take-home point is that there is a significantly longer time to your operation with every repeat colonoscopy that's required, which is quite logical. And so our findings really highlight that localization errors can have significant adverse effects on patient care. And so we really pushed for an effort to really elucidate the differences between the localization and reporting practices during the colonoscopy at our center. And we found that accurate tumor localization and standardized guidelines for tattooing, repeat colonoscopy, and reporting of your tumor location is actually quite critical to surgical planning and ensuring appropriate surgical approaches are used for the resection. Therefore, the recommendations that we came up with after this study are quite in line with the standardized guidelines that occur throughout the current literature right now. So we recommend that we recommend routine and endoscopic tattooing for all suspicious lesions. So those are any polyps that are over 1 centimeter, any flat or sessile polyps with potential ulceration, or any incompletely resected polyps. And we recommend that it's actually tattooed in 3 or more quadrants circumferentially, 1 to 4 centimeters distal to the lesion. We're also recommending that colonoscopy reporting should really be standardized as well, and it should clarify the size of the lesion, the distance from the anal verge if relevant, so for example in your rectal cancers, and the tattoo location, as well as the technique that was used to localize the tattooing. And so we really hope that with this study, it increases awareness of the need for tattooing and comprehensive documentation in order for accurate localization of our colorectal lesions and ensuring adequate and no delay in their time to definitive management. Thank you. So these are my references. And any questions?
We can have any questions. Participants can ask their questions in the chat box, or they can just unmute themselves and ask.
Okay.
No questions. Thank you, Dr. Sharon.
No worries. Thank you for your time.
Yeah. We will move on to our next speaker, which is Dr. Naveen Kumar M from India. I am passing him the stage to deliver the speech on studying the individual role and interrelationship between mean platelet volume and platelet distribution width in predicting fall or rise of platelet count in dengue. Over to you, Dr. Naveen.
Yeah, thank you, Dr. Priyanka. Good morning, one and all. So my topic is studying the individual role and interrelationship between mean platelet volume and platelet distribution width in predicting the fall or rise in the platelet count in the dengue patients. So myself, I'm Dr. Naveen, Assistant Professor in Department of Pathology, Apollo Institute of Medical Sciences and Research, Hyderabad. So these are my co-authors, and this is my overview of my study. Coming to the introduction, dengue.
Sorry to interrupt, Dr. Naveen.
Yeah.
Sorry to interrupt. Your slides are not moving. And can you put it in the slideshow mode?
Slideshow, yeah, 1 second, ma'am.
Yeah, yeah.
I think now it is visible now.
Just a second. Can you change the slides a bit?
Can you able to see, ma'am?
Can get inside. No, I can only see the first slide.
Ma'am? Ma'am, are you able to see my slides?
No, I'm still in the first slide. Yeah, it's moving. Okay, done. No problem.
It's visible right now?
Yeah, sure.
Yes. So coming to the introduction, dengue is a mosquito-borne viral infection. It has emerged as a global disease within a short span of 30 years. So it is aided by the multifocal increase in human traffic across the continents and the oceans. So the infection was restricted to a few tropical countries a century ago, but it has spread to subtropical and the temperate regions. 2.5 billion people around the world live in the dengue endemic countries. So half of which are live in the 10 countries of the Southeast Asia region. So WHO has categorized these countries into A, B, C categories. So depending upon the variable endemicity of the dengue infection. So category A signifies the hyperendemicity, and India is fall under to this category A. According to the National Vector-Borne Disease Control Program, Government of India, a total of 1,93,245 dengue cases were reported in the country during the period of 2021 from January to September. So out of this, in 2021, 3.6% and 2022, 11.1% were from the state of Telangana. And in the Telangana, maximum of these 50% of the cases were falling under the Hyderabad city alone. So the primary infection by any of the 4 different serotypes of the dengue envelope, like 1, 2, 3, and 4 of this dengue virus, that is dengue. So some of these do not cause any symptoms in most of the people, but it is a secondary infection by the heterologous dengue serotype, which is the single most important risk factor in these categories for causing the severe disease. So this is due to a phenomenon called antibody dependent enhancement, that is ADE. It is resulting in increase in the viral burden and more severe diseases, that is dengue hemorrhagic fever and dengue shock syndrome. So among this dengue fever, whether it is a dengue hemorrhagic fever or dengue shock syndrome, thrombocytopenia is a hallmark of this dengue fever along with the leukocytopenia. So it occurs due to combined effect of decreased bone marrow production and increased peripheral destruction of the platelets. So these decreasing platelet counts have to be found a predict in the severity of the disorder. Hence, it is important to study the platelet profile and understand its course during the disease. That is mean platelet volume, MPV, which is the measure of the size of an average plate. It is a marker of the platelet production and activation. And high MPV will indicate that there is an increased megakaryocytic activity. Low MPV, mean platelet volume, will indicate a marrow suppression and increased risk of the bleeding. Similarly, PDW, platelet distribution width, which is a measure of the platelet heterogeneity. It is also act as an indirect marker for the platelet activation. So thus, this mean platelet volume and platelet distribution width will help in determining the marrow function as well as platelet activation during the disease progression in the dengue fever. So these both will act as a early predictors of the imminent fall or rise in the platelet count. So this study will help in advancing the knowledge of pathophysiology of dengue infection and its spectrum, its disorder.
Sorry, are you passing your slides? Because
so by attempting such a study, we are trying to correlate the changes in platelet indices.
Naveen, sorry to interrupt, Dr. Naveen. We are not able to see your slides. We are still stuck in this slide number 3.
No, ma'am. 1 second. I'll open again.
Yeah. If you could please stop sharing and again start sharing.
Yeah, ma'am, can you see my 4th or 5th slide?
Yes, I can see. Put it in the slideshow mode.
Yeah, ma'am.
Yeah, now it is, yeah. Okay, put it on the slideshow mode.
Yeah, it's okay, ma'am?
Yes, yes. You are on the slide number 8, right?
Yes, ma'am.
Yeah, you can see that.
Can you see, ma'am? Like I'm moving my slides.
It's still not on slideshow mode, but that's okay. But we can see at least the slide number 8. Can we move to slide number 9?
Yes, ma'am. Can you see, ma'am?
No, I'm still at slide number 8.
Now, ma'am?
No, still it is on slide number 8.
Shared in like slide share more only, ma'am. To see now, ma'am.
Yes, now it is done. Yeah.
Thank you.
Yeah, aims and objectives.
Yes.
No, please.
Yes. Thank you.
Yeah. Continue, please. Sorry to interrupt.
So both this MPV and PDW will help in determining the marrow function as well as the platelet activation during the disease progression. So this study will help in the advancing the knowledge of pathophysiology of dengue infection and its spectrum of a disorder. So by attempting such a study, we are trying to correlate the changes in platelet indices with the variation of the platelet count. So it is a direct correlation between the platelet distribution width and the mean platelet volume will help in planning the better treatment and save the patient by governing them towards a better prognosis. So simultaneously, it would help in forbid unnecessary platelet transfusion, that is RDW and SDP, which will bleed them financially and prevent the wastage of resources. Coming to the brief about the review of literature, dengue virus causes a wide spectrum of diseases ranging from subclinical to severe flu-like diseases. So geographical distribution of the disease are significantly augmenting with a large number of cases remaining undiagnosed or underreported. Most of the cases tend to come to the physician in a later stages of the disease only if the patient will consult the doctor only when the symptoms begin to worsen. So platelet count have no role in determining the need for transfusion in dengue because whenever we will transfuse, so these platelets will act, is going to destroy by the antibodies of own patient platelets. So hence platelet transfusion have a limited role in management of the dengue. So consistent monitoring of the mean platelet volume patients and PDW value would help in early detection of the complications, and it will help in undertaking precautionary measures to prevent further deterioration of the patient. So the mean platelet value and the platelet crit has a positive correlation with a low platelet count, and low mean platelet volume and low platelet count will imply a marrow suppression, and this is a mechanism of the thrombocytopenia. So whereas the platelet distribution width will have a negative correlation with the platelet count. So high values of this platelet distribution width is seen in patients with the low platelet count. So high mean platelet volume, high MPV, high PDW, low platelet crit is going to commonly seen in the patients where in the ICU setup, longer duration of the therapy where they are required. So other cases like low platelet count, low PCT, low MPV, and high PDW will act as a predictors in determining the severity of dengue infection. So provision insight on the relationship between these platelet indices, that is MPV, PDW, and platelet crit, and the platelet count of the dengue patient would aid in early recognition of the danger signs and symptoms, and this will act as a early prediction of the outcome, which will further direct to the approach in the better aim of the therapy. So coming to the aims and objective, the current study focuses on the role of mean platelet volume and platelet distribution width in determining the course of the disease and in predicting its dreaded complications. So early detection of this dengue hemorrhagic fever, dengue shock syndrome would greatly help in better patient management and treating away from the direct consequences. So to study the correlationship, if any, between this MPV and PDW and platelet count in dengue, NS1 positive cases forms the main objective of this study. So the aim of the study is to arrive at a critical value for mean platelet volume and platelet distribution width, which can confidently predict the severe thrombocytopenia in the dengue fever. So materials and methods, this project was done along the lines of an observation study. So this was conducted for a period of for 1.5 years. That is 2020 to 21 in the pathology laboratory of Apollo Institute of Medical Sciences and Research, Hyderabad. It is a teaching hospital. So the current report we describe into cross-sectional study. So here we use it like statistical methods like mean, standard deviation, percentage will be calculated between the variables, and the correlation coefficient will be calculated between the MPV, PDW, and the platelet count. So the inclusion criteria, all seropositive cases of the dengue, that is already, which is diagnosed cases only, that is NS1, IgG or IgM in all the age groups. Exclusion criteria, thrombocytopenia resulting from causes other than dengue, that is seronegative, we are not included in the study. So coming to the materials and methods, the patient's blood sample will be collected in a irradiated tube, and the patient indices will be obtained by using a fully automated 5-watt analyzer. Here we are using the Mindray 5300. So right from the day of admission to the day of the discharge, the patient platelet indices, that is mean platelet volume, platelet distribution width, and platelet count will be monitored. All data will be generated and it will be documented in a Microsoft Excel sheet. So statistical analysis were performed using SPSS version 24. In the descriptive statistics, already I described, mean standard deviation percentage were calculated. So my observation and the results. Here in this study, 300 patients were enrolled and investigations, which is admitted in our AMSR Hyderabad hospital. Out of this, 180 patients were males and 120 patients were the females. So among this category, like in 20 years, we're following 54 patients, 20 to 30, 42 patients, and 34 to 60, 66 patients, and 40 to 50, 54 patients, and so on. So the mean average age of the age group in my study group is the 37.2 plus or minus 8.1 years. So maximum of the patients were males, and the maximum number of the patients were admitted during the monsoon season of the year. Fever, headache, generalized body pains were the chief complaints most of the patients presented here. Bleeding manifestations like epistaxis and melena were not so common. Only in 14 cases we have seen this condition. So out of 300 patients, predominantly 282 patients were having the fever, 210 patients with myalgia, and only in the 16 patients we were seeing the skin rash, the petechiae, and the breathlessness. So most of the patients, like out of 100%, 88 patients were admitted for a week or less than a week. But 12% of the patients where they required admission for more than 10 days. So in the latter group, that is the patients who admitted for more than like 1 week, the average platelet count was less than 19,000. So in these cases, the patients were experiencing a low or high MPV, low or high PDW during their hospital duration from day 1 to the day 10. So a negative correlation coefficient was observed between this platelet count and the MPV during the course of their hospital stay. Similarly, this negative correlation coefficient was observed between the platelet count and the PDW value simultaneously, apart from MPV, from the date of admission with the minimum platelet count. So this was my correlation on average, like significant value is 0.05 at the level. So, and the correlation of significant was 0.01 at the level 2 tail. So out of the day, like in the 1 week duration, so the platelet mean platelet MPV value in the dengue fever on day 1 was 7.42 femtoliters, and till day 5 it was 11.9 femtoliters. So the p-value was 0.04, indicating a statistical significance difference between these serial values in the hospital stay from day 1 to the day 5. Simultaneously, this PDW value in patients with dengue fever from day 1 to the day 5, there was slight increase starting with the 12.20% to the 17.60%. Coming, this was correlating again, the p-value of 0.05, statistically significant difference was noted. But particularly in the platelet count, day 1 was 95,000, but day 5 was 89,000. So p-value was only 0.01. So it was statistically no significant difference was noted. So it's clear cut indicating that MPV and PDW is going to, statistically it is going to signify, which is showing 0.04 and 0.05. So we can't take into consideration only the platelet count in the dengue fever as a critical value. Always we are going to correlate between the PDW and the MPV. So the mean MPV and the PDW was corresponding with the days with the minimal platelet count was, the MPV was 8.8 and PDW was 16.4. But the mean MPV in the platelet value just before the platelet count is going to begin fall. So that time the MPV was 11.9 and the PDW was 17.91. So significantly it is showing there is a lot of variation in the MPV and PDW before falling in the platelet count. So these MPV and PDW, we can consider as a critical value or value of concern, behind which there is a high chances of decrease in the platelet count. So this was my mean MPV, like 8.85, and the platelet count was 84, so 16.4. But if you see the platelet count was 56, the median was 16.7, the PDW. So among the discussion, dengue is one of the most common infectious disease prevailing in India. In spite of the fact that in India, dengue was first reported in 1940. But the first case of confirmed dengue infection from Kerala was recorded in 1997. Since 2001, the occurrence of this dengue is increasing widely in Kerala, and outbreaks were reported repeatedly from most of the central and southern districts of India. So dengue has become a matter of serious concern with the current increasing trends in number of the cases. So severity of these cases increases with a relationship between decrease in the platelet count. So initially, there will be a decrease in the platelet count in relation with the increase in the mean platelet volume and platelet distribution, which will indicating a compensatory increase in the bone marrow activity. So further, whenever there is a decrease in the platelet count in relation with the decrease in the MPV, so it is indicating that the marrow suppression and inefficacious compensatory mechanism which is favoring for fall in the MPV. So this timely prediction of decrease in platelet count with careful observation in the trending of MPV and PDW value from the day of admission to the day of discharge will help a physician in taking the prompt decision regarding the further plan of action in the treatment and in the prognosis. So this study in accordance with a study with others like age group, particularly like gender. So in our study, there was predominantly males was there, 60% of it. It was correlated with the Anchor M and et al. So there also the predominance of males was noted. In the study with Kannan and et al. So he noted that again, there was again 35 males and 20 females. And other symptoms like in our study also, there was a most of the important symptom that is a headache was noted. And study with Silak and D et al. So here they also found that the age group predominantly 20 to 39 years, and our study was correlating with their study. And Afsar N et al. He also reported that 86.7% of the cases belong under 30 years of the age group. Our study was correlated with this Afsar N et al. And the study was conducted in the large urban epidemics of the Kollam city of Kerala, Daniel et al. So the clinical features was fever, the most important feature. But in our study also, out of 300 patients, 282 patients, the significant history was a fever was there. And again, male predominancy was noted. And a study by Singh et al., he found that fever was presented in all the cases. So our study was also correlating with him. And the most important feature, again, headache 61.6%. The headache complaint was there. Our study was correlating with him. Manish et al. In their study, 7% of the cases were noted with the dengue fever with moderate and severe thrombocytopenia. And in that, 3 cases which required fall in the platelet count significantly for the progress duration. So he noted a relation between the clinical improvement and deterioration of this dengue fever with their platelet count and the indices, which was less than p-value was less than 0.05, which was correlating with our study. And study by Nabila et al., he observed that mean platelet volume found to be a significant higher in the dengue cases when compared to the controls. Here, he noted that mean platelet volume should be a significantly higher in patients with the platelet count below normal biological reference range that is less than 1.5 lakhs when compared to the dengue patients with normal platelet count. So he also concluded that high mean platelet volume indices, that's a platelet activation, it can be used as an initial marker to suspect the dengue fever in any case of the thrombocytopenia. A study by C. Miracle et al., he found that the platelet count in the dengue hemorrhagic fever and dengue fever showed a significant decrease from 4th day of illness. So in his study, he also observed that in the adults with this without shock, in the platelet count was initially, there was a mild to moderate decrease on 3rd day, followed by 7th day of illness and reached to normal on the 8th or 9th day post-dengue fever. A study by Manorama et al., he noted that again MP was significantly found high in patients with the bleeding manifestations, which was correlating with our study. Afshar et al., he also noted that there was a significant p-value in the study of the mean platelet volume with the concurrent with the present study. So he told that increased platelet volume, increased platelet addition, platelet aggregation, and synthesis of thromboxanes, which will lead to the complications like DIC, disseminated intravascular coagulation. So present study was correlating with the Nehara HR et al., which was found to be a significant positive correlation, p-value less than 0.01. So since the bone marrow activity and peripheral destruction of the cells also will play a major role in the pathogenesis of platelet count and any other diagnosis and form the topics of interest for the future studies. So conclusion, fever and myalgia, most common symptom observed in our study. So there was a decrease in the platelet count with MPV and platelet distribution, which was gradually increasing in the beginning of the days from day 1 to day 3. Later, it was fall in the MPV and PDW values. So thus, it is indicating a negative correlation between the both platelet count, mean platelet volume, platelet count, and the platelet distribution width. So preliminary identification of these alteration in the increase or decrease in this platelet indices will help in early assemble of any need of the resources, or we can prevent any dreadful complications. So a combination of clinical symptoms and hematological investigations like platelet count and indices, platelet mean platelet volume, platelet distribution within platelet will help in establishing a diagnostic algorithm which can be used to distinguish the dengue patients with the poor prognosis. So this is a summary of my study, which was conducted for 1.5 years. 100 cases was noted, 180 males and 120 females. Again, predominantly was less than 30 years of the age group was noted. The most of the important symptom was fever was noted, followed by the headache, vomiting, and only in 16 patients we have seen petechiae and the skin rashes. So 88 patients were admitted for less than 1 week. Only 12% of the cases were admitted for 8 to 10 days in the hospital stay. In that later group, where patients were 10 days, in that the platelet count was 19,000, where we are noted little bit of alteration in the MPV and PDW value. So these are my references. Thank you.
Okay, Dr. Naveen. Multiple participants can unmute themselves and we can ask questions if there is any. Okay, thank you, Dr. Naveen. We'll move on to our next speaker. Our next speaker is Dr. Sen from Turkey. I'm passing him the stage to deliver a speech on intestinal metaplasia and Helicobacter pylori rates in sleeve gastrectomy material. Sorry.
Hi, Campbell.
Yeah. Please share your presentation.
I'm sorry, 1 minute, please.
Sure, sure.
Melis, çabuk gel Melis. Çabuk gel, çabuk diyorum sana, çabuk. Basıyorum, buradan nasıl bulacağım?
Neyi?
Bulsana şeyi.
Ne istiyorsun?
Dosyayı.
Dosyayı açmamışsın. Açtın mı sen dosyayı?
Yok. Önce dosyayı mı açacağım?
Evet, tabii ki de. Onu açmazsan oradan bağlanamazsın.
Ama şunu. Buradan mı aç?
Aç işte dosyayı aç. Aç.
Burayı nasıl açacağım tekrar?
Zoom'a gir.
Hı? Giremiyorum.
Ekran dondur.
Hı?
Dosyayı önce açacaksın. Dosya açıldı.
Açtım. Tamam.
Tamam.
Şimdi girebilir
Zoom'a
miyim?
gir.
Tamam.
Zoom'a gir.
Giremiyorum.
Oradan geçebiliyorsun.
Hı. I am sorry. Can you see me? Can you hear me?
Yes, sir. Yes, I can show you.
Yes.
And the screen is also visible. Can you put it on slideshow mode?
I am very, very sorry to welcome to Istanbul. My name is Altekin. I am making this presentation from Turkey. I live in Istanbul and I am working in the Department of Pathology at Istanbul Demiroğlu Bilim University. As a matter of fact, while planning this presentation, my aim was to investigate the extent which sleeve gastrectomies are accompanied by intestinal metaplasia and Helicobacter pylori. However, while browsing the literature, I saw that the debate is more about whether these materials. Actually, this was pretty surprising approach because how can it be ensured that there is no malignancy in the local sample taken in the endoscopy you perform before the operation on a stomach you have remembered for sleeve operation, and that will not appear in the operation materials. In this case, we decide to evaluate the results we obtained from the cases we studied at the end of the study in this context. Sleeve gastrectomies, which are part of bariatric surgical applications, which are one of the methods used for the solution of the obesity problem, are widely used in the health center in many parts of the world. And these patients are, in addition to getting rid of obesity problems, they can also learn about existing or possible stomach pathologies that, thanks to stomach materials examined. Numerous studies have been conducted on this subject before, and generally similar conclusions have been reached. The most common of these surgical interventions is sleeve gastrectomy, and it is widely used in our hospital as well as over the world. A fairly simple surgical application, the gastric sleeve can be applied minutes by an experienced surgeon. After sleeve gastrectomy application, since remaining stomach in the patient takes the form of a tube, this operation is also referred to as tube stomach operation. Microscopy of stomach, which researches pathology after sleeve operation. Rate of gastric intestinal metaplasia detection in the general population. It was generally determined as 11.7%. Helicobacter pylori infection is seen all over the world. Together in different population groups in the same country has different proportions. Approximate of the world's populations, and 60% are infected with this bacterium. This microbe, 100% of those who carry is developed gastritis, they are lifelong. The risk of having peptic ulcer is 50 to 20%. Getting stomach cancer, the risk is 1 to 3%. The World Health Organization has identified Helicobacter pylori as a declared as a number one carcinogenic factors. What is the situation like in sleeve materials? Dr. Cheng et al. Examined 753 sleeve materials and found that the rate of Helicobacter pylori was 6.4% and the rate of intestinal metaplasia was 2.7%. And Dr. Sabah et al. In the sleeve gastrectomy series, 481 cases in 2020, they found the rate of Helicobacter pylori to be 35.34% and rate of intestinal metaplasia to be 1.66%. And they draw attention to the need for postoperative pathologic evaluation sleeve materials. Different to Dr. Abdul Ghaffar et al., they evaluated 546 sleeve gastrectomy materials and concluded that postoperative pathologic examination of these materials was not necessary upon the detection of less than 1% of random benign lesions and the observation of malignancy. However, in this study, there is no information on the presence of intestinal metaplasia and Helicobacter pylori. Dr. Safan and his friends, they evaluated sleeve materials from a 3-year series of 1,555 cases and found that the rate of Helicobacter pylori was very low in 52% of the case and found the normal histologic appearance, 33% chronic inactive gastritis, 6.8% chronic active gastritis, and 2.7% follicular gastritis. At the end of these, the recommended pathological examination of samples of patients with preoperative clinical symptoms. An important supportive study also draws attention to regional differences. In another study conducted by Dr. Utilitarian for Saudi Arabia, when 602 sleeve cases were evaluated, the rate of Helicobacter pylori was as high as 22.3% and intestinal metaplasia was found to be 1%. And the presence of polyps was observed in 3 cases, with the results postoperative evaluation of sleeve materials has been proposed for Saudi Arabia. Our work, the surgical materials of 72 patients who were admitted to our hospital with obesity compliance for 2 years and underwent sleeve gastrectomy were examined. 48 of our patients were female and 24 were male. Age distribution, it was 11 to 51 in women and 18 to 52 in men. The average age was calculated as 33.9 years for the woman and 26.7 years for men. The criteria we take into account in microscopy when evaluating all cases: activation, the presence of chronic inflammation, the presence of Helicobacter pylori, the presence of intestinal metaplasia, the presence of dysplasia, and other finds. Evaluation, activation, chronic inflammation, and dysplasia be classified as mild to moderate and the strong. We use numerological parameters ranging from 1 positive to 4 positive for Helicobacter pylori evaluation. Intestinal metaplasia was evaluated with focal or diffuse and complete or incomplete and incomplete. Sample evaluation, activation mild, chronic inflammation moderate, Helicobacter pylori ++, intestinal metaplasia, focal and incomplete type, dysplasia not detected, other proton pump inhibitor effect by PPI, structure of the lymphoid follicle. Example of our case, the presence of Helicobacter pylori indicated by the tip arrow, the presence of another Helicobacter pylori closure plan, the presence of Helicobacter pylori in another case, the observed focal and complete intestinal metaplasia, another case in which we observed diffuse, complete, and incomplete intestinal metaplasia. In another sleeve materials case, reactive lymphoid follicle structure, Helicobacter was present in this case and expected. The results of our study, sleeve gastrectomy materials belonging to 72 operated cases due to obesity were evaluated. Activation, which we based on the presence of neutrophils in our cases, was evaluated as mild in 68% of cases and moderate in 24% and strong in 8% of cases. The rate of lymphoplasmocytic cell increase, which we took into account in the presence of chronic inflammation, was found to be in parallel with the values of activation. It was evaluated as mild in 72% of the cases, moderate in 23%, and strong in 5%. Helicobacter pylori results, we observed the presence of Helicobacter pylori at different rates in 20 of our 72 cases. 14 of our sleeve materials cases with Helicobacter pylori positive, and 1 positive and 70%, and 2 positive 20%, and 3 and 4 positive and 10%. The consequences of Helicobacter pylori, it seems consistent with the conclusions of Sabah et al. Intestinal metaplasia results, we observed intestinal metaplasia in only 2 of the 72 cases we evaluated. Intestinal metaplasia was focal and complete type in 1 of these cases, diffuse and complete and incomplete type in the other. The presence of Helicobacter pylori was observed in both cases in which we detected intestinal metaplasia. In these results, it seems to be close to the results of similar research conducted by Aletian and his friends in Saudi Arabia. Other results, we did not observe dysplasia in any of the sleeve gastrectomy materials we examined. Reactive lymphoid follicle structure was observed in 15 of the cases, and all of them were accompanied by the presence of Helicobacter pylori. This situation is similar to the results of endoscopic biopsy. In 5 of cases, we observed the effect PPI and on the epithelium lining the gastric knot structures. Sleeve gastrectomies used for the treatment of obesity are increasing more and more every day, along with and in parallel with the effect of obesity. Evaluation of all kinds of surgical materials by pathology after the operation is important for the future health of patients. In our study, the fact that we did not encounter dysplasia and that our intestinal metaplasia rate was not too high are important results. However, it should be remembered that we do not have clear information about who has prevalent change, when and in what way they will come out. Life is not a gamble to be risked. For this reason, we advocate the need to send sleeve gastrectomy materials to the pathology, as well as every material should be sent to pathology after the operation. Thank you so much for patience.
Thank you, Dr. Aptekin.
Thank you.
If there are any questions, participants can ask questions. Is there any? I guess there are no questions. Thank you, Dr. Aptekin. We will move on. Our next poster presenter is Dr. Sharon Shinley, again from Australia. I am passing her the stage to deliver the poster on a multi-center review of the impact of COVID-19 on colorectal cancer. Over to you, Dr. Sharon.
Thank you. I'll just quickly share my screen.
Yes.
Is this projecting well enough, or is it too small?
Yes. Yes. No, that's okay. I mean, you can see
That's
it.
okay. Okay, great.
Yeah.
So I think everyone still remembers the effects that COVID had on their respective countries. In Australia, especially in Melbourne, we were hit quite hard in terms of our lockdowns. So in total, in Melbourne, we had 6 periods of where the entire metropolitan area went into lockdown. Which meant that in total, we had one of the largest numbers of days in lockdowns globally, and we had a total of 267 days. In addition to that, at the very start of COVID, our Victorian healthcare service was very concerned about how our healthcare system would very quickly become overwhelmed. And so thus there was Department of Health and Human Services directive where they actually stopped all non-urgent surgery. And unfortunately, they included things like endoscopies as part of a non-urgent operation. And so for us in the colorectal field, we were very concerned about the delay in presentation because of the lockdowns and people not accessing healthcare for fears of catching COVID. The delays in the referrals, because if they're presenting to their GP later, then they're getting referred to us much later as well. The delay to their investigations, because everything went into emergency mode, in that only emergency imaging, emergency colonoscopies, things like that were able to be performed. And ultimately, any potential delays to their definitive operation for all of our colorectal cancer patients. And we were not alone in that. Globally, there were a lot of health centers that were putting out massive amounts of data and research, reporting that there was not only an increase in the cancer stage migration at the time that they were diagnosed, but as well as the rates of incurable disease because of that. And in addition to that, because patients were often presenting at a much later stage and a much more complicated stage. So for example, they were presenting as emergency cases. So they were presenting as large bowel obstructions from an obstructing cancer. So then they had higher rates of complications such as perforations and/or obstructions. And so what did we do? So we partnered with the 6 major colorectal centres in Melbourne. So that's Northern Health, Austin Health, St. Vincent's, Monash, Eastern and Alfred. And we formed what we call the Melbourne Colorectal Collaboration. And we did a multi-centre review looking at the impact that COVID-19, the logistics of the lockdowns and things like that on our colorectal cancer patients in Melbourne, Australia. And so this was 6 units. It was a retrospective study from a prospectively collected database. So that's the Binational Colorectal Cancer Audit Registry that I spoke about previously, our national registry, as well as inpatient records. So that's things like multidisciplinary meetings, any emergency presentations, GP referrals, colonoscopy dates, all of those sort of things we also collected. Like I said before, it was across 6 different sites, and we differentiated the 2 groups of patients based on the date of presentation or the date of diagnosis. So we had the pre-COVID-19 period, which was from the 1st of July 2018 to the 30th of June 2019, and then the peak COVID-19 period, which was from the 1st of July 2020 to the 30th of June 2021, and we compared the data between those 2. And we excluded any patients that had benign pathology or any other cancer types that had metastasis, that had colorectal mets. So the patients had to be a colorectal primary in order to be included. So in total, we recruited 1,609 patients. In the pre-COVID period, we had 700 patients, and in the COVID-19 period, we had 906. If you look at the results, the middle results column, it'll just show you the sort of patient demographics that we had. So they were quite similar between the 2 in terms of, for example, 58.3, around the 50s mark, % were male, and the mean age at diagnosis was pretty similar, sitting at 67 years of age. And there wasn't really a difference between the 2 time periods in terms of the type of cancer that presented, so whether it was colon or if it was a rectal cancer. So what we found was that if you look at the tumor stage that's listed there, that is the tumor stage at the time of presentation. So as you can see that a lot of our patients, unfortunately in the COVID-19 period, were presenting with higher nodal and higher and quite advanced metastatic staging at the time of presentation. So for example, in the COVID-19 period, there was 56.3% compared to the 63.4, the 27.8% with N1 disease compared to 23.3, and the around 16% compared to 13 of N2 disease. And those p-values are listed there for you to have a look, as well as metastatic staging as well. There was quite a bit of a statistical difference there. But in saying that, the curability of the cancers, of the colorectal cancer patients that were presenting, didn't really have a statistical difference. Neither did the use of neoadjuvant therapy. What we did find as well was that there was no real time difference between the initial referral to the colorectal unit and then from that time point to when they got their investigation or when they got their surgery, between the 2 time periods. And that was a really interesting data point for us, because it really showed that despite all of the logistic restrictions and limitations with lockdown that were placed on us, we still were able to effectively work up and manage our colorectal cancer patients as soon as they were referred to us. And there was no difference between the pre-COVID-19 and the COVID-19 period. And our research also shows that there was no real difference in any post-operative surgical complications, despite the fact that they were presenting at later stages and a lot more patients required emergency surgery rather than elective. So if you can see there in the last column for results, for example, 28.1% of patients in the compared to 19.8% of patients actually were emergency patients. So they were the ones that presented to the emergency department with complications of their colorectal cancer, so with a p-value of less than 0.01. So I guess there's a lot of numbers there, and feel free to crunch through the numbers and have a look on your own. I think that's the purpose behind the poster. But what the important things I wanted to point out with our results was that we, interestingly enough, had less inpatient deaths in our COVID-19 period compared to our pre-COVID-19 period. And we had fewer 30-day admissions in our COVID-19 period compared to our pre-COVID-19 period. And what we're hypothesizing is that during those time periods where we had all of this reallocation of hospital resources to the emergency setting meant that there were better staff to patient ratios, which may have actually contributed to these reductions that we see in inpatient deaths and 30-day readmissions. And what we're really proud of in Victoria is that we implemented the use of telehealth medicine quite quickly at the start of the COVID period. And we think that really had an effect in preventing that time delay that quite a few of the other countries across the globe were reporting in their data sets. So the other thing that I wanted to point out was that there was no real difference in the length of hospital stay for our COVID-19 and our pre-COVID-19 patients. And that's probably also related to that reallocation of hospital resources and potentially patients getting better care because of the higher staff to patient ratios. Are there any particular questions?
Dr. Sharon, was indeed a very nice poster. If there is any questions from participants. Okay, I don't think so there are any questions. Thank you, Dr.
No.
Sharon.
Thank you.
Yeah. We'll move on to our next speaker. It is Dr. Mohammed Shoaib Zaidi from Saudi Arabia. I'm passing him the stage to deliver the speech on diabetes technology or human factor. Over to you, Dr. Mohammed. Dr. Mohammed. Yeah, okay. Dr. Mohammed is not there. We will move on to our next speaker, which is Dr. Heba Raghav from Egypt. I am passing the stage to deliver the speech on enteral and parenteral nutrition. Over to you, Dr. Heba. I think Dr. Heba is there in the participants list, but then please unmute yourself, Dr. Heba. Dr. Heba, can you please unmute yourself? You're the next speaker. Heba, we can see you. Kindly unmute yourself. You will have to unmute yourself so that we can hear you. If the capable region, we'll wait for 5 minutes further. Dr. Heba, yes, we can see you. Only unmute yourself. We are not able to hear you, Dr. Heba. Yes, you have unmuted yourself. Yes, I am not able to hear you. Just try and connect with your audio. Check the audio settings, please.
Dr. Heba, can you use your earphones?
Sorry for the disruption.
No problem. You are audible and visible both now, Dr. Heba. Can you share your screen?
Okay.
I think there are some technical issues with Dr. Heba. We will take a small break, 15 minutes. Okay, we will resume after 15 minutes. Thank you so much.
Good morning.
Yeah, it was working. Can we do it in 5 to 10 minutes once the coffee break is done? Your voice
Okay.
and your presentation is working fine.
Okay, I'll start now or after 5 to 10 minutes?
Yes, please, after 5 to 10 minutes.
Okay, thank you.
Okay, thank you.
Hello? Hello?
Hello, who's this? Are you Dr. Mohammed Shoaib Zaidi?
Hello?
Hello, this is Dr.
Hello?
Mohammed.
Yes, yes, yes. I'm
Yeah,
having difficulty
okay.
in
So we are
sharing the
having
screen.
okay. No, Dr. Mohammed, actually, we are having a 10 minutes break, coffee break. So we will resume post that. So should we start with you first and then Dr. Heba? Okay. So you be
Because
there online, all right?
sorry, the scheduled time was 9:30. That's why I was here.
Yeah.
Yeah. Okay.
Yeah, no
Okay.
issues,
Okay.
Dr. Mohammed.
No problem. No
Start,
problem.
okay, we'll
Thank
start in 5 minutes. Be there online and be ready with your
But
presentation.
how
We'll
can I
start
share
with
the
you
screen? It is
first,
not showing the
followed by
option.
Dr. Heba.
Okay.
No,
Thank
actually,
you.
the host will start the Zoom meeting again.
Okay.
Then
Thank
that
you.
time you will be able to share the screen.
So
Okay?
kind of
Yeah.
you. So kind. Thank you.
Yeah. Thank you. Good morning, everyone. Again, we went for a short coffee break. Now we will start with our speakers. Again, the presentation. Our next speaker is Dr. Muhammad Shoaib Zaidi from Saudi Arabia. I am passing him the stage to deliver the speech on diabetes technology or human factor. Over to you, Dr. Muhammad.
Thank you. Good morning. I just want to see how can I share my screen. Sorry, should I use the option of PowerPoint as virtual background?
No, you just need to click on that green button that is a share screen, and then you can share your screen.
Because it is not coming, the option is, there are multiple options coming there. Like there is PowerPoint as a virtual background, a portion of screen, computer, video.
No, you just have to click on the share screen button, and then you can open your PowerPoint.
I already clicked, but my
okay.
I'm not going to the desktop. I'm unable to go to my desktop to see my presentation.
So you cannot see the screen on the, I mean, there's a screen on which the select a window or an application that you can want to share. So on that, you cannot see your desktop.
Yes.
Or your PowerPoint presentation.
It is giving me options like screen, whiteboard.
Yeah, yes, that is right. That is right. They're sharing it for you.
But
okay. So you can just, this is your screen, right?
No, this is actually
minimize the window.
No, this is not the, this is my email.
You just minimize the window. You just minimize the window.
Okay.
Now you can minimize the window and go to your desktop.
Okay.
Is it possible now?
Yes. Okay.
Yeah. Yeah. We can see your screen. Put it on a slideshow mode, please.
Dr. Zaidi, we have shared your screen. You can just let us know. You can guide us by saying next.
Okay. Are you able to see my screen?
Yes, we can see your screen.
Sorry for the delay.
Actually, I'm so sorry for interrupting in between. We have shared your screen, so you have to guide us by saying next.
Okay.
Yeah.
So my topic for the presentation is diabetes or human factor. Actually, this is a case presentation. I'm Dr. Shoaib from University Diabetes Center in Saudi University, Riyadh, Saudi Arabia. So first of all, I would like to start with the verse from Holy Quran and discussing our patient who was an elderly lady. So the God Almighty has created you, then takes you back, and among you there is one who is carried to the worst part of the age, so that he knows nothing after. Sorry, actually it is coming on. So that he knows nothing after having knowledge. Surely Allah is all-knowing, all-powerful. And below, this is the very famous verses from the Shakespeare's Seven Ages of Man. And in the end, he says that the sixth age shifts into the lean and slippered pantaloon with spectacles on nose and pouch on side, his youthful hose well served, a world too wide for his shrunk shank and his big manly voice, turning again toward childish treble pipes, and whistles in his sound, last scene of all, that ends this strange eventful history, is second childishness and mere oblivion. Sans teeth, sans eye. Okay, so I have no conflicts of interest. Our case was an 82-year-old Pakistani lady who was bedbound and had multiple comorbids like Alzheimer's, type 2 diabetes going on for more than 30 years, hypertension, dyslipidemia, severe osteoporosis. She had a fall in the past and with a fracture of right femur. That was 4 years ago, and also had vitamin D deficiency. So it was in March 2021 that I was contacted by the patient's son, and he was actually, he's also a physician, and he was worried about his mother, who was having an HbA1c of 13%. She was not on any self-monitoring of blood glucose, and along with the hyperglycemia, she was also having postprandial hypoglycemia and considerable weight gain during the last 4 years. The patient was taking insulin glargine, regular insulin, DPP-4 inhibitor, an SGLT2 inhibitor, along with the ARB, aspirin, and statin, and memantine for Alzheimer's, calcium, and vitamin D, and she was intolerant to metformin. So in December 2021, the patient was put on intermittent flash glucose monitoring, that is Libri, and her regular insulin was changed to insulin aspart, that is ultra short acting. And the patient's son and the family flash monitoring. So by mid-January 2022, the patient was also started on GLP-1 analog, that's liraglutide weekly. And we'll see in the next few slides what was her ambulatory glucose profile. But this is actually the comparative AGPs between when she was not on Libri and liraglutide, that was in December, and this is compared to the one which we got in January and to February 2022. So as you can appreciate that initially she had a time in range that was 11%, just 11%, and that got reduced to 92%. And time above range in December 2021 was 40%, and that was just reduced to 1%. And she was not having any hypoglycemia at that time, and her GMI, glucose management indicator, was 6%. So after that, the patient started developing frequent hypoglycemic episodes that were associated with hyperglycemia also. So she was having high glucose variability. And so her insulin had to be discontinued altogether, both the short-acting, ultra short-acting, and the long-acting in September and October 2020. And afterwards, as we'll see in the next slide, that the patient achieved a euglycemic state without having any hypoglycemia or hyperglycemia in November, December 2020. This slide is indicating 1 year data, as we discussed earlier on. On the left upper part, just concentrate on the left upper part, you can see that with the green zone, it is showing the time in range, and that was so very low. And that got improved in a couple of months to 91%. From just 11%, and then gradually it started decreasing again. That that is in September 2022, the patient was having hyperglycemia associated with hypoglycemia, and her time in range was 74%, and time in the hypoglycemia less than 54 was, or between 54 to 70 was 20%. Then if you go down to the left lower part, you can see that after still in October to November, she was having these hypo and hyperglycemic episodes. And then after stopping insulin, you can see on the right lower part that her sugars got under control. There was no hypoglycemic episode, and her last time in range got improved to 78%. The middle figure in the lower part of the slide is showing the normal, what should be the normal in an elderly as recommended by the American Diabetic Association and other authorities. As you can see that it is the time in range should be more than 50%, and time above range more than 180 should be less than 50%. And this is the another representation of the patient's glucose profile through a graph, and you can see in with the time in range is indicated by this purple bar, and you can very well appreciate that in December, this is the time in range, and gradually it got improved. Then again, it started going down associated with hypoglycemic episodes, and the hypoglycemic episodes are indicated by light blue. So, but this is the last AGP showing very reasonable time in range, and there were no hypoglycemic episodes. So this is the, now we come to the discussion of this case, and we can see that according to the American Diabetic Association, they in the 2023 also and before also, they have classified 3 categories of people with old age. And on the top, if the patient is healthy and having a long life expectancy, that they recommend that the HbA1c should be less than 7%, and the fasting should be 80 to 130, and the before sleep, the blood glucose should be 80 to 180. And if the patient has got multiple comorbids, so it is he or she has got a complex disease or intermediate, or having 2 or more instrumental ADL impairments, then he or she has intermediate remaining life expectancy of less than 8%. And on the lower part, you can see that the patient has got a very complex poor health. Then the patient has a limited life expectancy. So they recommend to avoid both hyper and hyperglycemia. And our patient, most probably she was in the middle part. So the next slide also is showing the different values which have been recommended. These are the AGP values according to the international consensus. And the top left part, you can see that for old age people, it is time in range recommended more than 50%, and time below range less than 70 should be less than 1%. And the lower diagram is the same as we discussed earlier. So this is a slide showing one of the study that was published in the Journal of Diabetes and its Complications in 2018. And it showed that the hypoglycemic episodes were occurring in a sizable portion of these patients. There were a total of 989 patients, and the hypoglycemic episodes were occurring 28 to 65%. And they concluded that the CGM picks up asymptomatic hypoglycemic episodes in older patients. And the same goes for our patient also. Actually, she had dementia, and she was not complaining of any hyperglycemic episodes. Maybe she had this autonomic neuropathy, that was causing these asymptomatic episodes, leading to the hypoglycemia. And through this study, it also mentioned that the CGM not only improves or detects the asymptomatic hypoglycemia, but it's also improved the well-being and the diabetes-related stress of the patient. So the next study is also from BMJ Open Journal, and it is showing the what is the advantage of CGM in people who have memory issues like dementia. So they one of the key point in this study was that the device did not interfere with the patient's daily activities and their usability and comfort. And so in the conclusion, they recommended that the real-time devices with automated data transfer may be more suitable older people with memory problems. And this is a very famous study. It's called the Diamond Trial that was published in Journal of Diabetes, Science and Technology in 2017. And it was done on people with type 1 diabetes and people with type 2 diabetes with multiple daily insulin injections. So our patient was initially on just basal insulin, but most of the data that's available in the literature, it has been done on people with type 1 diabetes with CGM, using CGM. But those who with type 2 diabetes, in this study, they have discussed about the type 2 diabetes patients also. And you can see on the left side of the figure that this is the, on the x-axis, this is the baseline HbA1c, and on the y-axis is the HbA1c after 24 weeks of CGM. And you can see that this is actually the scatter plot, and the dots or the cross which you can see below the diagonal line, they indicate that the HbA1c was well controlled, and this horizontal line is actually the American Diabetes Association recommendation, 7% of HbA1c. So all the blood glucose levels that are below the diagonal line, they are under control, and above that there are not good control. So, and in the lower part of the diagram, you can see the line. This is the solid line, which is showing an efficient or good, reasonable HbA1c after starting CGM, and the dotted line is the control. So, in these patients, those who are more than 60 years of age, having type 1, type 2 diabetes on multiple insulin injections, the CGM use was high and was associated with improved glycosylated hemoglobin. And they considered, or they recommended to use the CGM in these types of patients. And as you can see on the lower part of this slide, that the top part, if you can see that these are the group of patients who are put on CGM. On the right hand side is the control. So as compared to the control, there was less glycemic variability. The time in range was better, and there was no hypoglycemia, less hypoglycemia also in those who were using CGM. This slide actually is the busiest slide, but I have only highlighted the main points. And according to this study that was published in the Journal of GMIR Diabetes in 2019, and it's also it was done on impact of just to see the impact of the new technology on middle-aged and older patients. And they actually did interviewing with these patients. And they found that the physician guidance and the participant motivation were the main factors that compelled the patient to adopt the device. And they also said that the women were found to be more compliant to the advice, and they were more inclined to using the CGM. And there are some of the patients, they also hinted that if their blood glucose was going high, the values were high in the CGM, they were thinking that this may be a progression of the disease, and that was actually changed their behavior. So the CGM was, according to this study, it can be helpful for diet control, and it can be an effective behavioral modification tool as well, especially in women. So in conclusion, the significance of the family support, actually, sorry, I have another slide, sorry, because this is some this is error. This should have been before. So these are actually the guidelines from the Saudi CGM, the guide for diabetes that were published in 2021. And on the left-hand side, you can see that the continuous glucose monitoring has been recommended by the Ministry of Health in all patients who have type 1 diabetes and type 2 diabetes with having hypoglycemia unawareness, which could have been a factor in our patient, in people who are having chronic renal failure, on dialysis or transplant, or suffering from gastroparesis. And it can also be used temporarily in type 2 diabetes patients who were using insulin and had poor control at least 3 times per year. So these are the recommendations. And on the right-hand side, you can see for the elderly population, they recommended the same 3 targets as we discussed earlier in the international consensus, that on the top, if the patient has a life expectancy more than 10, then HbA1c, according to the Saudi guideline, should be less than 7.5. And if they have multiple comorbidities, then HbA1c, recommended HbA1c is between 8 to 8.5. And the third, if they have end of life care, then these subset of patients should avoid hypo and hyperglycemia. So I will go back to the conclusion that the significance of the family support in CGM usage by the elderly people having type 2 diabetes cannot be overemphasized, as we saw in our patient. And the diabetes technologies like continuous glucose monitoring can be instrumental in achieving an euglycemic state, and also can act as a behavior modification tool, as we saw in one of the study. And the CGM can also reduce the patient's burden of frequent blood glucose pricks and improve glycemic outcomes. Actually, this is a very important factor in our clinical practice, because patients are complaining they don't want to prick too many times. And in the last, the physician guidance and participant motivation are the key determinants for the device adoption. Thank you.
Thank you, Dr. Muhammad. Is there any questions from the audiences? I think there are no questions. Thank you, Dr. Muhammad.
Thank you.
So we'll move on to our next speaker. That is Dr. Heba Ragab from Egypt. I am passing her the stage to deliver the speech on enteral and parenteral nutrition. Over to you, Dr. Heba. Kindly share your presentation.
Okay. Is that clear?
Yeah, your screen is visible. Yes, it is visible. Yeah.
Okay. Our today's topic is about enteral and parenteral nutrition. The first thing, we will talk about the nutrition science. It's a multidisciplinary area that covers the role of nutrients. Just a second. According to the nutrition science, it's a multidisciplinary area that covers the role of food and nutrients in health and disease across the lifespan and processes by which an organism ingests, absorb, transplant, and utilize and excrete food. Nutrition forms. We have 3 forms nutritionally: an oral route, enteral, and parenteral route. According to the oral route, we have a regular diet and therapeutic diet. According to the enteral, we will take it through a tube or a stoma. And the final and the last one is the parenteral. It's a partial or a total nutrition. Nutrition preferences. The oral route, it's a regular diet, is usually under the supervision of dietetics and should cover individual caloric need according to recommendations based on scientific evidence, such as recommended daily allowance or dietary reference intake. The oral food came in the form of regular food in organized plan or considered caloric liquids or a fortified food. What about the fortified food, which is vitamins added in case of deficiency in micronutrients? The second one is the enteral. Enteral nutrition is the delivery of nutrients through a feeding tube reaching esophagus that goes directly to the stomach or small intestine to pass the area of complication for a special medical purpose. What about the parenteral? A parenteral intravenous administration of nutrients such as amino acids, glucose, lipids, electrolytes, vitamins, and trace elements. Parenteral nutrition may be total if the patient is MPO or null per mouth, or a partial if it's something complementary. Our golden rule, if the gut works, use it. How does my digestive system work? The mouth received food and works on it by mechanical crashing through teeth and some digestive secretions. When you swallow, your tongue pushes the food into your throat and the food passes into your esophagus. After receiving ingested food from esophagus, the stomach breaks it down into chyme and empties it into the duodenum. The pyloric sphincter slightly opens when chyme down to lower pylorus. Each mixing wave forces almost 3 millichyme into the duodenum, and we will get the gastric emptying. The small intestine consists of the duodenum, jejunum, and ileum. The large intestine, we have the colon, responsible for absorption and elimination. The 3 steps of how our colon works, it's occurring to the fermentation, intermination, and finally sphincter that controls the defecation, excretion of liver residues, wastes, and some water. Simply, your body mission is nourishing you, especially your digestive system. Once the food reaches your mouth, every part of your digestive system collaborates to turn it into small parts, then liquid, the chyme, to facilitate the process of absorption. In your large intestine, the colon absorbs water, excrete wastes in the form of a stool. Finally, we can't neglect the cooperation of hormones, enzymes for controlling the digestive process. So let's talk about the enteral nutrition. What is enteral nutrition? Enteral nutrition is the delivery of nutrients through a feeding tube reaching esophagus that goes directly to the stomach or small intestine to pass the area of complication for special medical purposes, supporting maintenance of the functional integrity of the gut, strengthen the utilization of the nutrients since nutrients undergo first-pass metabolism, maintaining normal digestive and absorption, potentially maintaining the gut-associated immune function. This is the advantages of keeping the patient on enteral nutrition. So when is enteral feeding used? We can't eat enough, so I have to start enteral feeding. When you can't eat enough calories to meet your nutritional needs, it should be provided in patients with at least a partially functioning gut. If you can't eat enough, you are at risk of malnutrition. So I have to start an enteral feeding and at risk of a weight loss and very serious health effects. Okay, the second part should be initiated in patients with inadequate oral intake for 7 to 14 days, or in those patients in whom an inadequate oral intake is expected over 7 to 14 days. For critically ill patients, enteral nutrition should be initiated early within 24 to 48 hours of admission to the critical care unit. Who receives a tube feeding? Tube feedings may become necessary when you can't eat enough calories to meet your nutritional needs. This may occur if you physically can't eat safely or if your caloric requirements are increased beyond your ability to eat. Some patients need it for a short term from 4 to 6 weeks. More than 6 weeks specified as a long-term enteral nutrition. Who receives enteral nutrition or needed? A stroke patient, a cancer patient, critical illness or injury, which reduce energy or inability to eat, failure to thrive, to eat in young children or infants, serious illness, which places the body in a state of stress, making it difficult to take in enough nutrients, neurologic or movement disorders that increase caloric requirements while making it more difficult to eat, and finally, GR partial dysfunctioning. Types of enteral feeding. There are 3 main types of feeding tubes. These tubes may have a further subtypes depending on exactly where they end in the stomach or intestines. The placement of the tube will be chosen by a doctor based on what size of tube is needed, how long enteral feeds will be required, and your digestive abilities. The doctor will also choose an enteral formula to be used based on tube placement, digestive abilities, and nutritional needs. Second possibility is the stoma. That's inserted endoscopically into the stomach, example percutaneous endoscopic gastrostomy, or with a jejunal extension, or into the jejunum percutaneous endoscopic jejunostomy. Types are a nasogastric, a gastrostomy, and a jejunostomy. The tube types, first one, a nasogastric, starts in the nose and ends in the stomach. Nasoenteric, from its name, tube starts in the nose and ends in the intestine. And the third one, orogastric, starts in the stomach, in the mouth, and ends in the stomach. Naso-post-pyloric tube feeding is the last one. How is tube feeding applied? Tube feeding administration depends on the tolerance of the patient, continuous administration over 24 hours, and a cyclic administration, it's over 12 hours only, and bolus or gravity over 10 minutes. What is colostomy? It's an opening for the colon, and it's temporary to keep the stool away from the bowel in case the colon will be removed. Example, colon cancer, those colostomies are performed permanently, used to correct problems with the lower digestive tract. Other ostomoses include ileostomy. Creates an opening from the ileum to the outside of the body through the abdominal wall. Aerostomy is a diversion of the tube that carry urine out of the bladder. What about the enteral formula? Enteral formulas are vary in caloric content from 1 to 2 kilocal per milli. Formulas composed of different sources of carbohydrates, protein, fats, micronutrients according to each case need. The majority of energy in enteral formulas generally comes from carbohydrates, with standard polymeric formulas providing from 30 to 60% of energy from carbs. Immune-enhancing formulas contains arginine, glutamine, nucleotides, and omega-3 fatty acids. The enteral nutrition formulas, we have 4 to 5 formulas, a blenderized form, disease-specific, targeted for organ dysfunction or a specific metabolic condition, modular, used for supplementation to enhance the nutrient content of a formula or a diet, a polymeric or a standard one, contains intact nutrients, and finally the elemental or a semi-elemental one contains a partial completely hydrolyzed nutrients, protein, and altered fats. And these are a formula types. Okay. Our enteral goal, achievement of a greater than 50% to 65% of the calculated calories within the first week of hospitalization is our aim. Efficient enteral nutrition delivery is consistent infusion of more than 90% of the calculated caloric goal. Special care to avoid refeeding syndrome. Possible complications of enteral feeding. First one is aspiration, which is food going into the lungs. Second one is refeeding syndrome, electrolyte imbalance that may occur in people who are very malnourished and start receiving enteral feeds aggressively. Third one, infection of the tube or insertion site. And last one is nausea and vomiting that may result from feeds that are too large or fast or from slowed emptying of the stomach. The second part of the complication, we may face a skin irritation at the tube insertion site, diarrhea due to a liquid diet or possibly medications, tube dislodgement, tube blockage, which may occur if not flushed properly with water. Who shouldn't have an enteral feed? The main reason a person wouldn't be able to have enteral feeds is if their stomach or intestines aren't working properly. Someone with a bowel obstruction decreases blood flow to their intestines, ischemic bowel, or severe intestinal disease would likely not benefit from an enteral feeding. So if we are failed in an oral and enteral nutrition, we have our last option, the parenteral nutrition. So parenteral nutrition, it's an intravenous administration of nutrients such as amino acids, glucose, lipids, electrolytes, vitamins, and trace elements in the bloodstream via a peripheral route. The peripheral route is limited to 800 to 900 millismol per kg due to thrombophlebitis or a central access. Parenteral nutrition may be taught if patient is MPO or maybe a partial something complementary to the caloric need of the patient. When is parenteral feeding used? Patient failed in enteral nutrition, short bowel syndrome, distal high output fistula, mesenteric ischemic, intractable vomiting, complete intestinal obstruction, refractory diarrhea, paralytic ileus. Parenteral nutrition delivery methods. We have two forms, a continuous infusion over 24 hours or a cyclic infusion over 12 hours. How is parenteral nutrition applied? As we have mentioned, via peripheral route, which is limited to 800 to 900 milliosmol per kg due to thrombophlebitis, or via central access. What about the types of parenteral nutrition formulas? We have two types, a 3-in-1 or 2-in-1. The 3-in-1 contains dextrose, amino acids, lipid mixed together. The 2-in-1 admixture, it's lipid-free somehow, contain dextrose and amino acids together in one container, while lipid emulsion infused separately over 12 hours, which is called a piggyback method. Those solutions can be administered using separate bottles, but are preferably administered using compounding or ready-to-mix bags. Products must be combined in a suitable environment and under aseptic techniques that ensure sterility of the final product. The PN compounding. Compounding in sterile methods mentioned briefly in USP Chapter 797 and defines conditions for sterile compounding of parenteral nutrition. Stability and storage criteria are also defined in the USP. Parenteral admixing and order of mixing described in details in ASPEN. Attention should be paid to completely of products compatibility assured according to manufacturer and compatibility studies. What about the complications of parenteral nutrition? As enteral nutrition, we have complications in parenteral. First one, refeeding syndrome. Second one, bone demineralization. Third one, hypertriglyceridemia. Fourth one, hypertriglyceridemia and hypoglycemia. Fifth one, hepatic complications. And last one is catheter infections. All are suspected complications for parenteral nutrition. Patients follow-up of nutrition therapy is a measure to check and adjust that nutrition delivery is in progress and nutrition intake or provision is sufficient, as well as to assure tolerance and the goals and expected outcomes are achieved by monitoring the nutrition intake, weight anthropometry, and body composition, lab values, physical functioning, and the quality of life. As a small comparison between an enteral and parenteral feeding, the enteral feeding partial functioning gut is a must. 2 feedings or a stoma may become necessary when you can't eat enough calories to meet your nutritional needs. This may occur if you physically can't eat safely or if your caloric requirements are increased beyond your ability to eat. Some patients need it for a short term, and more than 6 weeks are specified as the long term. Enteral nutrition most closely mimics regular eating and can help with immune system function. What about the parenteral nutrition? If you are at risk for malnutrition and you don't have a functional gut system, you may need an option of a parenteral nutrition. Parenteral feeding refers to a given nutrition through a person's vein. You will have a type of venous access device such as a peripheral or central catheter inserted so you can receive a liquid nutrition. If this is your supplementary nutrition, it's called a partial nutrition. When you are getting all of your nutrition requirements, it's called a total parenteral nutrition. Parenteral feeding can be a life-saving option in many circumstances. However, it's preferable to use enteral nutrition if at all possible, if you have a functioning gut. Our conclusion, the impact of nutritional status on the quality of life. Clinical nutrition is a vital hospital tool to sustain and improve quality of life of patients. Here we got the references. Thank you. Any questions?
Thank you, Dr. Heba. That was a great insight on the parenteral and enteral nutrition. Anyone having any questions? For that technical glitch. Am I audible now?
Yes.
Yeah.
Yes, you are.
Yes, thank you. We will move on to our next speaker. That is Dr. Saida Sarah Mejabin from Saudi Arabia. I am passing her the stage to deliver the speech on comparative analysis of diagnostic accuracy of malaria parasite by microscopy, RDTs, and PCR. Over to you, Dr. Saida.
Yes. Good morning. Thank you so much, Priya. And I thank UGC for giving me this opportunity to present today in the conference in front of all the respected attendees as well as organizers. So I'm Dr. Saida Sarah Mejabin. I'm a general pathologist from India, and presently I'm residing in Canada, and I've worked as a specialist pathologist in Saudi Arabia and India as well. My area of interest is hematopathology. So I'll begin my presentation here. Yeah, just do let me know if everything is okay, if you can see my screen. Is the screen okay?
Yes, it's fine.
Okay, right. So today my topic of presentation is comparative analysis of the diagnostic accuracy of malarial parasite by different modalities. And what we have used is microscopy, the rapid diagnostic tests, which include Plasmodium falciparum histidine-rich protein and Plasmodium LDH as well as PCR. So before we begin, let's talk a little about the impact of malaria, both in the endemic as well as non-endemic regions of the world. According to CDC, in the year 2020, an estimated 627,000 people died of malaria, and most of them were children in the sub-Saharan Africa. So the hazardous nature of infection can be assessed by the following statement from WHO that says malaria is endemic in 107 countries inhabited by half of the world's population. As we all know, it's caused by the protozoan parasite of the genus Plasmodium, and among the 5 species that we have, falciparum is the most pathogenic and fatal if it is not treated on time. And this is especially so in a non-immune host, like, for example, children, pregnant females, and also the non-immune traveler from non-endemic regions to endemic areas. So clinical assessment, even by experts, cannot reliably confirm or exclude a diagnosis of malaria. We do have the typical clinical features like cyclic fever and splenomegaly, but they are neither sensitive nor specific. And this is why we need a rapid and accurate diagnosis of malaria. And this is integral for the appropriate treatment of affected individuals, as well as to prevent the further spread of infection in our community. Microscopy remains the gold standard for the diagnosis of malaria, and it has a threshold sensitivity of 5 to 50 parasites per microliter, depending on the expertise at the center which is doing it. And we also have the newer rapid diagnostic tests, which actually detects malarial antigen, and they are reported to be highly sensitive, specific, time-saving as compared to the other modalities. So this study is undertaken to compare the efficacy of these rapid diagnostic tests to microscopy as well as PCR. So we have conducted a 3-year study in our department. A total of 750 clinically diagnosed cases of malaria were studied, and we have devised a composite standard reference method by using the 3 modalities like the thick film microscopy, rapid diagnostic tests, and PCR. For the microscopy, we've used EDTA anticoagulated blood, and we have used both thick and thin blood films on unfixed dried films placed in buffered water stained with Giemsa. The rapid diagnostic tests are immunochromatographic tests, and they use monoclonal antibodies. These monoclonal antibodies, they capture malarial antigens in a blood sample, and we can see a visible color change on the kit that we have. And PCR was done in a reference laboratory as per standard protocols. So these are a few of the slides that we have from our department. So here we can see falciparum gametocyte, the banana-shaped structure, which is very clear here. And then we also had, there are multiple ring forms, though I'm sorry for the poor quality of the picture. It's not very clear, but then we could see multiple delicate ring forms. And this is malaria pigment in a neutrophil. We've also seen schizont, Plasmodium falciparum in our positive cases. And we have used these kits to do the rapid diagnostic tests. And as we can see, when we have the 3 lines, they were positive for the malarial antigens. So our results showed a total of 252 true positive cases. 358 were true negative among the 750 clinically diagnosed cases. And among the true positive cases, we had 155, which were positive for Plasmodium falciparum, and 97 were positive for non-falciparum malaria. Well, then we compared the sensitivity and specificity of different methods. The thick film microscopy showed a sensitivity of 77.5 with a specificity of 81.9. And the rapid diagnostic test, the sensitivity in our study was very high, 84.3, and the specificity was 77.2. With the PCR, we could achieve a sensitivity of 82.6 and a specificity of 78.2. We have also done a comparative analysis with different other studies and have found our study to have more or less the same results. So to discuss, starting with the microscopic review of the peripheral blood smear, as we've already seen, it has a sensitivity of 77.5 and specificity of 81.9. So the sensitivity of thick film smears were lower than the rapid diagnostic tests and the PCR. And this could be related to the parasite density. The specificity was found to be higher than the rapid diagnostic test, but it was almost comparable to PCR. And finally, the microscopic review of peripheral blood smear is always considered as the gold standard for the diagnosis of malaria. So there are certain advantages that we've noticed, and it's there in literature as well. It has the microscopy has the ability to detect malarial parasite with a threshold sensitivity of 5 to 50 parasites per microliter, but this depends upon the expertise at the center, as I've already mentioned. And another very important point is we are able to precisely detect and differentiate the species, as well as do the parasitic density index. And this would guide the clinician in terms of treatment and in terms of whether the patient needs any kind of parenteral treatment or hospitalization, especially in cases of Plasmodium falciparum. And also, we were able to monitor response to treatment and hence drug efficacy. So the test results, the microscopy becomes negative once the patient starts treatment in most instances. And so it is helpful to monitor response to treatment. So overall, it is cost effective and it is precise if we have the expertise to see it. And so it is very useful in endemic areas as well as developing countries. The disadvantage or the drawback, or we can see what we can think of is if there is lack of experienced personnel who can see the slide and detect the parasite levels, that could be one drawback in some centers. And another is about the turnaround time. So in our study, we had it approximately 40 minutes. Coming to the PCR detection of malarial parasite, so the sensitivity was 82.6, and it is more than the thick film microscopy. But then thick film microscopy was more specific than PCR, with their specificity being 81.9 and 78.2 respectively. So what PCR does is it detects specific nucleic acid sequences, and it has the ability to detect less than 5 parasite level per microliter of blood. So it's highly sensitive. PCR is useful for both initial parasitic diagnosis as well as for monitoring the efficacy of treatment. So what could be the weaknesses or the drawbacks? It requires a turnaround time of 10 to 11 hours because this is mostly done outside of the lab, but microscopy took an average of 40 to 45 minutes. And also PCR is expensive. It might require electric power. It is time consuming, as we've already said. So it could be less affordable in the developing countries. So nowadays we are using PCR more importantly for quality control, but we are expecting certain techniques to provide more rapid results like the real-time PCR. And that could be the answer maybe in the near future. Coming to the rapid diagnostic test, so we have done the Plasmodium falciparum histidine-rich protein 2. We have used these kits and Plasmodium LDH. So rapid diagnostic test was found to be more sensitive than PCR and thick film microscopy, but it lacks specificity as already discussed. So also what we have noticed, it had a higher number of false positive cases, around 103. And even though the patients were tested positive, there were no sexual or asexual forms seen in the peripheral blood smear. So, and also what we have found is the Plasmodium falciparum histidine-rich protein is more sensitive than LDH for the detection of Plasmodium falciparum infection. So rapid diagnostic test is a diagnostic tool that can be used for early diagnosis. and it has actually greatly improved the control and management of the disease. It also requires small volumes of blood, and it can be done on finger stick specimens as well. So the major drawback could be that it remains positive during treatment, and hence response to treatment cannot be assessed. So the antigens that we detect, the histidine-rich protein and the LDH, they remain in the blood for a prolonged period of time, even after the patient is started on treatment. And this is the reason why the rapid tests still remain positive. And so we cannot assess response to treatment. So, and also it is reliable, but then it requires a continuous quality control monitoring. WHO recommends that a quality control of these tests by monitoring their response using microscopy for at least 20 malaria positive and negative rapid diagnostic test samples. Also, it could give a suboptimal sensitivity if the parasite index is low. Again, it cannot differentiate accurately between parasitic species as well as density. And it could be expensive, particularly in the developing countries. Another important thing is if manufacturer instructions are not followed, results could be inaccurate. So to conclude, microscopy is the most widely used tool to diagnose malaria. And if it is done meticulously, it's the most sensitive, and it can detect a very low parasitic level. It's considered to be the gold standard. Also, it gives important information to the clinician, like the species of the malarial parasite, its stages, and the parasitic density. Rapid diagnostic tests are costly when compared to the blood smears. Of course, if we have expertise and it cannot assess the response to patients, response of the patients to treatment, it is unable to assess the parasitic stage and density, and it remains positive even when the patient is on anti-malarial drugs and responding to treatment. So PCR is expensive, and it has a turnaround time of 10 to 12 hours. And all these factors limit the use as a screening test for malarial parasite, and it still makes the old dictum, blood smears are the gold standard for the diagnosis of malaria, to still hold true. These are my references. Thank you so much.
Thank you, Dr. Saida. That was a great presentation. Any questions from the audiences? I guess there are no questions. Thank you, Dr. Saida. We will move on to our next speaker. Our next speaker is Mr. Mehmet Zeki Ogut from Turkey. I am passing him the stage to deliver the speech on should we excise the ectopic liver tissue associated with gallbladder encountered during laparoscopic cholecystectomy. Over to you, Dr. Mehmet.
Hi. Good morning, ladies and gentlemen. Hi, everyone. Thank you, Dr. Priyanka. My name is Zeki Ogut. I'm a general surgeon from Turkey, Şanlıurfa Ceylanpınar. It's an honor for me to make a presentation in such a distinguished conference. Today, Today I will talk about hepatic cholestoma case. My talk will take about 10 minutes. I'm going to start with an introduction about hepatic cholestoma. Cholestoma means the presence of normal cells and tissues in the abnormal localization. The instance of ectopic liver tissue has been reported to range from 0.24% to 0.47%. Here, ectopic liver tissue. cirrhotic liver, on the cirrhotic liver. Hepatic cholestestomas are more rare condition that is usually encountered incidentally during abdominal surgery. Most hepatic cholestestomas are asymptomatic. Rarely they can be symptomatic. The clinic of these tissues is usually insignificant, but depending on their appearance, they can be confused with malignant mass. Where is the ectopic liver located? Diaphragm, hepatic ligament, omentum, stoma, adrenal glands, pancreas, spleen, esophagus, and umbilical cord can be found in intra, extra, and retroperitoneal region, such as retroperitoneal and thorax. The gallbladder is the most common site, ectopic liver location. I will present a case of hepatic cholestoma, which was discovered incidentally during elective laparoscopic cholecystectomy and didn't require resection. The patient, 44 years old, a female patient, was admitted to our clinic 2 months after her acute cholecystitis and attack, and after treatment. Physical examination was normal. Laboratory analyses were normal. There was no finding in favor of cholestoma in the patient with cholecystitis in her radiological imaging. Intraoperatively, incidentally, there was an ectopic liver tissue of approximately 15 times 5 millimeter in size, originating from the liver on the left side of the gallbladder and attached to the serosa of the gallbladder. So standard laparoscopic cholecystectomy was completed without disconnecting the hepatic cholestoma from the liver. You can see here, you can see hepatic cholestoma on the gallbladder. Post-operative follow-up was uneventful. The histopathological findings were chronic cholecystitis and cholelithiasis. When we will look at the conclusion in result studies, it has been determination that these cholestoma don't have any finding in favor of increased malignancy. Since the risk of malignancy is not high, we don't resect the cholestoma in order to not to prolong the operation time and not cause complication. If the ectopic liver receives its blood supply from the liver parenchyma, resection may prolong bleeding and operative time, as it may cause uncontrollable bleeding during resection. If there is no risk of malignancy, resection may not be done by considering bleeding and other complication. Thanks for listening.
Thank you, Dr. Mehmet. There are any questions from the audiences? Yeah, I guess I don't think so there are any questions. Thank you, Dr. Mehmet. We will move on to our next speaker. Yeah. We will move on to our next speaker. This is Dr. Durga Bhavani Banti from India. I am passing her the stage to deliver the speech on health supplement-induced cholangiocarcinoma, a case report. Over to you, Dr. Durga.
Thank you, Dr. Priyanka. Can you hear me?
Yes, I am. You are audible.
Okay. Hi, everyone. My name is Durga Bhavani Bandi. I'm a recent graduate from Gandhi Medical College, Secunderabad, India. I am here to present to you a case report on a, just a second while I share my screen. Can you see my screen?
Not yet, Durga.
What
Yeah,
about
now
now?
it is visible, Dr. Durga.
Okay.
Yes, it is visible now.
Okay. So the topic I want to talk about today is a health supplement-induced cholangiocarcinoma, a case report. So to start with, I want to give the introduction of the cholangiocarcinoma, which is an uncommon neoplasm that arises from the biliary epithelium and comprises only approximately 3% of all the GI malignancies. While there are many risk factors for cholangiocarcinoma, whether it be the more common ones like primary sclerosing cholangitis, the parasitic infections, and the choliodocal cyst, this is the less common etiology we saw, and that too because of herbal supplement the patient was taking, and we found it quite fascinating, which we want to shed some light upon. So to start with, our patient was a 92-year-old female with a history of arthritis, presented to an emergency department with generalized abdominal discomfort, jaundice, and a decreased appetite of 1 week duration. Her review of system was normal. Her physical examination was normal. Most of her lab reports were normal, except for her liver enzymes, which were elevated. On detailed history, we got to know that she has been taking a herbal supplement called Hemohen recently because of her arthritis. We wanted to investigate more, and we wanted to perform more imaging. When we did a CT scan, it revealed a soft tissue infiltration along the gallbladder. A focal structure of the common hepatic bile duct confluence was seen, as well as a intrahepatic bile duct dilation. On MRCP, we could see a moderately dilated biliary duct with marked narrowing of the confluence. With ERCP, it was confirmed, and a stent was placed to relieve the stenosis. And when we were investigating more and we saw the tumor markers, we saw that they were elevated. As you can see in the diagram here and also in the ERCP image finding, that it's clearly, let me see. Seen that like the hepatic confluence of the biliary duct is stenosed. And when we were working her up with other lab reports, the hepatic panels, the autoimmune workup, the ANA, anti-smooth muscle antibody, the anti-mitochondrial antibody, all of them came negative. And the biopsy we took, we did an immunochemistry on that. It showed the mucin-producing cells were positive. So she was eventually referred to the oncology department to take care of her. A PET scan was done, and the prognosis was seen, and ultimately she was referred to a palliative treatment. So I want to conclude by saying that this was a different thing for the cholangiocarcinoma, because most of the herbal medication and herb supplements are not under scrutiny by the FDA as the same for the pharmaceuticals that are supplied in the US. So the cancer causing potential of these is quite ignored. So while a case of cancer comes to the department, we have to take like a detailed history, and we should broaden our differentials and take a detailed history of whether the patient is taking any herbal supplement to actually help us diagnose and treat more. That's it for me today. Thank you.
Thank you, Dr. Durga. Any questions, audiences? I think there are no questions. Thank you, Dr. Durga. That was a nice case. Our next speaker is Dr. Sherry Scott from UK. I am passing her the stage to deliver the speech on embedding education into clinical laboratory professional training to foster sustainable development and greener practice. Over to you, Dr. Sherry. Dr. Sherry. I think Dr. Sherry is not there in the participants list. Yeah, okay. So I think Dr. Sherry will be not there for the presentation. We will move on for the lunch break. Thank you so much. We'll resume after the lunch break. Thank you so much, everyone.
Good afternoon to everybody. It's my pleasure to be a chairperson, and now we will begin the day 3 post-lunch online session. Our next speaker is Dr. Sherry Scott from UK. So I'm passing her the stage to deliver the speech on embedding education into clinical laboratory professional training to foster sustainable development and greener practice. Dr. Sherry Scott, stage is yours.
Thank you very much. So in today's presentation, I'm going to be talking about sustainability in clinical laboratory environment. Thank you very much for inviting me to speak this afternoon. I'm going to be helping you to understand the relationship between the climate and the climate emergency and public health, help you understand sustainability and how we can look at sustainability quality improvement within laboratory practice, and hopefully help you gain some knowledge of case examples of where laboratories in the UK have embedded sustainability into their practice via their education. So just to give you a bit of an overview of my background. So I am a biomedical scientist, HCPC registered. I practiced in the clinical chemistry laboratories for over 21 years, working in the NHS. I've now moved to academic practice at Nottingham-Trent University. I'm a practice-based lecturer, which means I retain my practice experience. I'm a CPD officer for the Institute of Biomedical Science, chief examiner for the Institute's higher specialist diploma, and editorial board member for their journal. And more recently, I have become involved as their sustainability champion. I'm working with the European Federation of Laboratory Medicine on their Green Lab and Sustainable Lab Task Force as a core member. So we're facilitating and educating professionals across Europe. I am founder of the Clinical Lab SUSNet network, which is a network where we can collaborate and foster sustainable practices. And I'm also an education lead for sustainable development within my university. And I've got lots of collaborative projects on the go relating to those roles. So I'm working with the Laboratory Efficiency Assessment Framework Group to embed clinical framework within the hospitals. I've helped develop the guidelines of the EFLM to help sustainable practices. I'm launching student projects across the UK to foster a more sustainable practice, and helping to develop and facilitate education in sustainability. So what is sustainability? Well, it's the balance between the environment, equity, and the economy. It's the most common definition is sustainable development is the development that meets the needs of the present without compromising the ability of future generations to meet their own needs. And we base that around 17 global goals that replaced the Millennium Goals in September 2015. And these UN SDGs look at ensuring that we reduce poverty, there's zero hunger, we have good health and well-being, we foster and share good quality education, and also looking at climate action and the health of the land and animals, and making sure we've got partnerships to meet these SDGs. It's well documented that our changing climate is leading to more frequent heat waves and extreme weather events. We've seen flooding, we've seen drought, we've seen storms throughout the UK, and quite often it's the poorer nations that get most affected by these extremes in temperature. And as we see these extremes appearing in news headlines and growing evidence of the health impacts of climate change, such as air pollution, increased levels of heart disease, increased levels of stroke and lung cancer, and also increased spread of infectious diseases, we're coming to the conclusion that as health professionals, we need to adapt our own practice to try and reduce those negative effects of on the carbon production of waste production. So why consider sustainability in our education? Well, climate change is becoming more apparent. We've got organisations declaring health emergencies, and sustainability and understanding is becoming a fundamental skill. It's appearing in our professional practice. It's a requirement of our education and our undergraduate education, but it's also a requirement in our professional practice because it's linking to our hospital policies, it's linking to our government legislation, and it's a fundamental skill that our graduates need as they move on in their careers and joining the clinical labs. So we need to look at how we can reduce our carbon footprint, reduce our air pollution, so that we can have a positive impact on the environment and our current practice, as opposed to the negative effects that we see in rising temperatures, we see in rising sea levels, and our current CO2 production. So I'm part of the NHS in the UK, and we've got a number of early steps that we have taken to try and decarbonise our current practice. We've got an NHS long-term plan, so we're looking at new models of ways of working. We're looking at our medicines and supply chain and working with our suppliers to ensure they meet their CO2 and net zero emission targets. We're looking at our transport and travel and how we can use zero emission vehicles. We're looking at our innovation, looking at transforming digitally so that we can have more sustainable practices. We're looking at our buildings in our hospitals, our lighting and our heating, and we're looking at our patient pathways and trying to embed more sustainable methods in the way that we treat and look after and diagnose our patients. If we look at this figure from the Centre for Sustainable Healthcare, which is a non-profit organisation, they share how the NHS have got a pathway to net zero, where they're going to look at national electricity decarbonisation, looking at that digital care pathway, looking at our current buildings, and looking at our research, innovation and offsetting. We can look at where our carbon emissions come from so that we can target our innovations and target our changes to the areas that have carbon intensity. If we consider the carbon footprint for medical instrumentation, we can look at the energy that we produce within transport of our staff, of our patients, or of our consumables and our procurement. We can look at the gases that we use and the waste that we produce, whether that's plastic, whether that's chemical, and looking at ways we can reduce that waste or recycle that waste. So when we're considering that travel, it's helpful to look at how carbon intensive different forms of travel are. We can take the example of France that are banning domestic flights, because if you can see the carbon intensity per kilometre for a domestic flight at 255 grams of carbon is a lot higher than the same for train or other public and commercial routes of travel. We can look at the difference between a petrol car and an electric car and encourage greener transport of our employees. And we need to consider the circular economy, because most economies discard raw materials as waste after use. And if we consider that circular carbon economy, we're looking at managing and reducing those emissions. So having a closed loop system, including the 4 R's: reduce, reuse, recycle and remove. If there is something that is no longer fit for purpose within the clinical laboratory environment, can we reuse it for parts? Can we have a send back or sell back system to our suppliers? Can it be refurbished and used for alternative options, such as our universities for teaching and training? Can we recycle any of those raw materials to reduce the need for those materials, that product to go to incineration and landfill? We need to look at our manufacturing, our consumables, our reagents and our logistics to try and reduce the amount of waste we produce. Labs are more carbon intensive. They are harsher on the environment than office spaces. This illustration from My Green Lab really demonstrates that labs produce 10 times more energy than the office, 4 times more water than office spaces, and 12 billion tons of plastic per year. So they have a really strong environmental impact. So we need a sustained collaborative approach. We need to, it is hard to reconcile that circular economy with the healthcare sector. There is a large use of single-use plastics because of the hygiene and because of the versatility within our current clinical pathways and our practice within the lab. So we need to look at our energy consumption because it's unavoidably high when we've got equipment, when we've got PCs, when we've got lighting that we use within that lab. So we have to consider our NHS hospitals, our trusts, so that we can all become more sustainable and adopt that circular economy. So we can go beyond the 4 R's and consider the 6 R's. We need to reduce what we use, recycle what we can, repair if it gets broken, reuse it if we can, restore it for alternative methods. So rethink our current practice. This paper by Malera et al. From 2021 really considers some of the things we can do within our clinical laboratories. We need to think about the tests that we order, or we need to work with our clinicians and our requesting bodies to try and reduce unnecessary testing. To only use the tests that we need that have value to that patient pathway. Because if we can reduce the number of tests that come into the lab, we can ultimately reduce the energy consumption and the waste that we produce. We need to look at the tubes in our collection bottles and look at how much plastic we use, the type of plastic we use, and reduce those tubes if necessary. Thinking about if something has come to the end of its life, how we can reuse it within the lab environment. Do we have a green purchasing plan? Do we work with our suppliers to ensure they are sustainable and green and responsible? Do we have a paperless policy within our lab environment, within our practice? Can we reduce the energy and water consumption of our daily activities? Excuse me. And can we increase our collaboration between the wards, between the laboratories, between our networks, so that we can reduce the number of orders that we need to place? And can we make sure that we use renewable energy sources to supply the energy that we need? As healthcare professionals, we have a responsibility to do no harm. So we need to adopt the principles of sustainable healthcare. Prevention, we need to promote that health and prevent disease by tackling causes of illness and inequalities. We need to encourage patient self-care, empowering our patients to take a greater role in managing their own health and healthcare. We need to consider lean service delivery, streamlining our care systems to minimise wasteful activities. And we need to consider the low carbon alternatives, prioritising treatment and technologies that have a lower environmental impact. So what we can do is we can use this model that's been presented by Centres for Sustainable Healthcare to embed sustainability into our practice and education. Quality improvement is a fundamental aspect of healthcare practice. And SUSQI is integrating sustainability into that quality improvement. So we can look at a more ethical and sustainable healthcare system. And what we use is this triple bottom line equation. We look at the sustainable value by looking at the outcome for the patients and the populations over the environmental, social, and financial impacts of a change. And this can be implemented where whichever discipline, whichever part of pathology that we work, whether we're on the front line with the patients or we're behind the scenes in the diagnostic clinical laboratory. So quality improvement is about acting, planning, studying and doing. It's looking at the system and improving that process and the systems. And it's built on a foundation of measurement. It's about goal setting and testing those goals. We need to think about what are we trying to accomplish by implementing a change? How will we know that change is an improvement? And what change can we make that will result in that improvement? And this is where it comes into embedding sustainability into our education. We can use SUSQI as a form of education for sustainable development. And the aim of SUSQI is to deliver care in a way that maximises positive health outcomes and avoids both financial waste and harmful environmental impacts, and subsequently adding social value at every opportunity. So we need to set goals, study the system, design that improvement and measure that impact, that key quality improvement framework. So how can we improve the sustainable value of our current practices? Well, we need to look at the drivers of change that we use in our quality improvement. We need to consider what outcome is needed, whether that outcome is to improve health of our patient group or reduce carbon within our current practice. We need to consider what those primary drivers are. Is it about reducing an activity to have a positive environmental impact or reduce the carbon intensity of a current practice? And then we can link it to the secondary drivers. Are we looking at prevention? Are we looking at patient empowerment? Are we looking at the lean pathways? Or are we looking at low carbon alternatives or operational resource use? And that will impact on our change ideas. And the Centres for Sustainable Healthcare Principles of Sustainable Clinical Practice help us reduce our resources while maintaining and improving our health outcomes. So increasing that sustainable value. So here are some sustainability and quality improvement projects that can be linked to pathology practice. We can consider what service improvement requirements are needed. We can consider the sustainability when we're setting our current research projects for our post and undergraduate students and trainees. And we can consider whether we want to change to a paperless printing policy, whether we want to look at amending or changing or evaluating our use of resources and consumables, whether there's an alternative reagent or a green chemistry that we can employ, whether we can look at the lab impact and the patient impact as part of a current project that we've got going, whether when we're looking at a change, whether we can consider the waste and the energy as part of that change, and whether that impacts on staff time that can then ultimately impact on positive sustainable value. And we can evaluate our quality improvement changes, our education for sustainability, by looking at the carbon footprint. When we're thinking about the environmental impacts of any healthcare intervention, there are several broad categories we can consider. So if we consider that carbon footprint, we can link it to energy use on site, whether that's burning fuel for heating or electricity. We can look at the carbon footprint in the combination with the release of gases within our practice. We can link the carbon footprint to the travel of our staff and patients and carers. We can consider the carbon footprint of our pharmaceuticals or our medical equipment. So linking it to that distribution and manufacture, not just considering that delivery. Thinking about the non-medical equipment and supplies within that supply chain. So what do we use in regards to furniture, IT and laundry? Considering our food production and our waste disposal. Then we can also consider the non-carbon impacts. The air pollution as part of our current practice, the deforestation, landscape degradation, the loss of biodiversity as a result of our current practice or our current working environments. Do we have a negative impact on the depletion of scarce natural resources? Thinking about the bioaccumulation and toxicity of the waste we produce, including the plastic pollution from those single-use plastics. And then we can link that to the social impacts. We can identify positive and negative social impacts of our current system. We can think about why this is important and look at the negative social impacts on different patient groups. What are our patient learning needs, for example? What are our social needs of particular patient groups? And then we can look at the wider social impacts of our systems and our processes. So we need to look at quality improvement and consider the process map. This is a process map, look at mapping the use of salbutamol, of inhalers within an asthma pathway. But we can also use the same system in pathology. If we consider the carbon footprint of pathology testing that was mapped by McAllister in 2020, he associated most of the carbon outputs were linked to sample collection. Those emissions were attributed to the emissions attributed to laboratory reagents and power use were very much smaller. So if we can reduce the overall need for testing in the lab environment, making sure we get rid of that unnecessary testing and utilising point of care, we can have reduce those carbon emissions. If you consider the patient pathway when they're attending phlebotomy clinics, if the sample was to need repeating because of waste, because of errors, because of unnecessary samples taken, you're going to automatically impact on that carbon footprint, not only from that sample travelling to the lab, the plastic involved in that sample, but of that patient getting to that phlebotomy service in the first place. Lopez and Bedrick considered the environmental management systems within pathology, and they looked at how ISO 14000 can potentially be used to improve the environmental impact. They wanted labs to consider the 3R concepts of reduce, reuse, and recycle. And the next few slides consider the changes or the programs in place to help you reduce that environmental impact. This example from Newcastle Hospitals in the UK wanted to reduce their single-use plastics used in the transport of lab samples. They wanted to reduce the issue of those single plastic bags. So what they did was they introduced sample transport boxes. They worked with phlebotomy, and by using those boxes, turnaround times were increased, error rates were reduced, and overall lab efficiency was increased. So there was a cost saving, an environmental saving, and the social impact was improved for the patient. We have a Getting It Right First Time initiative within the UK to reduce our errors, reduce the unnecessary testing, and utilising point of care where we can. If we look at the patient point of care of sources available, as long as we make sure it's appropriate and it's used, has quality control, it has real value in that patient pathway. We can consider CRP in increasing the reduction of diagnostic uncertainty and enhancing antibiotic stewardship. We can consider U&E point of care when reducing pseudohyperkalemia when patient samples don't get to the lab in time. We can consider point of care at reducing the carbon footprint through reducing the need of samples getting to the lab. This particular case study looked at antibiotic overprescribing in a nursing home residential setting. By using CRP within that nursing home, it not only had a promising diagnostic tool to reduce antibiotic prescribing for lower respiratory tract infections, but it reduced the need for the CRP sample to go to the lab, reducing plastics, reducing the carbon footprint of transportation. We can use frameworks such as Laboratory Efficiency Assessment Framework Tool for certification for our greener practice and recognition within the lab. Here is the Sir William Dunn School of Pathology and some of the initiatives that they put into place while using leaf. Autoclaving tubes, cleaning and washing their tubes, decontamination, and looking at recycling. There are lots of guidelines and checklists that you can use that the EFLM have produced within their guideline booklet. You can download the booklet and start working. Can you reduce your freezers to -70 instead of -80? Can you look at alternative sourcing of greener materials? Can you look at switching lights off and turning off computers when you leave the room? My Green Lab is another organisation that is looking at improving the clinical sustainability practice. They offer certification like LEAF. There is a freezer challenge linked to -70 freezers. They have ACT labels that is an energy efficiency or greener sustainable label linked to consumables that many of the suppliers are considering. And you can join the network. So you can join the International Clinical Lab SUSNet network to share ideas, share best practices, and gain education to help more sustainable practice. You can use resources such as this resource from the Royal Society of Chemistry that helps provide knowledge and guidance and promote best practices in sustainability. The academic and research sector are ahead. There are less regulation in this sector, so there are some things you can do in academia that you can't do in clinical practice, but there are many things, small things that we can do to improve our sustainable impact. We can consider those LEAF or My Green Lab, but we can also consider the energy consumption of the equipment that we buy. Is there an energy capture model of our suppliers, of our big equipment? Can we reduce our water consumption within the lab? And can we have a signage to encourage switching off equipment to save energy? Can we change any of our protocols to use less solvent? Can we replace our energy suppliers to be greener? Can we recycle within the lab environment? But it is only through working as a partner that we will get this change to be recognised. So we need to work together, as in that SDG 17, to make a more sustainable and greener practices. Thank you very much. I welcome any questions in the chat that I can answer afterwards. Thank you.
Yeah, thank you, Dr. Shirin Squad, for your enlightening speech. So now the topic is open for discussion. Any queries?
Thank you very much for this opportunity to speak today.
Yeah, thank you, Dr. Shirin. So now, I'll let you know that next 4 speakers, Dr. Jonathan, Dr. Durga, Ms. Anand, and Ms. Jonathan Kraft is not available because of some personal issues. So we will take a break and we'll resume shortly. Thank you. This
meeting is being recorded.
I'm passing him the stage to deliver the speech on the rare cause of elevated alkaline phosphatase. Mr. Jonathan Kraft, welcome.
Thank you so much. Thank you so much. Welcome, everyone. I am thrilled to be here with you today. Just going to get the presentation up here. Welcome, physicians, researchers, and those who are just interested in hepatology and gastroenterology. It's great to be here with you all virtually, of course. I very much wish I was with everyone in person myself. I'm in Western Canada right now, and we're being hit by one of the worst blizzards of the past decade. So I wish I was with you all in person, but I'm excited to be here with you today. Today, I'm going to be sharing something that I think is so exciting. It's this kind of investigation, a case study about a rare cause of elevated alkaline phosphatase. I also really want to quickly just thank my mentor, Eric Schack, who is with University of California, Davis, who's been monumental in helping me pull together this case. So the agenda for today, we're going to go through a quick background of alkaline phosphatase. We're going to look at the situation and this rare cause. We're going to then move to a discussion and kind of the usual suspects when we talk about alkaline phosphatase, and finally transition into what are the takeaways from this case? How does this impact the field? How does this, what can be taken away from this case? So starting right there with the background on alkaline phosphatase, this is of course just a quick a view of it from a biochemical perspective, but moving more into the clinical perspective of it, and I will refer to it moving forward as ALP. It was first described in 1923 by Robert Robison. In 2016, the American College of Gastroenterology clinical guideline stated that liver-derived ALP, and that is really critical, and we're going to come back to that time and again throughout this presentation, on the importance when we're talking about ALP, especially when we're doing writing, when we're writing papers or research. It's really important to give that emphasis on, is it liver-derived ALP? If it's generic ALP, if we look down here at this table, at the bottom here, it could be liver or bone or kidneys derived. It could be duodenum, or it could be the placenta. And so it's really important when it's mentioned at all times to include that its origin. But in 2016, ALP, it was stated that ALP should be assessed as markers of liver injury and not liver function, which had been one of the, it had been a bit of a competing perspective on it, two ways to look at it, but moving in towards viewing it as liver injury when ALP is high. And of course, in the modern clinical setting, it's one of the standard lab values that is collected. And so it's a really important biomolecule to be aware of, and of course, and be ready to act when we see it. So just looking at our quick timeline here, we've got 1923, it was first described. 2016, we're kind of narrowing in our focus a little bit on it and saying it's a marker of liver injury and not liver function. And in 2019, a female patient presented with an elevated ALP and was referred to hepatology. And that's where our story begins. Now, the general response towards elevated ALP, usually it will be spotted in that initial blood test. And so it's going to be that liver enzyme that's abnormal valued, and it's going to then be first looked at by a general practitioner. And the first step they are going to do is determine if it's a liver-derived ALP. If it is, then the first step is going to be to do an ultrasound. And that's going to be looking for cholestasis or neoplasm, simple to find and easy to diagnose on that, as well as potentially going into anti-mitochondrial antibodies, looking for primary biliary cirrhosis. If the ALP is 1.5 times the upper limit of normal, building out from a negative ultrasound, then there's going to be a referral to hepatology, or it will, if there is, of course, a positive ultrasound, then it's going to be referred to hepatology as well. So once this case gets passed over to hepatology, if the ALP is 2 times this upper limit of normal, and it's so important to look at this upper limit, right? In a clinical perspective, you know, some people just have those high lab values. And so this is just the general guidelines, but we're going to see as we go through this case that there needs to be this flexibility, but usually ALP is there, of course, showing something. So if it is 2 times the upper limit, or sorry, if it's under 2 times the upper limit, then Hepatic origin is suggested. So that's going to be, again, an ultrasound of the liver, if that wasn't done already, to rule out the extrahepatic biliary obstruction. If that comes back normal, then we're going to be, it's suggesting that it's an intrahepatic cause. What's interesting about this is that you'll notice this, our flow through this is really indicative that it likely is extrahepatic biliary obstruction or intrahepatic cause. When that comes back negative, and we would check the intrahepatic cause by doing some antibody level checks, but when those come back negative or normal, I should say, then it's time to go to the liver biopsy. And then going back to the start, of course, if ALP is greater than 2 times the normal, then we're going to go and check that liver biopsy as well. So we're going to jump into the actual case now with this background information. So a 45-year-old female patient arrives in the clinic. There's no referred by, well, we'll get there. So no previous medical history. You'll see here some of the abnormal lab values: the iron saturation, iron binding capacity, the hemoglobin, and mean corpuscular volume were all low, lower than the normals. The normal values are in the square brackets there. And then the patient's values are bolded. And then the ferritin, erythrocyte sedimentation, C-reactive protein, ALP, and gamma-glutamyl transpeptidase were all elevated. The unremarkable lab values, and this is going to kind of play in later, of course, is the aspartate transaminase was normal, the alanine transferase was normal, and the total bilirubin was normal. So the initial diagnosis was iron deficiency anemia, as well as anemia of chronic disease, building on a bunch of the iron lab values. However, the elevated ALP was also caught, and it was determined that it was of hepatic origin because of the high GGT value, or gamma-glutamyl transpeptidase. So that was able to be, that immediately sort of was referred to hepatology. And then this brings us back to kind of where we're at in the timeline here. So in 2019, that female patient arrived, of course. However, the reasoning for the ALP remained elusive at this point. So the patient was treated as an outpatient and was sent home because, as many of the physicians here will know, we cannot hospitalize and keep everyone with an elevated ALP, even if it is significantly higher than the normal in the hospital. That would inundate the whole system. So there's something going on, but they're going to be treated as an outpatient for this ALP. However, they arrive in 2020 for their follow-up, and they're assessed with an even further elevated ALP. So the elevated is, the ALP is increased from 746 to 889. Now, going back again quickly, I should have pointed this out. The standard value for ALP is between 35 to 120 international units per liter. So we were at 746. The patient came back in 2020 with 889. So we're seeing this rise, of course, in the value. So that led to more tests and a lot more unremarkable lab values. The aspartate transaminase was still normal. The alanine transferase was still normal. And that was, of course, in the grand scheme of things, that was a bit surprising. Total bilirubin was normal. And then we did a bunch of antibody tests, all of which were negative. So this kind of called for a liver biopsy as well as echocardiogram being ordered. So looking at the workup, initially we had that mixed iron deficiency anemia we talked about, as well as the anemia of chronic disease. So thought initially was there could be a GI bleed. And so we did an upper endoscopy where we did find this lovely specimen of Candida esophagitis. That was cleared with a round of fluconazole though. And then a colonoscopy was done, as well as capsule endoscopy. All those came back normal. There was no GI bleeds of any type. that kind of brought us then to the workup of the elevated ALP, and the liver biopsy performed was normal. There was no significant fibrosis, there were normal bile ducts, and there was no portal or lobular inflammation of the liver. And the echocardiogram also was normal. However, the physical exam that was done, which was actually built on the baseline taken when the patient was referred to the hepatology clinic, on the baseline, a new hard and immobile 2-centimeter supraclavicular lymph node was appreciated. And so that was immediately a bit of a sign, of course, to what may be part of the cause. Of course, it wasn't known at the time, but that was the big narrowing in, you could say, in this case. So workup on the lymph node that was appreciated, biopsy was performed, which confirmed a diagnosis of Hodgkin's lymphoma. That was followed up with the PET and CT scan, confirming that it was stage 3A. And then the treatment was 6 cycles of brentuximab vedotin and doxorubicin and vinblastine dacarbazine. And that was highly successful, achieved remission. And with that, the ALP returned to normal. So this was a big, this is really the step 4 here is where the excitement about exploring this case came about. The ALP was evidently related to the Hodgkin's lymphoma infection. And so that kind of started raising questions about why did that happen? Why did the liver have no, seemingly very little involvement, none detectable, and yet ALP was evidently very much involved in Hodgkin's lymphoma. And so when we're building on this timeline here, in 1984, there was a literature published by Beamer that actually described that ALP is elevated in 81% of patients with stage 4 Hodgkin's disease. It was Hodgkin's disease at the time. And that's interesting, right? Looking back now, seeing, okay, well, hindsight is, of course, so much clearer, and we're able to now see that, well, makes sense. Of course, we're not going to go in and think that Hodgkin's lymphoma, which is quite a low prevalence in the United States, of course, we're not going to be thinking that, oh yeah, high ALP, it must be Hodgkin's, but it definitely made sense. However, the reasoning for this is not understood currently of why Hodgkin's lymphoma, especially an advanced stage of it, causes this. So kind of running us through that paper again by J.J. Beamer, it was Hepatic Manifestations of Lymphomas, published in the Annals of Clinical and Laboratory Science in 1984. So there was a demonstrated correlation of elevated liver ALP by stage of Hodgkin's disease. And it went up, of course, in stage 1 and 2, there was about a 14% correlation, 65% in stage 3. Again, our patient was in stage 3A, and then 81% up into stage 4. In many cases, ALP was not associated with hepatic lesion in this study. And that is comparable with our findings with this patient, where the ALP, of course, was elevated, but there was seemingly no hepatic involvement or compromise. Upon successful treatment of Hodgkin's disease, abnormal lab values consistently returned to normal. Again, that was consistent with our findings as well. So moving into the discussion here and kind of the usual suspects, when elevated alkaline phosphatase is appreciated, there's usually a 3-step flow to follow. The first would be extrahepatic biliary obstruction. The second would be interhepatic cholestasis, and the third would be non-hepatic cause. So you'd start at number 1, rule that out with the ultrasound, Common causes, malignancy, biliary stricture, infections. So that can be ruled out somewhat quickly by a general practitioner oftentimes. Moving to step 2 of the flow is going to be intrahepatic cholestasis. Now, common causes, and one of the most common causes, is primary biliary cholangitis. And 95% of patients have elevated ALP from this. So of course, we're going to be immediately sort of suspecting something along these lines. Primary sclerosing cholangitis as well, non-alcoholic fatty liver disease, drugs, graft versus host disease, as well as other systemic disorders. However, if we look here, once we get to the third part of the flow, non-hepatic cause, that breaks into so many different parts, right? It could be physiological, it could be related to pregnancy. Again, remember, ALP has all of those different origins, and so it can be hard to know exactly where we're going with it if we're not sure where it's derived from. Diet can impact it. A meal, large meals before the blood test can impact it. High bone turnover, again, that's bone-derived ALP, as well as extrahepatic disease. Now, when a normal GGT comes back, when a normal GGT comes back, or elevated GGT, my apologies, when an elevated GGT comes back, that's going to be indicative in telling us that we're looking at a liver-derived ALP. And so if it's a elevated GGT, we can kind of rule out the pregnancy side of it, as well as the high bone turnover. And we're looking here at extrahepatic disease. So kind of looking back into the books, looking back into the research on it, I was looking at, well, wait, where is ALP associated, elevated ALP, that's specifically derived from the liver, or there's a recorded elevated GGT. What is it associated with? And so I started pouring through the research, and there is actually a huge body of research and a lot of different case studies tying it to amyloidosis, type 2 diabetes, large vessel vasculitis, B-cell lymphoma, colorectal cancer, and the list goes on. But as I start writing all these out, you start to want to group, like, what's the meaning of this? And so suddenly, we start getting some obvious groupings. There's malignancy, there's autoimmune diseases, as well as chronic diseases that seem to be now linked, and that some of these might be through a specific case study, some of them might be through more meta-analyses, but these are starting to come, the picture is starting to resolve more on ALP and it being involved in a lot more. So this is more of a exhaustive list, you might say, of different autoimmune diseases, chronic diseases, malignancy that have been recorded related to an elevated ALP. And I think it's a bit overwhelming, because we look at this and we say, well, I mean, this is a lot more than just hepatology and gastroenterology. This is systemic. And that is what seems to be the case. Alkaline phosphatase, though a liver enzyme used to test liver function, is seemingly related to all of these other diseases and problems in the body. And so we are in some ways becoming the scouts of all these other things that are coming down the pipeline, and being able to start, when our awareness of ALP's role in some of these other diseases is there, we're able to very effectively move through the logical flow towards starting to try and rule out some of these linked causes of the ALP. So looking back through our timeline here, in 2008, looking back, ALP, it was stated by Chung and the rest of the research team that ALP may be another biomarker of systemic inflammation, especially in women. And so, of course, this patient was a woman, but broad scope looking at this, back in 2008, this was already being thought that ALP could be a biomarker of systemic inflammation. And in 2022, actually back in November, recent publication, ALP is now linked or was linked as a biomarker in 19 different diseases. And so while there are a lot of case studies showing different areas where there is an elevated ALP and GGT, liver-derived ALP, this one actually linked 19 different diseases through a meta-analysis. So the takeaways of this case, this is the big part, of course, of what's the point? What can we take from this individual who came in and is now part of the case study? So I would say the most important takeaway from looking through the research is there is a huge importance of stating the source of the ALP. Where is it derived from? If it is liver derived, which it will be, I'm sure, for many of you who are attending, it will be probably liver derived. It's really important to include that. Whether it's a factual statement, if you don't have the space for the word counts or whatever it might be, just stating that it is liver derived ALP, or of course including the values of how you were able to make that determination. Without their origin, it is so hard to actually make use of that case study in the long term in regards to ALP. It's just not, it's not possible, because if we look back really quickly here at large vessel vasculitis, that would be a good example of one that we would assume is linked to bone, actually bone-derived ALP. However, because the author went out of their way to include the GGT value and other values as well, that was able to be included in this research, that actually there is liver ALP involved in it in some regard. So there are 4 primary ways to establish the origin of ALP. The GGT, which we've talked about a lot, fractionation of the isoenzymes, heat stability, or electrophoresis. But that's so key, and that's one way that every publication just lends so much more value. And lastly, looking at the unique features of the case, ALP was 6.2 to 7.4 times elevated above normal. GGT was elevated. It was indicating liver-derived ALP. However, serological testing was all normal. Liver biopsy was normal. And so all the suggestions kind of went out the window, and we had to get creative. We had to really think about, what could this actually be? How do we go beyond what we're assuming ALP is so commonly known for? How do we look beyond that? And ALP is linked to many chronic inflammatory conditions, one of which is Hodgkin's lymphoma, of course. But when extrahepatic biliary obstruction and intrahepatic cholestasis are ruled out, of course those should be ruled out first, this may be an indication of an undiagnosed chronic inflammatory condition. And this may be one of the most early detections of it, because it's coming for the Hodgkin's lymphoma. This was a very early indication to be looking for it, and it results in the best case outcomes for the patients. And so I hope this has been helpful. I hope it's been able to show where the research is going with ALP, how it's being pulled together in a lot of different areas. And I just thank you so much for your time. If you have any questions or curiosity, please feel free to email me.
Okay, thank you.
Thank you.
We'll move on. Our next speaker is Dr. Sanjay Rao from USA. So I'm passing him the stage to deliver the speech on obscure overt gastrointestinal bleeding in the intensive care unit. So Dr. Sanjay Rao, welcome.
Hi, thank you very much. Thank you for having me today. Jonathan, that was an excellent talk, very informative, and it'll definitely change the way I practice. Let me just open up my slides here. Okay, hopefully you guys can see that and hear me okay. My name is Sanjay Rao, and I'm currently a third-year internal medicine resident at Jefferson Health Northeast. My program is located in Philadelphia, Pennsylvania in the United States. I'm also happy to report that I will be continuing my medical training in the field of gastroenterology at the University of Massachusetts in the US. The topic I want to discuss with you all today is that of obscure overt gastrointestinal bleeding occurring in the intensive care unit. I first came across this case a couple of years ago in the ICU when I was working as a first-year resident, and it was really interesting to me. And it was right around the time where I was starting to really become passionate about GI. And this case really caught my attention. And the way that the presentation is going to go is I'll do a couple of background slides, followed by the case that I experienced, followed by several modalities that we can use in the setting of GI bleeding, and then go into some of the algorithmic approaches that are seen in the literature. So as far as disclosures, I do not have any disclosures to report at this time. And then as far as my introduction, so, GI bleeding is something that is extremely common, whether you are a gastroenterologist, a hepatologist, a hospitalist. Pretty much everybody who works in the hospital comes across GI bleeding in some form or fashion. GI bleeding can carry with it an extremely high morbidity and mortality. And for this reason, some of these cases end up going into the intensive care unit, especially when they're more severe. When a GI bleed has no obvious source after investigation, usually endoscopy and colonoscopy, the designation is often obscure. And I think this is an important definition to put forth because it's not something you really see day to day when we manage patients. We don't generally classify GI bleeding as obscure, but it's a good moniker to have and a good way to hone down a definition and convey exactly what is going on with a patient. What's interesting is you can further classify obscure GI bleeding into two different forms. One of them is overt GI bleeding. In overt GI bleeding, what you have is blood loss presenting as melena, hematochezia, or hematemesis. Many times when we think of GI bleeding, we think of overt bleeding. And many of the times when we're working in the hospital, we really care more about overt bleeding because that leads to more acute blood loss anemia and acute shifts in blood pressure and clinical stability. You can further classify GI bleeding as occult. And occult GI bleeding is blood loss that's identified through more microscopic means. This is through hemoccult or FOBT testing. Many times, occult GI bleeding might be a reason a patient is initially admitted to the hospital. However, sometimes these patients, if there's no obvious bleeding, if they're not requiring transfusions, the workup for occult bleeding often is pushed to the outpatient setting. And many times the reasons for occult bleeding are things that are a little bit more chronic or span years rather than days. And for that reason, the outpatient setting is reasonable. In the case that I'm about to present, it is a complicated patient case with two short interval episodes of profound, obscure, overt GI bleeding that ultimately proved fatal. So here we have a 59-year-old male. He has a past medical history of anemia and prostate cancer, status post-prostatectomy, and he presented with 1 day of hematemesis. When you talked to him, he said he had one episode of hematemesis. He described it as painless and bright red, and that he's never had this before. He doesn't drink alcohol. He doesn't have any other GI concerns or cause or history, no family history of any GI malignancy, and he denies any melena or hematochezia, and he has no changes in his bowel movements. In the emergency department, the patient had another large volume episode of hematemesis, and due to the severity and the volume of bleeding, it was thought that he was unable to protect his airway. For this reason, the patient was subsequently intubated, and he was brought to the intensive care unit where I was taking care of him. I spoke to gastroenterology and discussed the case, and obviously they were concerned for the large volume hematemesis and the need for intubation, and he was taken emergently to the endoscopy suite. In the endoscopy suite, he underwent bidirectional endoscopy. In the upper endoscopy, he specifically had a small gastric clot. However, I spoke to the GI doctor at length about this, and he said that it is extremely unlikely that the small gastric clot was the cause for the episode of bleeding that we saw in the ED, and unlikely to be the cause of bleeding that he saw at home. The patient, like I said, had a colonoscopy at that time, and the colonoscopy was normal. There was no signs of active bleeding, and there were no obvious signs of old blood either, or any other pathology that could have caused this sort of bleeding. The patient was subsequently stabilized. He was given fluids. He did not require blood at that time as his hemoglobin was stable. And then he was subsequently transferred to a tertiary care hospital. The reason he was transferred to another hospital is that the initial hospital he came into was more of a rural community hospital that my program works at. However, it was thought that if he rebleeds, he might need further, more advanced treatment in the form of IR or surgery, which would not be able to be performed at the smaller rural hospital. For this reason, he was transferred to our flagship hospital. On arrival to the tertiary care hospital, he was noted to be slightly hypotensive, and a repeat CBC was done. A CBC at that time demonstrated a hemoglobin of 3.8. For this reason, he underwent a massive transfusion protocol, and this involved transfusing him 4 units of packed red blood cells all at once. There was no obvious signs of bleeding at this time, but due to the patient's change in clinical status, he underwent a CT abdomen pelvis with contrast. The CTA was negative for any abnormal bleeding, so we were unable to localize the bleeding at that site. Thankfully, this was on day 2. From day 2 to day 8 of the hospital stay, the patient was monitored. He was in the ICU for several of those days, but then moved to the general medical floor as his bleeding had resolved. Unfortunately, on hospital day 8, the patient became hypotensive once again. A repeat hemoglobin was performed, and it again demonstrated a profound drop in hemoglobin, this time to 5.1. Due to the hemodynamic instability and the severe anemia again, he required a second round of massive transfusion. So that would have been his second round of getting massively transfused. He was given another 3 units of packed red blood cells. At this time, gastroenterology was called once again. They had been following along before, but since he had not been bleeding in the prior 6 days, they had started to mentally sign off. We spoke to gastroenterology again, and because of the likely cause of his hypotension being another gastrointestinal source, as there was no other obvious source, the GI doctor took him back to endoscopy, and the patient had a push enteroscopy at that time. Push enteroscopy did not show any active source of bleeding, and that prior area where there was the small gastric ulcer was not actively bleeding either. Because of the negative push enteroscopy, the patient underwent a CTA angiogram, which again was negative. Again, no bleeding source was localized. Lastly, because the patient remained clinically unstable, but no bleeding could be identified, the surgical team was looped in. We spoke to the surgical attending and discussed the case. and the patient had emergency surgical exploration of their small bowel. Unfortunately, no area of bleeding could be identified at that time either. After surgery, the patient was taken back to the ICU and continued to be treated, but despite aggressive resuscitation and the extensive investigation that we had performed, unfortunately, the patient continued to decline. The patient remained in the hospital for another 48 hours, and the patient was treated medically with blood and fluids and pressors. The patient was ultimately transferred to comfort measures and passed away shortly after. So, what this case demonstrates is an example of a patient with multiple episodes of obscure overt GI bleeding in the ICU. And I think this situation is quite unique because after going through the literature, when you see these cases of obscure overt GI bleeding, they generally present more so with melena and hematochezia rather than hematemesis. And in this case, this person came in with hematemesis at home and observed hematemesis while in the emergency department. And I think the reason for this is that many of these cases of obscure overt GI bleeding occur more distally, and that's why they're harder to generally be found on endoscopy or push enteroscopy. Unfortunately, no clear-cut source of bleeding was found in this case, and that's difficult, right, when you don't have an answer in medicine. But it is clear that this was obscure overt GI bleeding, and that the more likely cause of bleeding in this case, just based on epidemiology and what's most common, is likely that of a vascular ectasia. So that's something important to keep in mind when you come across these cases. When I had this case, I thought about it a little bit more and tried to figure out, what more could have been done? What could I have done differently earlier on in the hospital course? And what should our approach be in these cases? As you can see, many different modalities of diagnosis and therapeutics were employed. However, nothing was successful. And it made me think, is there a stepwise approach to this? And after looking through the literature, there's no real standardized approach that I could find in the US or internationally that has been successful. And that is the gold standard for management of these bleeds. And, that kind of brought me to thinking, what would that be? What interventions will we do and in what order? And it made me think about what the different interventions we had as gastroenterologists at hand to manage these bleeds. So, for the next couple of slides, I'm going to go over some of the modalities that were used both in this case and the techniques and procedures that are used in general to not only identify but treat bleeding, obscure overt bleeding specifically. One of the main ones that was done in this case is push enteroscopy. And push enteroscopy is an excellent modality to use for small bowel investigation because it allows you to visualize much more of the small bowel than a common upper endoscopy will do. Generally, push enteroscopy is utilized once an EGD is negative and you need to see more of the small bowel. The push enteroscopy employs either a dedicated video enteroscope or a pediatric versus an adult colonoscope. I've personally seen a pediatric colonoscope used more. And this allows for direct visualization of the mucosa. Specifically, these devices generally allow us to see around 50 to 100 centimeters past the ligament of Treitz, which makes it better as far as investigating the small bowel as compared to upper endoscopy. In general, the diagnostic yields are quite variable, between 26 and 80%, depending on where you look at the literature. The limitation with the push enteroscopy, however, is that you are unable to visualize the distal small bowel. As we see in our case, we did a push enteroscopy. However, no obvious source of bleeding was performed. So it was likely suspected that the bleed was somewhere after 100 centimeters of the ligament of Treitz, but but before the terminal ileum. In addition, the push enteroscopy has several complications associated with it, like mucosal damage and perforation, its risks are higher than an upper endoscopy because it is a little bit more aggressive in nature. The next modality I would like to talk to you all about is the upper GI series. An upper GI series with small bowel follow-through is an extremely safe option that's generally available, at least in the United States. It's extremely cost-effective, and it's very well tolerated by patients and readily available in hospital centers. It involves the consumption of oral contrast like barium in concert with fluoroscopy, and this allows for real-time imaging. What it really allows us to do is identify active bleeding zones, which can later be targeted. Unfortunately, while this study is safe and available, and the diagnostic yield of the study is extremely low. As you can see on the slide, the diagnostic yield of the upper GI series, depending on the literature, for finding active bleeding in the setting of an obscure source is 0 to 6%. So it makes you consider, is this even worth doing or not? And in addition, the upper GI series is just a diagnostic study. So even if you are able to localize the bleeding, you have to come in with a therapeutic intervention afterwards. The next modality I want to talk to you about is the video capsule endoscopy. This is something that's a little bit newer, but there is a little bit more data out. The video capsule endoscopy can serve as an additional tool for detection of culprit lesions. Specifically, what it is a small pill-sized camera that the patient swallows, and it takes pictures through the entire GI tract from mouth to anus. And those images are uploaded to a storage device and then later read by a gastroenterologist or hepatologist. With this video capsule technology, what we're able to do is allow for direct visualization of the entire GI tract, something which was a shortfall of upper endoscopy and push enteroscopy. In addition, what we see is that the diagnostic yield of video capsule endoscopy is very high, around 92%, which is excellent, especially when you think the small bowel follow-through barium swallow is 0 to 6%. This is a much superior study. The limitations, however, with video capsule endoscopy is that it is diagnostic only. You might be able to localize a bleed. Furthermore, it is very difficult to assess where the active bleeding is, even if you see it on video capsule, because the actual area that the capsule is not obvious and cannot be localized to a single inch or centimeter of the bowel, but rather to a general zone of where we think the capsule has gone based on time transit. In addition, many times I've seen that this modality is used primarily in the outpatient setting. And sometimes, at least in the United States, this is generally due to an insurance issue. And lastly, this still is a newer modality, and there's limited data on its use, both in obscure bleeding and in other forms of bleeding, and whether it is used in other GI pathology as well. Looking at the two images on the right, figure A demonstrates normal mucosa, and you see the villi standing upright, and there's a nice pinkish yellow hue. Whereas the image below it, labeled D, that is a source of active GI bleeding, and that's what we would try to figure out and hone in on. The next modality is the nuclear medicine tagged RBC scan. This is an excellent modality that uses technetium-99 labeled RBCs to visualize bleeding rates. Like the upper GI series that I discussed before, is both safe and available in healthcare centers. In general, the rate of positive tagged RBCs for GI bleeding is somewhere between 26 and 78%. However, it comes with several severe limitations. First off, there's limited efficacy and limited data on the nuclear scan. Next, it has an extremely high false positive rate. And this is a reason why many clinicians actually do not use this modality. The reason for the high false positive rate is generally due to pooling of blood in the bowel. And lastly, it comes with a high false negative rate as well. And this is thought to be due to the intermittent nature of GI bleeding, and you just can't quite capture the timeline of GI bleeding. Therefore, especially with this modality, the risks and benefits really need to be considered, because you might end up chasing a bleed that's not there, or you might end up getting that false positive as well. And moving on, the next modality I wanted to talk about was balloon enteroscopy. This is definitely something that is much more newer in the literature. Balloon enteroscopy can aid in both diagnosis and treatment of obscure overt bleeding. Specifically, balloon endoscopy uses adjustable and inflatable balloons to advance an endoscope deeper into the GI tract than normal enteroscopy or even push enteroscopy. More importantly, it allows for complete visualization of the entire small bowel, along with therapeutic capabilities with it. While it is a great tool to have, this modality, I've seen it myself, is extremely operator dependent. Many gastroenterologists are not accustomed to this technique and do not have the procedural volume to acquire expert skill. In addition, it is very hospital system dependent, as some GI departments do not equip this specialized endoscope. Lastly, due to its ability to anchor to the mucosa to propel the endoscope forward, it comes with its own series of complications like mucosal damage, laceration, perforation, and several other severe major complications. So while it is excellent in viewing and visualizing the small bowel, it also has its own complications that it comes with. And the last modality I wanted to talk to you all about is the intraoperative enteroscopy. This is something that I don't see happening very often in our own hospital, but it is an orally passed colonoscope or dedicated video enteroscope with a surgeon who telescopes the small bowel over it. The second approach, as can be seen in the picture on the right, is insertion via an enterotomy site that the surgeon makes, and again, telescopes the bowel over it. The yield of this modality is extremely high, around 50 to 100%. However, obviously, this is the most aggressive of all the interventions that we've seen. This is an intervention that we did in the case that I detailed as kind of a last-ditch effort after we had exhausted upper endoscopy, colonoscopy, push enteroscopy, and CTA. And it was really kind of a Hail Mary. The problems with intraoperative enteroscopy is its high mortality and morbidity with doing the procedure. You have complications like mucosal trauma, laceration, perforation, and you can have other complications like ileus and abscess formation, and also small bowel ischemia. So, we've gone through several of the modalities that are used. It makes you think, right? Like, what is the proposed stepwise approach for these cases? And, going through the literature, I wanted to talk about three of them that I thought were of particular significance. The first one that came to mind was by Grolnick and co. in 2005 out of the American Gastroenterology Association. And what they propose is, after a normal upper endoscopy and colonoscopy, that's when you would get to that first bubble of recurrent obscure overt GI bleeding. And what they recommend is repeating an upper endoscopy if the patient rebleeds, which is what we did as well. They also recommend repeat a colonoscopy with intubation of the terminal ileum as well. And obviously, if any bleeding is found and treated, you're going to stop at that point. However, if no source is identified, then they recommend going back and performing a push enteroscopy at that time, which is what was performed in the case. Well, interestingly, what they recommend is, if a push enteroscopy is negative, performing a small capsule endoscopy and a video capsule endoscopy. It allows you to see that small part of the bowel that push enteroscopy could not get you to, especially when double balloon endoscopy is limited. And finally, if that is negative, then they recommended an intraoperative enteroscopy. For lesions that are beyond the reach of push enteroscopy, when the capsule is positive, then you would perform intraoperative enteroscopy as well. So you're going to perform it regardless of capsule result. And this is more or less in line what was performed at my own hospital with my case. However, we did not perform the video capsule endoscopy because we simply do not have it available on the inpatient side. The second algorithm that I saw that was quite fascinating to me was one out of the Japanese clinical practice literature. And this came out in 2017. And while the slide might look a little busy, if you follow the arrows, it actually makes sense. Starting in the right upper side, you have an upper GI endoscopy and colonoscopy to look for bleeding. Then only once we do that can we diagnose it as an obscure bleeding. And in this case, it's overt and occult. They recommend in Japan to do a plain and contrast enhanced CT from the chest to the pelvis. If you have abnormal findings on the CTA, they recommend a balloon-assisted enteroscopy or further angiography, which is a coil embolization by IR. And those are some things that were not performed in my case. However, if there's an absence of abnormal findings, they also agree with Gralnick to do a small bowel capsule endoscopy. And if that's again negative, they do recommend a nuclear or a Meckel scan at that time to look for bleeding. And then those all reflex, if negative again, to a balloon-assisted enteroscopy. So the workup is a little bit different, and I want you guys to see what the different approaches are and the stepwise thinking in each of these approaches. The last algorithm came from Liu and company in 2011. And what I want you to take away from this is, again, there's a flow chart talking about obscure and overt GI bleeding, but this one is a little bit less specific and a little bit more general. What we see is in massive overt bleeding, you can use enteroscopy, angiography, or surgical consolidate, and they don't necessarily place it in any specific order. The abbreviations are in the top right of the screen there. What they do recommend is in the obscure GI bleed cases, they recommend a capsule endoscopy. And if positive, then going to embolization or endoscopic therapy or surgery. And if negative, then what you would do is just maybe monitor the patient for ongoing bleed and then repeat one of these studies or go for a Meckel scan. Or interestingly, they recommend a hematology referral if there's any problem with coagulation. You guys can follow kind of the rest of the flow chart, but I just want you to see the different approaches by different people in different countries and how this one is a little bit more broad and gives you several different tools at each step, whereas other ones I think are a little bit more helpful and tell you exactly which modality to use in which situation. In conclusion, we see that obscure overt GI bleeding can be extremely difficult to identify and even harder to treat. What we've done is gone through diagnostic and therapeutic interventions that are available to most practitioners, so you know what's at your disposal. Each modality harbors its own risk and benefit and therefore must be considered for each patient specifically. Lastly, we went through several approaches on how obscure overt GI bleeding can be worked up in the hospital. My goal is to give you the tools and knowledge depending on your own area of practice and expertise to systematically approach difficult bleeding cases. The research on this topic and in the field of GI is constantly evolving, and new management approaches are constantly being published. However, the future for GI and management of these complex bleeds are very bright. Thank you very much for your time.
Yeah. Thank you, Dr. Sanjay, for your excellent presentation and enlightening speech. Now the topic is open for discussion. Any questions? Okay, thank you, Dr. Sanjay. So moving on to our next present speaker, Mr. Bernard Gauthier from USA. So I'm passing him the stage to deliver the speech on digital transformation.
Welcome. I will share my screen.
Yes.
We will today make a presentation with two people, that means me and my friend Michael Tartar, we CEO and founder of DMAP. And for today, what we will show to you, first of all, the digital transformation in pharma, in big pharma, what at stake for big pharma, and then we will talk about digital maturity model, and this will be performed by Michael. Let's start with digital transformation in big pharma, what at stake. A quick disclaimer. All this sharing, discussion, and exchange are only my opinions. It's not Sanofi official communication. I want just to be, all of you, make sure of that. Okay, now digital transformation. Just perhaps start by recalling what is digital transformation. And digital transformation is not, let's say, moving from a written letter to a PDF or a fax to an email. This is not digital transformation. This is digitalization. Now, what at stake with digital transformation? Okay, it is leveraging everywhere, anytime, and it's come from never-ending communication. That means internet seamless communication with it, all the networks, Wi-Fi, 3, 4, 5G, Bluetooth, NFC, and so on and so forth. It is the creation of new device, smartphone, that is not so ancient, for IoTs, wearables, and all the device we can find, and especially medical device, communicant or medical device in global health. The raising of new habits, new usage, e-business, social networks, now telemedicine, and for since let's say recently, home office for everyone, tracking everything and thus computing this new ocean of data. All these points allows us to make a digital transformation. And what it implies, it's you have to change your processes and your ways of working. You have to generate and use this generated data. You have to change your purpose and product, or perhaps create new ones. And especially, for example, if I take examples, in this case, in big pharma, we have the quality end-to-end that we could change our ways of working and processes. We have, for example, either all the pharmacovigilance that could be that could leverage digital transformation to be more efficient, going more smoothly. And for example, for the purpose and the product, we have what we call drug plus. That means going beyond only delivering a drug. That is connected solution, that is digital therapeutics. All these opportunities are given by the digital transformation if you are moving to real digital transformation. Now, let me recall what is the purpose and the activities of a big pharma. First of all is to invent. It's the first step. Inventing, that means you start from a disease. With the biology, clinical trial, literacy, you move to thousands of molecules, and then you finish on one drug. Then, working with health authorities and regulators, from one drug, you move to one treatment. And then, second step of the pharma company activities, industrializing. That means that with using supply chain, manufacturing, logistic, you start from one treatment to go to one product. Then third part, that's commercializing. And you start from one product, and then with marketing, medical studies and communications, and field for fees, you finish to one prescription. And then with HCPs and doctors, you move to one prescription, to one medicament for one patient. Now, we will focus on every step of these activities where digital transformation can bring opportunities. Is a focus on every of these activities. avoid inventing, okay? Inventing on the disease, you could use artificial intelligence for computing research literacy, for computing disease figure and patient profile, just to ease you working on a disease and starting to imagine what is at stake regarding all the molecules involved and the drugs involved, just to find perhaps one molecule you could start, one kind of molecule you could start to, let's say, deep dive on it, just to know if you could use it as a treatment in the future, okay? Now, for example, moving to the molecule steps, you could use artificial intelligence, what we call in silico R&D, just to design molecules and their isomer. That means one molecule could have hundreds of similars, and using AI helps you to design it. That means that it's new, because before you have to perform and develop every molecule with the chemistry, instead of just references all the possible isomer and similar molecules. Same thing, you could simulate the behavior of this molecule. That means you stay on the computing facilities to image what could be the behavior and the interest of this molecule. Then you leverage digital to move forward from this thousands of molecules to one drug. That means remote clinical trial follow-up, patient targeting for this clinical trial, wearables and biomarker to ease the follow-up of the outcomes of this molecule, and all the documentation, accuracy, and quality that you will leverage. And part of this document is all the data generated within this processes to be able to move forward to the healthcare authorities and say, hey, I discover a molecule that could, let's say, have a positive impact on this disease for this kind of patient. Then, last one, working with the healthcare authorities and regulator, you have all the documentation and the data, accuracy, traceability. You could leverage all the usage and side effects. You could, let's say, make some seamless agreements workflow, working with these authorities. And sometimes you have a lot of authorities from European Union, from FDA, from other countries. All this could be leveraged with the digital. Same thing, you could bring some and perform some simulation on the patient population, on the impact, global impact, the financial impact, or the financial aspect. That means what at stake regarding launching this medication. All that stuff will allow you to launch this treatment on the market. Let's move to second part, industrializing. Okay, you start from the one treatment and you go to one product. Okay, you could leverage artificial intelligence in simulating molecule creation process. That means that one moment you have discovered a molecule that could be very useful for a disease, and you have to industrialize. That means perform and create this molecule at larger scale. Okay, sometimes you have to simulate the process to see how you will industrialize this process. Same thing, supply chain means using artificial intelligence, all the computing, machine learnings to forecast the component needs, optimizing the deliveries, optimizing the supply follow-up either. That means smoothing in a way your ways of producing this molecule. Manufacturing, same thing, using digital with what we call industry 4.0, IoTs, virtual reality, AI for predictive maintenance, serialization, ERP and production just-in-time management, all could be leveraged with digital. Same thing with the logistic, warehousing, order and delivery management, product follow-up. And if I focus on the last one, commercializing, you start with the product to prescription. You could use artificial intelligence to market survey, for marketing teams. Patient profile, you could use digital for omni-channel communication, for e-business when it's not under prescription, but OTC. For medical studies communication, you could use artificial intelligence for the literacy, just to perhaps find some studies, new studies purpose and expected medical claim. You could have the multi-treatment impact. Digital could allow you to work remotely with patients involved in studies, using IoT wearables, optimizing all the pharmacovigilance and the quality follow-up. Same thing for field forces. That means all the people from pharma companies that are in front of the HCPs, targeting HCPs, performing webinars to share the let's say content and explain the value and the ways of working of the new treatment. A CRM to follow up your contact with every healthcare professional. Tablets when you're visiting an HCPs, and to let's say for regulatory constraints, for example in France, to follow up and register all the extension you have with HCP. Now, I let the floor to Michael, just for him to present DMAP and the maturity, the data digital maturity.
Thank you, Bernard. Do you want to keep pushing the slides for me, or do you want me to?
Yes.
To do it? Okay. So thank you very much for this introduction. We have seen a lot of opportunities regarding digital in each steps of the value chain in the pharmaceutical industry. Maybe you can switch to the next slide. I just want to emphasize that if you want to leverage all those technologies, each company has to have a deep comprehension of its digital maturity, which means you don't just have to deal with the technology and get it to solve some problems or to get some opportunities, but you have to consider technology as part of something more global. That means digital maturity. Can you move to the next slide, Donna, please?
Yes.
I'm not sure I can do it myself. No. Okay. Next slide again. Okay. Thank you. Okay. So what you will want to do if you want to leverage all those technologies, you want to consider your maturity at a 360 degree. So which means that first, can you push the button, please? Okay. First is a strategy. The first one is you want to consider how your digital strategy is built, so then you support the strategy of the company. The second phase, the second level of your digital assessment is you want to understand what are the structures inside the company, because you don't want to have those technologies alone. You want to have them inside, and you want to make them bring value to the company, even if the employees are moving. The third one is the employees themselves. You want to be sure that all those technologies are well used by the personnel of the company, and you want to have everyone use very efficiently all those technologies. So you want to train them, you want to be sure that they use them appropriately on their daily job. The fourth one is the offer, which means that what you want to understand how your offer is designed and distributed via digital. So which means that you want to innovate, but you also want to sell, you want to market your offer and use and leverage digital for that. And you want to understand that deeply. The fifth one is the technology, which means how you use technology and any solutions to support any stakeholders. Those stakeholders could be internal, for example, your employees, but it could be also external. That could be your partners, your clients, and anyone involved in the data that you will produce. and the services that you will provide to anyone. And the sixth one is the environment in which your company is working on. And you want to understand how your company apprehend this economic, regulatory environment related to digital, because you have many regulations all over the world that you have to confirm to if you want to be on the digital stuff. Thank you. If you want to consider all those aspects, what we suggest is that you screen your company regarding the 150 indicators that will help you assess your digital maturity. Because, for example, on the strategy, on the digital strategy, if you want to understand how is your digital strategy done, you want to go deep inside, and we suggest to focus on 13 indicators that will help you understand how at which level you are ready today to build your strategy. If you, I won't detail too much on today on that slide, but you understand the principle. This is that if you want to evaluate your ability to go to digital, you just want to go through the 115 indicators that are presented here. Okay, and if you move to the next slide, I just want to emphasize the DMUP.com platform that will help you do this diagnostic. You have to measure yourself against these 115 indicators, and you will realize that the platform will adapt itself to the different type of companies, the size of the company, and country where the company is. The second aspect is the benchmark, which means that when you evaluate the company regarding its digital maturity on each of the 115 indicators, the platform will give you the steps that you have to do if you want to be better on each of the aspects. And for the premium subscribers of the platform will give the position of the company regarding this indicator in comparison to its market. So this means that, for example, a pharmaceutical company in any country in the world will be compared to that same size of company on the same industry in the same country in the world. The third step is that you will be able to manage your digital transformation, because you will get from the DMUP.com platform, you will get some steps, some action maps that will help you move forward and increase your digital maturity. The fourth value of the platform is that you will transform inside the company, because as I said, 115 indicators is very much, and you see that we have a broad aspects to cover, but you have to consider that all those indicators are built in the same way with 5 levels of maturity. So which means that even if you talk about HR, IT, marketing, sales, you will be evaluated against those 5 levels of maturity, which means that it accelerates the discussions between the different stakeholders inside the company. And finally, the tool is I don't know if we have consultant here, but for consulting firms, it's very useful to use that tool to evaluate the digital maturity of their client. And if you move to the next slide, please, Bernard, can you? Oh, thank you. If you want to understand how you can use all this platform, you will see that we have 3 different methodologies that you can combine to evaluate the digital maturity. So you have here the tutorials. I'm sorry for now they are only in French, but if you want to learn that language, that will be the good opportunity, and you have the subtitles, and soon we will provide them in English. Can you, and you at the top left, at the top right, sorry, at the top right of the slide, you see a QR code that will send you to a small presentation in English of the platform, so you can learn more if you want to, if you are interested to do it. But the good news is that you can do it today, and it's free, and the platform is in English. So if you want to evaluate your company, you can do it for free right now with the discovery plan. I don't know if you can switch to the next slide. Yes, just some sample screens so you can have a look at the platform before you move forward. And that's all for me. I think that I have covered it very fast, but I want to let people ask questions. Maybe if you have some questions that would be fine for Bernard and I to answer your questions.
Yeah. If you want some if you have some questions, even other in the opportunities of digital transformation for Laban pharmaceutical company, or what at stake regarding the digital maturity assessment, please take the micro, or perhaps type it in the discussion chat.
Okay, thank you, Mr. Bernard, for your enlightening speech. Now the topic is open for discussion. Any questions?
Don't be shy. Huh? Every time the first question is the hardest one, but once questions, then we can move forward.
Maybe I can ask questions if no one asks a question. I would ask a question to you, Bernard. If you would do a diagnostic today, how would it be useful for your company to do it? Using a digital diagnostic on the process or country, or maybe a BU of your company?
I think that the most useful would be starting from the strategy, just to have a look of how globally the company is looking about moving forward with the digital transformation. And then we can deep dive, let's say, activities by activities with the whole aspect.
BU by BU or process by process?
BU by BU and
BU by BU.
By main activities, for example, what can bring digital maturity, for example, in manufacturing is not, let's say, it's transversal regarding all the BUs related to the market, but it's very useful because, okay, what is related to manufacturing will help manufacturing, but it's really focused on manufacturing. That means that's why you start with the strategy, make your own assessment for the whole company. That means either as you present maturity of the leaders of the company, are they ready to move forward and shaking the company, because digital transformation is shaking either a company, and this shaking will lead us to new opportunities, especially in pharma. For example, a big outcome of digital transformation is what we call digital therapeutics. That means moving from drugs to using digital tools to create new treatments without any drugs. No drugs, but treatments, yeah, and you could measure outcomes. The second one, a very important benefit of digital transformation, is all about the data. And especially as it is a very high regulated environment. For example, a clinical trial, it's hard to put people into a trial, but you could use real world evidence, real world data. That means that you use connected solution to follow up a patient in real life, and with a massive amount of patient followed with the treatment, having perhaps other treatments, you could have a better idea of your treatment, the outcome, let's say the risk of using with other treatment, and all this data could allow you to find new medical insights, a new benefits. That's why digital transformation leads to new treatment, virtual one, digital one, plus data that you could leverage and reuse to improve this treatment or find new ones.
And that's why you said that first is strategy, because if you want to make that move, you need to have the top managers of the company to be involved in that move.
Yeah, because it checks really pharma.
It checks a lot. Yes,
really, yes, it checks a lot, and all the big pharmas are facing the same issues regarding digital transformation. When I'm discussing with peers, I realize that we all face the same issues. It checks a lot, and it's hard to have, let's say, a leadership committee that is ready to shape the company.
And that's one of the aspects that we cover in the digital maturity model that we assess with DMUP.com. This transversality and the way we shake the company is one of the aspects, and that's why I built that tool, so that people understand that while we shake the company, we still manage it. We're not just shaking for shaking. We are shaking to transform it to do another business, another way we do business.
Yeah, and it allows then after that to shake, let's say, very precisely.
Exactly.
And that makes a more smooth shaking, as if I could say like that. And then it's better to commit people and involve people.
True.
Is there some other question from the audience?
I have a question. Can you hear me?
Yeah.
Okay. Very good presentation, Bernarda and Michael. Tell me, in your opinion, how you define pathology informatics and digital pathology?
Let's say we are more working on
the tricky question.
Yeah. In fact, there's two things. First of all, we are working more when we are talking about digital therapeutics on therapeutics, not on the pathology. That means that we are more focused on the outcome. But I was mentioning the artificial intelligence for the literacy, because when we are talking on the pathology, leveraging artificial intelligence allows you to use all the data produced by all the peers, all the doctors, and the data from every patient, just to be more accurate in your comprehension of the disease, of the pathology. And then it allows you to move forward to imagine some treatment, because you, first of all, will work on the patient level, on the pathology level, on the molecule level, and all these different levels. That means, in a way, you're moving around this pathology to find where you could have an angle to start to fight this pathology. That means perhaps treat the pathology or treat the patient, that easing its own life. For example, I'm working a lot and principally in the therapeutic area of the diabetes. And we know that, for example, we could help the patient treat, let's say, the consequences of the disease of the diabetes with insulin, but we could either bring some services to the patient to ease the harness, the burden of the disease. That means, for example, helping the follow-up, helping adapting the treatment, helping perhaps the glycemic measurement with new kind of device, with continuous blood glucose measuring. All these things are part of the strategy you could have regarding the pathology, and using the digital, because you have a lot of data, and all this data could help you to find new ways, new medical incomes, and perhaps then move to the medical field to see if what your data seems to give some relation could be proved with medical, with clinical, with a real clinical trial.
Thank you.
My pleasure. I hope that helps.
Yeah, thank you, Mr. Werner. Now moving on, our next keynote speaker is Dr. Michel Britzke from USA. I'm passing the stage to deliver the speech on discussion of Brodsky 2022 and how to prevent lab relapses. So well.
Yes, hello. I sent my slides in, PowerPoint slides. Can you show them for me, please?
So can you unmute yourself? Dr. Michel, can you unmute?
Okay, can you hear me now?
Yeah, sir.
Okay, I sent my PowerPoint slides in. Can you start showing them? I need to get the my end of the things showing. Just a second.
Yes, sir. Yes, Dr. Michel, you can go ahead.
Yeah, I'm trying to get the slideshow.
Yes, yes.
I can't see the screen right now. Wait a second.
It's visible. We have shared your screen.
I can't see it from my screen. Just a second.
Yes, yes.
Sorry, I'm having trouble here. I'm sorry, I'm still having trouble. Permit me a few minutes. I'm having trouble getting Zoom up on my screen. Just a second.
Like already we sir, already we have shared a screen, sir. It's visible.
I cannot see the screen. That's the problem. Just a second. For some reason, I'm having trouble getting to Zoom. I am not getting there.
So can you go to that option left, share screen?
I'm trying to.
Yeah. in that shared screen, you can open the PPT and you can share that like a screen.
I'm sorry, I'm having trouble.
Dr. Michel, you are the PPT, right?
I'm having trouble getting to the screen for some reason.
Okay. Okay. Sir, if you are unable to like share the screen, we will share the screen. Just you can see that screen.
I understand that, but I'm having trouble at my end.
1 second, Dr. Michel, like we are sharing the screen.
My computer is not being cooperative. Oh, here we go. I joined from the browser.
Yeah, can you able to see the screen now?
Not quite yet. I have to sign in through the browser.
Okay. Can you open the home page of this Zoom, sir?
No, I cannot. I'm having trouble. I had the thing disconnected and I'm having trouble getting it operational.
So you are reconnecting it again?
I can't get the Zoom meeting on my screen so I can see the. Well,
like
I'll just have go ahead. Go ahead and start showing the slides.
Yes, I already started showing the slides, sir. You can see the screen. The slide is displayed.
I can't, that's the problem is I cannot see the screen. So I can hear you and I know that you have the slides up. So I'm gonna just start talking as if I am seeing the slides. Just a second here. Okay, breast cancer in a perioperative window. Is that the title you have?
Dr. Michel?
Is that the title on the first slide?
Yes.
Breast cancer and the perioperative window?
Yes, this is the first slide.
Okay. All right. I'm at University College London. My background is unusual. I have a PhD in experimental physics, and I ended up making a career change into oncology research. Next slide, please. Project was funded by NIH and the Komen Foundation. There is one patent pending and no other conflicts to report. A book was published by Thomas Kuhn in 1962 that got a lot of interest among the scientific community. Kuhn said that any science has 4 distinct phases. When it first starts out, it's new, called a pre-paradigmic phase. It's a situation where there's no consensus among the different people doing this research on what the mechanisms are, what books to use, what names to use. After a while, this eventually becomes normal. People agree on what the mechanisms are and how to do research. This is called normal science, and that could stand like that for a long time. But once in a while, you run across an anomaly. You run across data that are not explainable by this normal science. In this case, the science can go back or forward. If someone someone a little smarter than the other guys can say, well, I can make a minor adjustment in the mechanism and show that this is very close to normal science, so it's not a crisis. Okay, and then that's all right. But if no one can find a way of explaining this anomaly in terms of normal science, then they have to consider that this might be a revolution, a paradigm shift. Okay, let me go on. I edited a book with Romano Demicheli that was published by Springer Nature in 2018. This is 2017. Perioperative inflammation is triggering origin of metastasis development. And for some reason, I ended up getting a picture of this book being advertised on the front page of the New York Times. So I had to take a picture of that. The book, that textbook I just wrote, it's described, there was a foreword written by Robert Weinberg. Weinberg is a very well distinguished researcher in oncology. He is probably the most authoritative person in the world of oncology. And he said in the foreword to this book that he thinks that this notion is not likely to be accepted by many in the clinical community oncology. And what we say in that book is that surgery can cause a relapse, that it's like surgery causes cancer to spread. And this was not well received. Weinberg said this is likely to profoundly influence future surgical oncology and post-surgical treatment protocols. Well, let's see what's going on. Now, next slide. This project actually started in 1993. Are you on the fifth slide, the sixth slide? Data presented in 1993. That should be number 6. Data were presented by Romano Demicheli in 1993. I was attending a cancer conference in one of the cities in Europe. I forgot which city it was. And out in the hallway, I saw a poster presented by Romano Demicheli of the Milan National Cancer Institute. And it caught my eye because the data that Demicheli was showing was a bimodal relapse pattern. I had not seen that before. There were 2 peaks of relapse in patients treated, no chemotherapy, just surgery only. I was fascinated by that. And then I walked into the lecture hall and Michael Baum, a surgeon from UK, was talking about the bimodal relapse pattern in UK. Well, we all got together afterwards and confirmed that they were talking about the same thing. The Milan data are by far more superior, so I'm going to focus in on that. There were 1,173 early stage breast cancer patients with long-term follow-up, mastectomy only. There's a sharp peak at about 18 months after the surgery, the minimum at about 50 months. And then that was followed by a broad shallow peak, 60 to 70 months that had a long tail extending to over 10 years. This general pattern has now been identified in over 21 databases from US, Europe, and Asia. Next slide. The quality of Milan data. I have a lot of experience with databases in breast cancer. And I must say the Milan data are the best I've ever seen. And if I had to tell you what were the reasons why the Milan data is really high quality, I would say, first of all, patients in Italy typically comply with physician directives. So when the physician says, do this, that's the patient does that. The second thing is that people don't move too much. They stay in the same cities and towns for over generations. So because of that, there are few patients lost to follow-up. The third item is Pinuccia Valagusa has long been a database manager. I happen to have spent some time with Pinuccia Valagusa. She is a very competent lady. I've seen her give lectures in front of 2,000 medical oncologists. She knows her subject, and she is a very competent database manager. So because of these three things, I have confidence in the quality of the Milan data. Okay, the next slide I'm showing, this is it's the 8th slide. This is the slide, this slide shows the Milan data in postmenopausal patients. This is in the form of a relapse hazard. Hazard is the probability of a patient entering a window 3-month wide in this case, entering this window relapse-free and then undergoing a relapse during that 3-month window. So in this relapse hazard, there is a peak at about 18 months and then a minimum at about 48, 50 months. And then that broad shallow peak, 60, 70 months going out to 10, maybe more years. There's something happening maybe at about 100 months, but that might be noise or it could be important. Okay, these are the same data, but for premenopausal patients. It's different in that that first peak seems to show up as 2 peaks. There is a peak at about 10 months, a sharp peak at about 10 months, and then another at about 30 months. The rest of the data for the premenopausal patients is the same as the postmenopausal patients, but there's a distinct difference between the postmenopausal and the premenopausal patients. Next slide. Okay, these are data, Milan data, but presented in the more normal disease-free survival format. Bonadonna Valagusa. Bonadonna is a well-known person in breast cancer. He's deceased now, maybe 10 years, but he was the first person to use multiple drugs in treating cancer patients after surgery. He's very well recognized, and it's a very important name. And Valagusa was also a co-author of that Bonadonna paper published in the New England Journal, 1995. You can see that there seem to be 2 sections of this disease-free relapse format that looks like they're not the same thing. That first drop starts off at everyone's disease-free at time 0. And then down at about 5 years, it reaches a plateau. Seems to be a minimum number of new relapses. But then it seems to start again at 5 years. And then it drags on. So it looks like there are 2 different populations that show up as relapse in breast cancer patients in the absence of chemotherapy. Pretty interesting. We'll see what happens later. Okay, this is another paper that was pretty interesting. Bernie Fisher. Fisher was the person who first proposed that you can do a lumpectomy instead of a mastectomy if you follow it up with some radiation. He died some years ago at age 101. By the way, I happen to personally know every one of these people. The ones who are alive and those who are gone, I knew them while they were alive. This figure from Fisher was published in 1984. All this is before the routine use of chemotherapy. And these are relapse-free, disease-free survival and grouped by the number of nodes positive. The curve on top is for 0 nodes positive, and the curve on the bottom is for more than 12 nodes positive. Now let's look at the 0 node positive curve, the one on top. This says that if a patient is determined to have breast cancer and the physician just removes the primary tumor, 80% of the patients will be cured. 20% of them will relapse, and that's it. They will never relapse after 20 years, after 120 months, 10 years in this figure. But it looks like there are 2 phases. There's the first phase in the first 5 years, and that seems to be a flattened area. and then it starts up again, and it goes into a very slow decay, maybe down to 7-8 years, where it seems to become flat. But now let's go down to the more than 12 nodes curve, the one on the bottom. And the bottom curve does the same thing as that 0 node population curve, but the numbers are different. There's a period at about 4 or 5 years where that first relapse area seems to stop for the 0 node population. And the same thing does for the more than 12 nodes population. But while only about 10% of the patients relapse with 0 nodes in that first, say, 5-year period, but there are probably 80% of them in the more than 12 nodes that relapse in that same time. But the difference between the 0 node and the more than 12 node is not in what happens, but in the magnitude of what happens, how often it happens. Something is going on that tells you there's something common between the 0 node and the more than 12 nodes. Okay, next slide. This, in general, you can make the statement that this was not explainable with the continuous growth model that has guided early detection and therapy of breast cancer for many years. Okay, Demicheli and I decided to try and understand what those various peaks were. Yeah, my background is in physics. I got to be pretty competent in the use of computer simulation. You're showing that figure with the triangle in the middle, I presume. Should be anyway. My contribution to the sciences and computer simulation. I did a lot of work trying to understand tumor growth by using computer simulation. I had a lot of time. It took me about 5 years to figure out what's going on. And I got quite competent in using computer simulation to examine cancer growth. So the idea that Demicheli and I had was we were going to take the Milan database, the Bonadonna-Vela-Gusa database, and my computer simulation skills, and take a growth model that Demicheli proposed. He said he has an MD PhD. He did a lot of work with studying tumor growth. He said the most basic description of cancer growth is it starts off as a single cell. It can remain dormant for a variable period of time. And then all of a sudden it can start to go into a division, and it can get to a point that avascular micrometastases. It can get to the point where you get to be about 1 million cancer cells in this little clump. 1 millimeter in diameter would be the clump. And it can't get any bigger than that until it gets a blood supply from the host. And that's called angiogenesis, first started by Judah Folkman. But once angiogenesis, it takes in this little tumor, started off as a single cell, can grow to be a detectable lesion or a lethal tumor. So there's 2 events that have to happen, but there are 2 possible dormant states: waiting for a single cell to start dividing, and waiting for a avascular micrometastasis, waiting for a vasculature supply from the host, which is called angiogenesis. I imagine everyone listening to this knows about that. So, okay, next slide. I used my knowledge of computer simulation to study the different peaks in the relapse data. And these are the peaks that I found. This is for the this is for the premenopausal patients. The 10-month peak seemed to be surgery-induced angiogenesis. Avascular micrometastases were sitting in a state waiting for some sort of a blood supply. And at the time of surgery, something happens at or about the time of surgery to induce angiogenesis. And those deposits relapse in about 10 months. That 30-month peak corresponds to single cancer cells that were sitting dormant, and then something happened at or about the time of surgery to induce them to dividing, and then they had to go through angiogenesis stochastically, and those are 30-month peak. The rest of it was about the same. Curiously, the benefit of surgery first appears at about 5 years. Everyone says, well, you got to remove the tumor to prevent relapse, but you first get the benefit after 5 years. Before 5 years, there's no benefit at all. Okay, just general comments about computer simulation. It's a powerful tool, but it's only as good as the clinical data that I have available. I mean, I can't guess what the tumor growth is, but if I can see clinical data and I know how cancer cells go from cells to avascular micrometastases to become metastatic and then grow up to be a detectable tumor, I can put it all together. But this computer simulation is powerful, but it's only as good as available clinical data. And I've already showed the clinical data that I thought were good. Another thing is that you need medical specialists to do this kind of work. My background is in physics, and I don't have the medical specialty. So my co-authors included surgeons, medical oncologists, an anesthesiologist, and another scientist who knew a lot about blood circulation. So the combination of my background in computer simulation and having these specialists looking over my shoulder and making sure there's no errors in the paper, and then it has everything fits their specialties. So those are the limits of using computer simulation. You're probably, this next slide, this growth of metastasis from an osteogenic sarcoma, that's figure 16. You're probably wondering how I got to the point where I knew how to say that surgery can cause metastasis. Well, I was a visiting professor at University of Texas, San Antonio, in Bill McGuire's lab. McGuire was the person who first proposed that estrogen and progesterone are prognostic factors in growth in breast cancer. And so McGuire wanted me to see if I could add hormone therapy to a computer simulation I had already done. And it ran into a problem. And I had a 6-month appointment. At 4 months, I had to go to McGuire and say, hey, the project failed and I don't know why. Well, they brought in someone who developed this database and said that one of the labels, one of the columns I was told was mislabeled. I was told these numbers were when the patient relapsed, but the true answer was that that date was the time when the patient was last seen by the physician. So it was no small wonder that I could not get this to work. Anyway, McGuire said, well, you got 2 months left to go on your project, do whatever you want. So I spent 2 months in the University of Texas library doing literature research. They had a beautiful library there. And this was at a time, 1989 is the time I was doing this. This is at a time when physicians, when they first got a patient who had cancer, they didn't amputate right away. They didn't start treatment right away. Nowadays, someone comes in and a cancer on a patient, the physician will immediately take the tumor out and start treating the patient. But in this day, in 1989, they didn't do that, or 1968. That's when this paper was, this one figure was presented. This was a case report of a 16-year-old boy who was diagnosed with osteosarcoma. And the physician, Smithers, did nothing for 4 or 5 months. They did some radiation right away, but nothing after that. All he did was take images of the lung. he knew that osteosarcoma typically relapses to the lung, and he was just taking pictures of the lung every few months to see what's going on. And he could see nothing at all until this one point where it says just visible, just visible. And then it grew up on a straight line and a semi-log scale. This is a log scale on the vertical size and a linear scale on the time. And anything that grows like a straight line and a semi-log scale is constant doubling time. This is a common type of growth for cancer. At any rate, the thing grew out to be 12 cubic centimeters, and Smithers, the radiologist, he removed it. Nothing unusual about it. But the remarkable thing that I saw in this figure was that it seems like there's a coincidence between when the tumor, the lung tumor was just visible, and the amputation. That raised some questions. What is this saying? Is this saying that it's a coincidence that the amputation and the just visible tumor was a coincidence? I have a hard time believing it was a coincidence. The only other explanation is that the amputation caused the relapse to initiate. Well, that's what I came to. I came to the conclusion this figure will probably never be seen again, because no one is going to wait for 4 or 5 months before they remove a tumor. And this will not happen again. This is the only picture you're ever going to see of this. That the amputation of the osteosarcoma seemed to precipitate the lung metastasis. It doesn't say how often this happens. This could be 1% of the time, or it could be 99% of the time. But I got to be pretty confident that somehow or other, amputation causes relapse. Don't know if it's 1% or 100%. At any rate, because I saw this figure, I felt comfortable adding a possible surgery-induced relapse in that figure back there, where I said that the surgery caused relapse. It was based on this figure. Okay, I published this in a paper. I published all the papers that I found when I was doing this medical literature research. I published it in 1990. This is available, Medical Hypotheses, 1990. This paper is available. You can find this figure in that paper, Medical Hypotheses, or in the Smithers paper, Clinical Radiology, in 1968. Next slide. Okay, at this point, I can make some quantitative judgments here. That early peak, the dominant peak, was composed of 2 previously unreported surgery-correlated relapse modes. Avascular micromets are induced to vascularize. They show up at 10 months peak. It occurs in about 20% of premenopausal node-positive patients. And with sharp, it seems to be more prominent for premenopausal node-positive patients than any other case. And it was 5-to-1 node-positive to node-negative, and 2-to-1 premenopausal compared to postmenopausal. I mean, this is how a physicist does things. I try and understand as much as I can about this process. And once I get to a point where I think I have a good picture of what's going on, it's a lot easier to make a good guess as to what's going on. Okay, what I came up with in analyzing the Smithers data was that 50 to 80%, the Smithers data and the rest of the Milan data, 50 to 80% of relapses are iatrogenic. They're treatment associated. And they're at 10 months and 30 months. And they increase, the number increases with tumor size and nodes positive. That's pretty revolutionary. Okay, the peak after 50 months is more or less the natural history. And the first benefit of surgery to remove metastases appears at 5 or 6 years. And as I said, this is all published. Next slide. Since then, I was looking at a lot of other cancers to see if I could see the same bimodal pattern. And every cancer I looked at, either from large databases or case reports, you can see that same pattern. That pancreatic one on top, that's a case report where it's obvious that surgery causes some activity. Melanoma, clinical data, and lung cancer, prostate, osteosarcoma. Every cancer I've looked at seems to have that general pattern as I examined pretty carefully in breast cancer. Okay, next slide. It turns out that this problem might have been known 2,000 years ago. I ran across this paper, Irving Ariel, and Ariel did some research in the ancient reporting of cancer treatment, breast cancer treatment. And he found something by Celsus, 30 BC, 38 AD. Celsus, these are the words, but it probably been translated through several languages, so the exact wording may not be perfect. Celsus says, first there's the cacoethes. The cacoethes is a small tumor that's pretty apparent, but it has not gotten through the skin. It's obvious, but it hasn't gotten through the skin. None of these can be removed with the cacoethes. The rest are irritated by every method of cure. The more violent the operation, the more angry they grow. That's something you hear from surgeons a lot, that surgery causes an angry response of the tumor. After an excision, it recurs, bringing it with it the cause of death, whereas at the same time, by using no extirpation, protract lives, notwithstanding the disorder, to an extreme old age. Okay, Galen, in about the same time period, we have often cured this disease in early stages, but after it has grown to a noticeable size, no one is cured with surgery. Yeah, I was pretty astounded here. It turns out that what I was just finding in that data before, it seems to have been known 2,000 years ago. Next slide. Okay, I did some investigation to see if I could explain clinical observations by what I have been reporting in the past 10, 14 pages, whatever, and then the prior, I guess, 18 pages. I'm only going to discuss one of these. The one that I'm going to talk about is mammography. It turns out that mammography seems to work better women age 50 to 59 than age 40 to 49. When they were first playing around with mammography, they knew it made some improvement in outcome. Women's lives were saved, but they didn't know the quantity. So they did clinical trials. Trials were done in the US, in the UK, and in Sweden. Most of them were done in Sweden. What they found was that for the women aged 50 to 59, there was an early appearing 20% mortality advantage to the patients who had mammography compared to the ones that did not have mammography. But when they looked at the ages 40 to 49, there was an anomaly. There was at the third year after the trial started, there was an anomaly. There were more deaths among the intervention group than the control group. This didn't make any sense. I was studying this and I said, well, this might make sense by what I've been finding. It could well be that that third year abnormality, the situation where there's anomalous data, the early relapses for the women who are premenopausal occur after about 10 months, let's call it a year. And survival after relapse in the absence of any chemotherapy was 2 years. So it's believable that this could explain relapses, mortality in the third year. And sure enough, there were a lot of relapses, a lot of mortality in the third year for the premenopausal patients and not for the postmenopausal patients. I mean, so that was pretty interesting. So I wrote a paper, this is now 2005. I wrote a paper and I was ready to publish it. Publishing, it was about a week away. And I was on Judah Folkman's staff at Harvard at the time. And Folkman generally did not like newspaper reporters, but he happened to like this young lady, Amy Marcus. She was a Pulitzer Prize winning reporter from the Wall Street Journal. And Folkman invited her to come to one of the lab meetings. So we were sitting there waiting for the meeting to start Friday morning at 9:30 or 9 o'clock, whatever it was. And I happened to be sitting next to Amy Marcus, and we started a conversation. She asked me, "What are you working on?" I said, "Well, I'm studying the early relapse. I'm studying the relapse after mastectomy, and for premenopausal women is more so than the postmenopausal women. And it looks like this can be explained by surgery-induced angiogenesis, surgery-induced activity. That surgery causes a relapse." And publishing a paper in 2005, well, Amy Marcus was fascinated by this. She was a premenopausal woman. So she and her editor decided that Amy should write a piece that to be published in the Wall Street Journal. So that next week, when the day the paper came out, I think it was September 2005, Amy Marcus's report came up, I think a 1,200 word report in one of the front pages of the Wall Street Journal, and Harvard issued a press release. And this got a ton of publicity, as you might imagine. The people at Harvard told me, people from the newspapers will call you and television. Don't reply because you can't beat Wall Street Journal for publicity. So I left it alone. Interesting thing happened. About a week after this paper was published by the journal and the Wall Street Journal and my paper, got a letter to the editor from Isaac Gukas. Isaac Gukas he died recently. He was a native Nigerian and a surgeon. He was working at a hospital in UK. He said, what you reported could explain what happens in Nigeria. He said in Nigeria, when a woman feels a breast lump, they typically do not go to a surgeon. They go to an herbalist and get some soothing ointments. Then they go back to their village and die from untreated breast cancer because they know that the surgery to remove the tumor provokes relapse. Provokes, that's the word that Isaac mentioned. Well, this is fascinating. This sort of set us off in a new direction. I ended up making 3 trips to Nigeria after this event. This really got interesting. Something is going on in African breast cancer that's different from Caucasian breast cancer. That was fascinating. At any rate, there's more to be said about this, but it looks like Nigeria, it turns out that these are triple negative breast cancers, by the way, and triple negative breast cancers seem to have this ability to have surgery-induced tumor growth. Okay, that's all I'm going to say about this, but that got me pretty interesting. And by the way, after that paper came out, I was looking at Google and asked Google, does surgery cause cancer to spread? And I got something like 20 million hits after that paper came out, and Amy Marcus wrote it up in the Wall Street Journal. So if you hear anyone saying that surgery seems to cause a relapse, it's triggered by this report by Amy Marcus after she saw my paper. Interesting little story. Okay, next slide. We didn't know what was going on. We didn't know what was causing these relapses. Then in June of 2010, some new data came up that was stunning. It looked like, well, this was done. Forget is an anesthesiologist. He was at a hospital in Brussels, And this was a teaching hospital, so they have to show the residents in anesthesiology all the drugs that are used in anesthesiology. But Forget decided he wanted to do a retrospective study. He wanted to do a study to see the relapses of the patients treated by this one surgeon. One surgeon did the same thing, conventional therapy. The only difference was Forget used different drugs that were used in anesthesia. And it turned out that one drug was far superior to any other drug, and that was ketorolac. It's an NSAID. No ketorolac, you get these early relapses, but with ketorolac, the relapses are gone. Dem Kelly and I went out to Brussels and we saw their data and we gave a talk and they gave talks. But this was fascinating to us. Dem Kelly analyzed the data, the Forget data, and presented in this format. There was a five-fold reduction in relapses months 9 to 18 for this ketorolac compared to any other drug. Ketorolac is one of three NSAIDs that can be used as IV. But at this time at the hospital, the only NSAID they had was ketorolac. So, there could be more than just ketorolac that does this, but we know pretty sure that ketorolac seems to prevent these early relapses by a five-fold effect. Okay, next slide. At this point, we knew that some intervention around the time of surgery would be needed to stop those early relapses, but we didn't understand what mechanism could explain that Forget data. And I did a general survey of these pretty complicated, large fields, and I just wanted to look for correlations. Surgery, inflammation, and angiogenesis, circulating tumor cells, the immune system, cancer dormancy, and neutrophils. I just took a look at these things in a very crude way, and it looks like inflammation occurs after surgery. IL-6 is a marker for inflammation. It shows up for a week after surgery. Angiogenesis plays a role. The platelets are angiogenesis. Platelets typically sequester VEGF as they circulate through the blood, and then during surgery they they expel the VEGF. So their VEGF is reduced for the first few weeks, and then it's kicked off in large quantities. Circulating tumor cells, that could be part of this. The immune system will be compromised from the surgery. Maybe that's an effect. And cancer dormancy is well known. And neutrophils seem to show up in a lot of these areas. Neutrophils are parts of the white blood system that are generated in large number after there's an injury. And the injury is the surgery. So I'm going to show you three reports here that fit all this stuff. A paper by Hiller, Brodner, Gottschalk, best practice in research, clinical anesthesiology. The perioperative period can be considered a perfect storm of immunosuppression and inflammation in the presence of residual or circulating tumor cells. This is suspicious. Maybe the inflammation is causing this, or the immunosuppression. Balkwell, Antovani paper, Lancet. Inflammation is not the spark that causes the genetic damage, but it's the fuel that feeds the flame. That's leading some interesting way. And Igawa et al. Did some study on capillary permeability, and he found out that capillary permeability increases 40-fold during inflammation. So something's going on with inflammation that seems to have a couple of different effects that may be part of this event. Let's go on, next slide. Okay, I came up with five possible mechanisms, and I'm just going to show you a couple of them. Hold on a second. Okay, I'm back. The neutrophil extracellular traps. Neutrophils are produced in a large number after surgery or some sort of damage to the body. They respond to inflammatory signals, and they can sometimes form nets, neutrophil extracellular traps. These are part of the body of the nets of the neutrophils are expelled as it's going through the capillary. And this is part of our body's immune system. This is how these neutrophils can capture bacteria or other things that are in the circulating system to help us survive. So this is part of the natural body support to prevent being rendered sick by invasive things. However, neutrophil extracellular traps can capture cancer cells. So if you have cancer cells that are going through the in the circulating system, and they have neutrophils go in, then you can have neutrophil cellular traps that capture cancer cells. And neutrophils have the ability to extravasate. They can get through the wall of the circulating system, and they can drag these cancer cells into distant organs. So this could be a way of how neutrophils can cause a relapse if you have circulating cancer cells and inflammation. And in that book I was talking about, the Springer Nature book, one of the chapters discussed this whole subject. And after reading that chapter 4 in that Springer book, I would be surprised if surgery did not cause metastasis to appear after surgery. Next slide, mechanism 2. This was a paper that was published by Krell et al. Krell et al. Was one of the students in Weinberg's lab at MIT. And Krell developed an animal model. They took a mouse and they developed it so that this can actually act like what we're seeing in breast cancer. They were actually able to inject cancer cells into this mouse model. And if the immune system was intact, these cancer cells would go into dormant states. And they would stay there until there was surgery. Surgery in any part of the mouse could cause these cancer cells to be released and show up as a tumor. Well, that was interesting. Plus, they could do an experiment. I mean, with our technology, we can do a lot of analysis, but they can do an experiment that we couldn't do. They could prevent this from happening with an NSAID, with an anti-inflammatory drug. So this was more evidence that inflammation is what kicks off these events, what causes the relapse. Okay, next slide. I'll skip over this one. I'll skip over this one. The mechanism 5 was interesting. This was a paper published by some Harvard scientists. I happen to know 3 or 4 of these authors, and this is a high-level paper. The main guy was Vikas Sukhatme. Vikas, he was a co-author of one of the papers that I wrote. Vikas was a very sharp guy, and he is Dean of Medicine at Emory University in the U.S. The first sentence in that paper by Panigrahi et al., cancer treatment is a double-edged sword. Surgery, including biopsy, chemotherapy, or radiation, can induce tumor dormancy escape. And this is related to inflammation. Well, that's a pretty strong statement that every treatment is a double-edged sword. But I'm telling you, I believe these people because it's a very well-known group, at least in my opinion. Okay, there's a lot of things in the internet that happened after all this was published. First of all, cancer patients got really freaked out when they heard that surgery can cause cancer to spread. Also, the NIH was saying that this is a myth. This doesn't happen. The chance that surgery will cause cancer to spread to other parts of the body is extremely low. Well, they said that. I have data. I mean, I have that data from Smithers. The NIH doesn't have any data, but they just wanted to say that it's a myth. So they can do whatever they want. They have a $7 billion budget. And the bottom one, a Crail et al. Paper, was reviewed by Komarov in the New England Journal. Clinical lore says that resection of a primary tumor can cause previously inapparent metastatic deposits to flare. Well, you can take whatever you want out of these three different statements, but it's pretty interesting. I won't spend any more time on this. Conclusions: early relapses in breast cancer, which are the majority of relapses, consist of surges of angiogenesis and single cell activation. They're triggered by primary surgery that causes inflammation. It lasts for about a week. The systemic inflammation causes dormant cancer cells and deposits to exit dormancy, resulting in relapses by a number of possible mechanisms. Well, that's a mouthful, but that's pretty much what I saw at this point. And the data suggests transient systemic inflammation is a precipitating factor that results in angiogenesis and single cell growth from dormancy. The Forget et al. Retrospective data suggests that ketorolac, the NSAID ketorolac, reduces early relapses 5-fold. This may reduce breast cancer mortality by 25 to 50% at low cost and toxicity. By the way, I'm a cancer survivor. I'm a 25-year survivor of stage 3C colon cancer, and I was one of the founders of the Colon Cancer Alliance. So my orientation here is from the patient point of view. This is great. If you can reduce mortality at low cost and toxicity, that's great for the patient side. Medical oncologists may not be too happy about this, and Big Pharma may not be too happy about this, but from the patient perspective, this is great. The fourth item, breast cancer runs its course in over a decade, but most of the events that lead to relapse seem to occur in that 1 week after surgery. And this suggests that metastatic progression is amplified 100-fold during that post-surgery week. And judging from the Fisher graph, 10% of node 0 and 85% of N greater than 12, nodes greater than 12, those patients undergo surgery-induced relapse. That may explain the value of mammography and early detection. And N equals 0 is an early cancer. But if they don't spend any time looking for this tumor with mammography and you wait a year or so, you get more than 0 nodes. And the general surgeon and anesthesiologist should take extra precautions to control inflammation. And there are a large number of studies for a variety of cancers that correlate preoperative NLR. NLR is neutrophil to lymphocyte ratio. That's a good measure of inflammation. It's not perfect, but it's good because it's cheap and you can dig it out of any common blood draw. So you get a blood draw on a patient and you can read the neutrophil to lymphocyte ratio. So there have been a lot of papers published for different cancers. And I'm talking maybe 30 different cancers that correlate preoperative NLR, the neutrophil to lymphocyte ratio, and outcome. If NLR is high, the outcome is bad. And if NLR is low, the outcome is good. And this seems to be a good rule. The inflammation that exists before the surgery is done determines whether the patients will survive or not. And I would say that reducing perioperative inflammation will augment the benefit of early detection. And our current interests are to resolve the unmet need in Nigeria. I published a paper with my colleagues, Breast Cancer and the Black Swan 2020, and also want to teach our technology to young scientists while we study the sciences. I'm getting old. I'm not going to be around that much longer doing research, but I want this technology to be passed on to younger scientists. And general question, it's a tough question. Surgery apparently causes dormant cancer to wake up. Is that good news or bad news? Well, according to NIH, it's bad news. But according to my viewpoint, it's good news. It says there's a new mechanism that can be used as a way of preventing relapse. And it's zero cost and no toxicity. That's good news. And number 12, recent clinical data support our findings for many cancers, and especially breast and lung. I'll show you what that is. Well, before I do that, one more comment. Triple negative breast cancer does not have any of the markers for targeted therapy. So triple negative breast cancer only has chemotherapy as a treatment. You can't use tamoxifen or anything like that, or Herceptin. The only treatment that you can get for triple negative breast cancer is chemotherapy. And that's not very good. It's considered an unfavorable situation. One paper I saw talked about this as the kiss of death and triple negative breast cancer. So what we want to do is we want to propose to operate, we want to treat perioperative NSAID, ketorolac. We want to do this in Nigeria. We want to solve the problem in Nigeria. Triple negative breast cancer is about 10% of the population in the US, and in Nigeria, it's about 70%. So triple negative breast cancer is a major problem in Nigeria, much more so than in the US. Recent papers.
Excuse me, Dr. Michel, sorry
yes?
to disturb, sorry to interrupt. Can you make it a little quick, like other speakers are waiting, like it's on the time, on the board?
Okay, I'm just ready to close up.
Yeah, thank you.
Two more things. A paper was published by Bodway. They instead of using NSAID, they used lidocaine as an inject. They injected lidocaine into the tumor area, and they got for 5 or 10 minutes before surgery, and there were no adverse effects, and they had 30% reduction in mortality in breast cancer just by using lidocaine instead of ketorolac. So that's an interesting thing. Bodway is the author of that. And lung cancer, look at this paper by Razik et al. They were looking at patients who were treated previously, and they grouped them, the patients who have been taking NSAIDs compared to the patients who did not take any NSAIDs. And there was a huge difference in overall survival. The ones who took NSAIDs had 5-year survival of 30%, and the ones that did not have NSAIDs had 13%. Okay, these are my co-authors. I don't have time to go into them, but everyone's here. And these are the Nigerian people that I was visiting with. Okay, that's the end of my talk. Sorry to be taking so long. I'll entertain any questions, or if you want to contact me by email, michael.retsky@gmail.com. Thanks. Thanks for your attention.
Yeah, thank you, Dr. Michel. We'll take the questions at the end. So now moving on, our next speaker is Dr. Sarah Helroth from USA. So I'm passing her the stage to deliver the speech on use of bronchoscopic for EGD in eosinophilic esophagitis. So welcome, Dr. Sarah.
Thank you so much. Good afternoon, everyone. All right. So I believe everyone should be able to see my slides. So what we're going to be talking about today is a case report on the use of bronchoscope for EGD in a patient with eosinophilic esophagitis. Myself, Drs. Gagliardi and Sarnes were all involved in this case. So objectives. So during this talk, we're going to be talking about the alternatives that you can use in an endoscopy suite for patients with narrowed fibrotic esophagi, and promoting the importance of lateral thinking during procedures in order to help to provide patient care for the patients that you might not be able to care for otherwise. So this patient is a 30-year-old male who presented into our emergency department with dysphagia. He had no past medical or surgical history, and he was not taking any medications. He had had these feelings twice previously where he felt like he was getting a food bolus stuck and he wasn't able to swallow. However, with drinking liquids and slowly working on it, he was always able to eventually pass the food on his own. On this admission, he was taken for upper endoscopy in order to retrieve the food bolus. The EGD showed extensive concentric ringing and fibrosis that was consistent with the diagnosis of eosinophilic esophagitis. And you can see here in the image, the ringing present. Because of the extensive fibrosis, the scope was unable to advance any further than 30 centimeters past the lip. We attempted balloon dilation up to first 10 millimeters and then 12 millimeters. However, the scope still failed to pass through despite the dilation. Even attempts to ride the balloon down past this area of severe stenosis was unsuccessful. At one point, we were able to actually visualize the food bolus. However, we were unable to reach the bolus with the forceps for advancement into the stomach or for removal out through the mouth. So at this point, we decided that we were going to remove the endoscope. And because our endoscopy suite shares space with the pulmonary interventional suite, we had access to therapeutic bronchoscopes. Because of the thinner size of the scope, we were able to pass this, and we insufflated with a large air-filled syringe. And we were able to successfully pass through this area of narrow fibrosis in order to reach the food bolus and successfully removed it. So, as I'm sure many of you are aware, eosinophilic esophagitis, it's a diagnosis that commonly presents with either dysphagia, food impactions, food avoidance, intractable heartburn, regurgitation, or chest pain, with intractable heartburn being your most common presenting symptom. For diagnosis, you need a minimum of 4 mucosal biopsies from the proximal and distal esophagus, and diagnosis is made with 15 eosinophils per high-powered field. Some endoscopic features, you can see linear furrowing, concentric rings, which we saw in our patient, white speckled exudates, Schatzki's rings, and you also have a small caliber esophagus that has very poor expansion with either insufflation or with dilation. So when we're talking about eosinophilic esophagitis, it's important to then know what the normal esophagus is. And the normal healthy esophagus has a very variable diameter, mostly because it is very muscular in nature. So it has the ability to stretch and conform to whatever food or whatever instrument is passed through it. And the range for healthy esophagus is about 20 to 30 millimeters with insufflation, which means that you have the ability to expand and you can easily pass an endoscope through. And typically food would not be getting stuck. Your typical gastroscope. In this example, I'm talking about the Olympus gastroscope because that's what we use at our facility. However, many of the other brands and types of gastroscope have similar diameters. So your traditional scope that you would use for an EGD has a 9.2 millimeter diameter at the insertion point. The instrument port for this is 2.8 millimeters, and you also have access to an air-water channel and an auxiliary water channel. Now they do make a specific gastroscope that's a slim for situations just like this. This is a 5.4 millimeter diameter at the insertion point. Your instrument port is a little bit smaller, it's 2.2 millimeters, and you only have the air-water channel. you lose that auxiliary water channel. And so this is a wonderful tool for people that have access to it. Unfortunately, at our institution, being a small community hospital, this is not one of the scopes that we generally have and have purchased, because it isn't something that we would use enough to be able to make up for the cost of purchasing that extra scope. So in situations like this, typically we would have to abort the procedure and then have the patient sent down to one of the larger university hospitals in the city center. And at those places, they have access to this type of scope that's able to then pass through these areas of very narrowed and fibrotic esophagus in order to reach impacted food. What we ended up doing was we used the bronchoscope. So a therapeutic bronchoscope has a 6.3 millimeter diameter at the insertion section, and the instrument port is 3.2 millimeters. There is no water or air port for this scope. So one of the important things is because it's the same brand, all of our instruments are from the same company. All of our endoscopic tools, so your forceps and your nets, they're all able to be passed through the bronchoscope's instrument port without problem. So we could still use all of our typical instruments. The issue comes with insufflation. Because there's no air port, what you have to do is we used a very large syringe in order to inject air through the instrument port in order to expand the esophagus enough that we were able to visualize the food bolus. With this, you have to remove the syringe anytime you want to pass an instrument through in order to be able to reach the bolus. And so it's a constant going back and forth of pushing air or pushing an instrument through, and even water, using a water-filled syringe in order to inject through that single port. One of the other main differences is we were lucky in that this was in the esophagus. The bronchoscope is a much shorter scope. So if you're using it or you're trying to reach stomach or duodenum, you're not going to be able to make it. It's really only useful in this situation where we weren't able to reach 30 millimeters down in the esophagus. So this is a comparison between all of the scopes. So you can see the insertion diameter of 9.2 for your typical gastroscope. And then compared with your slim and your therapeutic bronchoscope, those are much thinner and they're much easier to use in a scenario like this with patients with eosinophilic esophagitis. Your instrument ports are all about the same size. And actually the therapeutic bronchoscope has the largest port size. And this means that you have instruments that would be compatible with all three types of scopes. Again, your gastroscope and your slim gastroscope do have a dedicated air-water channel, where your therapeutic bronchoscope will not have this. And finally, the gastroscope has that auxiliary water channel, which is not present in either of the two other scopes, which just means that you have to think a little bit differently when you're actually doing the procedure in order to be able to do all of the functions that you would typically do with your normal EGD scope. These are my references, and if there are any questions, then this is my contact information. Thank you, guys.
Yeah, thank you, Sarah, for your enlightening speech. Now the topic is open for discussion. Any queries? Okay, thank you.
Thank you so much.
Moving on to our next speaker is Dr. Edwin Roger. So he's from USA. So I'm passing him the stage to deliver the speech on tumor-related immune cells in their spatial immune distribution in non-small cell lung cancer. Dr. Edward, welcome. Dr. Edward, can you unmute yourself? Dr. Edward, can you unmute?
Okay. Can you hear me?
Yes, yes. Carry on.
Okay. Thank you so much for the organizers for inviting me to this conference. My name is Edwin Parra. I am associate professor at the Transnational Molecular Pathology Department. I am a director of the Multiplex Immunofluorescence Image Analysis Lab at the University of Texas MD Anderson Cancer Center. And the title of my presentation today is Tumor-Associated Immune Cells and their Spatial Immune Distribution in non-small cell lung cancer. Let me try to pass this. Okay, those are my disclosures. As you know, in the last year, because the important advance in immunotherapy also are important to analyze the tumor microenvironment. And for that, in the last 5 years, we saw revolutionary methodologies as the multiplex image technologies to analyze the tumor microenvironment, especially in translational research. With this kind of technology, we can analyze different kind of targets, proteins. We can analyze the T cells, B cells, lymphocytes, NK cell markers, vasculature markers. We can analyze different kind of pathways, and why not, we can discover new protein targets for treating our patients. With this kind of technology, we can stain those markers, around 8 markers in the lowplex technologies, and around 40 markers in highplex technology, and study in that way the tumor microenvironment of these specimens. One of the most reliable techniques today, and that evolved in the last 5 years, is the use of the tyramide signal amplification for staining these tumor cancers. And with that technology, we can introduce and we can stain several markers in one single section. Here, I can show an example of a panel of 8 markers using tyramide signal amplification. The markers are pancytokeratin for epithelial cells, and those one can be addressed also the malignant cells, CD3, T lymphocytes, CD8, cytotoxic lymphocytes, CD68 macrophages, FOXP3 as regulatory T cells, Ki67, a proliferative marker, and the axis, of course, of PD1, PD-L1. In the bottom, you can see the fluorescence staining. This is the decomposed image of the same marker that I show in chromogenic ISC. That is how we validate the panel. This is a reactive human tonsil. And on the right, you can see the composite image of this tissue with all the markers included. And you can see by the color, the markers in the tonsil. Why use multiplex immunofluorescence? Now we have the ability to see, for example, where come from PD-L1 expression. In the past, using only chromogenic ISC, were unable to say that the PD-L1 come from malignant cells or for macrophages. Sometimes was challenging to say that one, only with a single chromogenic ISC. Now, with this kind of technology, we can see that PD-L1 can be expressed by macrophages, as you can see in picture A and B. Macrophages in yellow and PD-L1 in orange. Also, we can see that the PD-L1 is expressed by malignant cells here in cyan in the figure C, and also can be expressed for lymphocytes in figure D. Multiplex immunofluorescence give us the opportunity and give us a high volume of biological information that is important to understand better the tumor microenvironment. We can study the architecture of the tumor, introducing different kinds of markers of collagen, for example. We can identify very precise phenotype of cells using the co-expression of the markers in the panel. We can study the distribution of these cells according to the tissue, if are in the nets of the tumor cells or surrounding the net in the stroma of the tumor or in the periphery of the tumor. We can analyze rare cells, and why not, we can discover new therapeutic targets for our research and treatment. Strategize the image analysis also is important, and depend of the staining that you use and the image analysis software that you are using. You can analyze the entire section of the tissue, the whole tissue section. We can analyze very specific areas inside of the tumor or outside of the tumor. And those areas, the whole tissue section and the region of interest, you can lymphoid, etc. We depend of the image analysis that are you using. Also, you are able to analyze the boundary of the tumor. You can analyze the periphery of the tumor and what happened in that periphery of the tumor. And the most important part of the image analysis is the phenotype your cell, combining with different markers that you have in your panel. You can analyze more precisely the cells population as cytotoxic T cell, herpes T cell, for example. And another important tool of image analysis is the spatial distribution of those cells. Because when you analyze those images, the software will give you a X and Y coordinate of the cells, and you can analyze quantify the metrics between different kind of cells, between malignant cells to lymphocytes, or between tumor-associated immune cells. Now I would like to discuss 3 examples of a project that we analyze and we study with this kind of technology. The first one is the neoadjuvant therapy versus non-neoadjuvant therapy. We study 112 non-small cell lung cancer, 61 cases not chemotherapy, and 51 cases chemotherapy treated. We analyze with 2 different multiplex immunofluorescence panels. Here you can see some of the markers included and the cell phenotypes. For example, malignant cells, T cells, helper T cells, cytotoxic T cells, macrophages that are expressing PD-L1, and in the panel 2 is mostly directed to lymphocyte markers as regulatory T cells, memory T cells, NK cell markers, and activate NK cell markers, as well as the antigen experience T cells PD-1 expression. Overall, we see that cases that have neoadjuvant therapy compared with the non-neoadjuvant therapy increase all the lymphocyte subpopulation in the cases compared to the not treated cases. Importantly, we observe that most of the cases that are neoadjuvant treated cases increase the expression on PD-L1, as you can see here in this picture. Here you can see non-neoadjuvant chemotherapy with panel 1 and panel 2. We have some lymphocyte markers, but when we go to the neoadjuvant chemotherapy treatment, we see that there is increase in the density of malignant cells that express PD-L1, as you can see here in orange, and also increase in the number of lymphocytes that is inside of the tumor and in the stroma of the tumor, as you can see here in panel 2. When we go to this table, we can see also that some p-values are predominant. We can see that, as I mentioned, that a malignant cell can be expressed more PD-L1. There is an increase that is very significant. You can see also that there is a helper T cell that increase. Also, in cases markers that are increased, as well as the memory T cell that express PD-L1 and the PD-L1 expression in the tumor that suffering neoadjuvant treatment compared with the non-neoadjuvant treatment. Using Kaplan-Meier and univariate analysis, also we demonstrate that if the patient has highest number of helper T cells in the epithelial compartment, in the tumor compartment, as well as in the epithelial stroma compartment, highest number of macrophages, those patients have a better outcome compared with the patients that have low proportion in the neoadjuvant treated cases. That means that probably this can allow us to target those markers and introduce a neoadjuvant therapy in those cases. The second project is the malignant pleura mesothelioma. We study 30 cases of this type of lung cancer. We analyze these cases using this panel that contain pancytokeratin, CD3, CD8, CD68, FOXP3, Ki67, PD1, and PD-L1 axis. Here you can see a co-expression of the marker using pancytokeratin, that is the epithelial marker or neoplastic cell marker in this case. We can see also the co-expression with the CD68. All these markers can be co-expressed with the PD-L1, with the Ki67, as well as double expression of PD-L1 Ki67. We found also with that panel that there are basically 18 different kind of phenotype lymphocytes. You can see better here the core plot that show the interaction between the different markers, CD3 plus, for example, CD8 that are cytotoxic T cells, CD3 plus PD1 and CD3 plus PD1, as well as the other markers. And here on the right, you can see a representative image of those co-expression and the different co-expression markers listed on the middle of the slide. Importantly, also we studied the spatial distribution of these cells in the tumor, and we analyzed the metrics between malignant cells and all these tumor-associated immune cells. And we found that importantly, in related to the cancer cells that doesn't express PD-L1, that express PD-L1, we have very close distance related to T-cell lymphocytes that express PD-1 and express PD-L1 marker. That means also that those cases can be treated with blockade therapy, PD-1 and PD-L1 expression. The third project that I want to show today is multiplex immunofluorescence approach that we use in non-small cell lung cancer. We apply 5 different type of panels, multiplex immunofluorescence. The panel 1 that listed here contain T lymphocyte, as well as the markers of CD68 and the axis of PD-1, PD-L1. The second panel is mostly for activated T cells. We use CD68, grandson B, and memory T cell, as well as regulatory T cells. The third panel is mostly immune checkpoint markers. We have PD-1, B7H3, B7H4, IDO1, and CD68, because we know that all these markers can be expressed in lymphocytes as well as in macrophages. And the fourth panel contain mostly checkpoint markers as LAG3, TIM3, VISTA, OX40, and ICOS. And the eighth panel is a myeloid panel that we put CD11B, CD14, CD33, CD66B, Arginine-1, and CD68. Here on the right, you can see the different core plots from each panel, and you can see the co-expression of the markers. For example, in panel 1, here in panel 2, in panel 3, in panel 4, and in panel 5. That means we have a lot of co-expression markers that identify different cell populations. Interestingly, in this project, we observed that the malignant cell not only express the classic PD-L1 by those cells. Here in this example, for example, in this core of tumor, we saw 27% of malignant cells express this kind of immune checkpoint marker. Also, we see in the same core that 59% of the malignant cell express B7H3, 16% of the malignant cell are expressing B7H4, 30% of the malignant cell are expressed IDO1. That means in the same tumor tissue, you can find malignant cells that express different immune checkpoint markers. You can see that sometimes the malignant cell can be expressed 3 different checkpoint markers, can be expressed 2 different checkpoint markers, can be expressed only 1 checkpoint marker as B7H3, can express PD-L1 and B7H3, can be expressed PD-L1, B7H3, and IDO1, only PD-L1, only pancytokeratin and IDO1. That means that probably if you target the principal immune checkpoint as PD-1, probably depend of the percentage of the cell that express the other marker, that cancer can relapse in the second point during the treatment. Also, we observe that there is around 32 basic cell phenotypes related to the malignant cell, related to the lymphocyte, and related to the macrophages, as well as the myeloid cell population. And you can see here an example of the distribution of all these kind of phenotypes. Sometimes are very few percentage of those phenotypes, sometimes it's a larger percentage of this cell phenotype. And only these are one part of the co-expression, because you can obtain more type of co-expression, combine the different markers in the different panels. The spatial analysis also, we found that there is two different kinds of distribution of the T lymphocyte and the other tumor-associated immune cells. You can see in the first one that is more mixed pattern. You can see here in cyan the malignant cells and in red the T lymphocyte. And if you see carefully, you can see that the T lymphocyte and the malignant cell are all mixed. In the second pattern, you can see that the malignant cells are more grouped in a net, a very well formed net, and the lymphocytes are surrounded the tumor net in the tumor stroma compartment. If we analyze this kind of distribution of cells, also it's very evident that most of the markers that are negative markers for the tumor, for example, cytotoxic T cells, regulatory T cells, for example, and cytotoxic T cells that express PD-L1, cytotoxic T cells that express PD-1, PD-L1, as well as the grand sign B here in very low proportion are mostly in the site of mixed pattern in this pattern. And the other cells that are important for attack the tumor, as for example, the cytotoxic T cells, memory T cells, and some macrophages, you can see in the other, in the right of the figure here, showing that those are distributed overall in this kind of unmixed pattern. With that, I can say in my conclusion that the multiplex immunofluorescence associated with digital image analysis offer a high quality throughput assay to study cancer, not only non-small cell lung cancer, but other type of cancers. Diverse population of tumor cell and tumor-associated immune cell phenotype can be present in non-small cell lung cancer and malignant pleural effusion, as we saw previously. A conventional neoadjuvant therapy increased the tumor-associated immune cells in tumor tissues when compared to chemo-naive tissues. Maybe can increase the response to immune therapies. Our data show that tumor cells and tumor-associated immune cells could produce multiple inhibitory factors in lung malignant mesothelioma and non-small cell lung cancer, as we saw previously. These findings highlight the importance of better understanding the complex relationship between malignant cells and immune cells in their these cells and in their spatial distribution to direct study new approaches of neoadjuvant therapy. With that, I want to say thank you. This is my group, the Transnational Molecular Pathology, and thank you all the people that integrate the different labs that I work and also the patients. Thank you and happy to answer any question.
Yeah. Thank you, Dr. Edwin, for your enlightening and wonderful speech. So now the topic is open for questions. Any questions from audience? Okay, thank you, Dr. Edwin.
Thank you.
So our next speaker is Dr. Jay Leeper from USA. So I'm passing the stage to deliver the speech on diseases of DNA structure, the search for a new class of pathogenic chemicals for a new class of pathogens, a hypothesis and a website and an assay. So Dr. Jay, stage is yours. Welcome.
Thank you very much. One moment. All right, this is Diseases of DNA Structure, or the title. By way of declaration, I declare I have no conflicts of interest with any commercial products referenced herein. Let me begin with an outline of where we're going in this talk. I'm going to give you some background. First part of this talk, we'll discuss short-term tests for genotoxicity, which I will explain, and use that as a model for what will follow. What will follow will be a discussion of a regular genesis assay, which is a proposed new test for a new genetic endpoint. We'll discuss changes in DNA structure. We'll discuss a website that I have developed and an assay that I have developed. And we'll conclude with some thoughts and plans for the future. First of all, genotoxicity refers to the effect of chemicals on DNA at various levels and by various mechanisms, such as to result in cancer or other pathologies. Let's focus on cancer. Question is, what causes cancer? And the answer is lots and lots of factors, as you can see here. But this talk is going to focus on chemical carcinogens, chemicals that are genotoxic, chemicals that cause tumors. And the question the world has been addressing for a while now is, how do we detect or test for carcinogens? Of all the chemicals in the world, how do we determine which are those that are dangerous, likely to cause tumors? Classically, what I call the old way, we did animal testing. Take mice, rats, rabbits, etc., expose them to suspect carcinogenic chemical, and you see if you get development of tumors. And this has a number of problems. It's expensive. You need a large facility. Care and feeding of the animals is an issue. You need a veterinarian on staff, special flooring requirements for washing and draining, special ventilation, a whole building and a whole team. What that means is that there are limitations in the number of chemicals that you can test and the number of doses for each chemical, just because of the expense involved. And similarly, the whole process is time consuming, take weeks or months until you get a tumor or no tumor endpoint. Well, recently, there is a new way. This is called short-term tests for genotoxicity. We're looking at a number of genetic endpoints. One class of genotoxic chemicals are those that cause mutations. With regard to mutations, the classical method, first really serious short-term method, was the Ames assay, Bruce Ames, University of California. He made an assumption that chemicals cause mutation, we know that, and the assumption that mutations cause cancer. Cancer is caused, as we said, by a lot of things, but mutations is one mechanism. The strategy was to develop a simple assay using bacteria to screen for chemicals that cause mutations, emphasis on the word screen. And the argument is that if it causes mutations in bacteria, it will or may cause mutations in humans. And then if it does cause mutations in humans, it will or may cause cancer. This assay was very straightforward, using a strain of Salmonella that had built into it a mutation in the histidine biosynthetic pathway. So there's a pathway, 10 steps, 10 enzymes. One of those enzymes was mutated, which we'll call His minus. And in the presence of a mutagenic chemical, if it could get a reverse mutation, product is called the revertant, and His plus. So we'll put that down as a shorthand, His minus going to His plus. The important idea to have in mind is that a mutation is a mutation. You're changing a base. Doesn't make a difference mechanistically if you're going from a base which gives you a wild type functional enzyme or a mutant enzyme that's non-functional. Either way, it's a mutation. It's more convenient to go from negative to positive. The point of short-term tests for genotoxicity compared to animal testing Said you can do it in 24 to 48 hours. You can do it much less expensively compared to animal testing. And therefore you can test more chemicals, you can test more doses, and advantageous in that respect. Understanding that given all of the assumptions built into this, subject to further testing, you need to do ultimately in animal testing to determine if it really is a carcinogen. So what we have at the very least, but importantly, is a screening system. You have 100 possible chemicals. You can't do all of those 100, so you select which are positive in the Ames assay and then go on to further animal testing. Using this and testing a wide variety of chemicals, especially those in the environment, they found mutagenic components in ladies' hair dye and in flame retardants in children's pajamas and Xerox toners. And these were all removed by the respective companies. And many other chemicals, such as food additives, such as chemicals, such as commercial products, the whole world of environmental chemicals was now able to be tested and screened in a much more easy and convenient fashion compared to animal testing. Second genetic endpoint is to look for DNA damage. This was done in what's called the PAL-A assay, which I will explain. Same idea, short-term test for genotoxicity, different genetic endpoint. DNA damage means presence of thymine dimers, presence of methylation, deamination, a whole series of others affecting the integrity of the DNA. Bottom line, cell with DNA damage, that damage is lethal, kills a cell. But the cell has a way to get around that problem. There's a repair mechanism. It's called excision repair. Excision repair has 4 steps, 4 enzymes involved. Let's say you have a single strand of DNA with some of these kinds of damage. You have an endonuclease enzyme which makes a nick, breaks a sugar phosphate bond on one side of the damaged area. We have an exonuclease that removes the damaged DNA, chews it up, so to speak. That gives you a gap, one intact strand, an opposite strand with a gap, with a missing bases. You have DNA polymerase known as PAL-A, which fills in the gap, and because of the enzymology involved, can't make that final 3' 5' bond, so you need a DNA ligase, makes the final bond, and then if you compare what you started with, damage in a single strand, and now you go through all of these steps, you have now repaired the damage. The hero of the story is PAL-A, otherwise known as PAL-1, otherwise known as the Kornberg enzyme. It's necessary for this whole process of DNA repair to take place. Without it, damaged DNA is lethal to the cell. Now we come to mechanics. I want to go through this just to give you an idea of how call this a typical short-term assay is carried out. We're going to use 2 strains. The PAL-A plus strain, the wild type, is what we'll call repair efficient, able to carry out DNA repair. PAL-A minus is the repair deficient strain. We'll spread a lawn on 2 plates. We'll add test compound to a filter paper disc in the center of the plate. You understand the test compound diffuses through the agar, incubate 24 to 48 hours, and then the cells grow up, and you have a zone of killing around the disc, and you measure the diameter of that zone. Now comes interpretation. If the PAL-A minus strain gives a larger zone diameter, then the conclusion is that the test compound is a DNA damaging agent. In other words, the size of the zone depends on the balance between damage and repair. And if you have the strain that's not able to carry out repair, you get more killing and it shows up as a wider zone. So here is your plate. Here is your disc in the center, filter paper with test compound. This has been spread, but it's white because it's not grown up. This is your poly plus strain, your poly minus strain. 48 hours later, you have your plate grown up. This is now growth of bacteria. This is your zone of killing where the chemical comes out. So even in the presence of repair enzyme poly plus, you still have some killing. But in the strain poly minus that cannot repair the damage, you have a much greater diameter, which means much greater killing. Or to take it sort of in reverse, if you get this larger zone, you conclude that the test compound is DNA damaging. This is the same picture, just shows you actual photograph of real plates. This is your lawn, this is your disc, this is your zone of killing, and this is your wider zone in the poly minus strain. In terms of format, you can do the poly in the liquid assay form as well. Here you add test compound to 2 tubes, one with the poly strain, the other with the poly minus strain. Sample from the tube, spread that sample as a lawn on 2 plates, incubate, count the colonies now that grow up, spread plate. And again, you look for differential killing in terms of the number of colonies. So here you put measured amount of test compound into collection of cells in this tube, poly plus cells and poly minus cells. And then when you spread them and you incubate them and you get colonies, you get more survival, you get less killing in the repair positive strain and more killing in the repair negative strain. Or once again, to reverse it, if you get this kind of an observation, your conclusion on the test compound, that was the question mark, that you conclude that the test compound is able to cause DNA damage and therefore possibly cancer, et cetera, et cetera. There are advantages of the liquid assay versus the plate assay. It's quantitative. You know exactly milligrams, micrograms, how much you're putting into the tube. And then you can get a dose response curve. You can measure the increased killing effect as a function of increased dose. So you get not just a plus minus answer or a rough approximation, but you get a very precise statement about that particular chemical, if it's a strong DNA damager or a weak DNA damager, and so on. Furthermore, we can and should take note of advantages of the poly assay compared to the Ames assay. First of all, in terms of the target, the Ames assay, as we just said, is a single base change in a single gene and a single histidine pathway. Here, the target is not restricted to a single gene in terms of location. It can be anywhere around the entire chromosome. And secondly, in terms of mechanism of genotoxicity, you're not restricted to a base change mechanism. Any kind of DNA damage, as we discussed, there are various kinds that are all detected by this poly assay. All of which means that you may detect a genotoxic chemical by using the poly assay that the Ames assay may not detect. Just as a very important aside, we have a disease, human disease, xeroderma pigmentosa, which is a form of skin cancer. And it's been found that this cancer is due to a deficiency in the ability to repair DNA damage. So that sort of brings it full circle, not just a test with bacteria, but here we are in humans. And again, we have tumor related to DNA damage, which means it's worthwhile and important to find chemicals that are able to cause DNA damage. I showed you this parlay assay in detail because I did a lot of work with that, and a lot of that work was for the United States Environmental Protection Agency Gene Tox program, and we published a summary of that work along with other similar studies in this paper published in Mutation Research on repair-deficient bacteria, using them for predicting genotoxicity and carcinogenicity. Having said all of the above, I should point out there are in fact many short-term tests for genotoxic chemicals, different genetic endpoints, amongst which we can list histochromatid exchange, sperm abnormalities, many others, different organisms and formats, yeast systems and tissue culture systems, and so on. Different genetic endpoint, different operational advantages, and so on. Which means, ideally, you would want to have a test battery, because if test A, let us say, will detect 70% of known carcinogens from animal testing and so on, and test B will detect 70% of known carcinogens, but not necessarily the same 70%. So if we use a combination of test A together with test B, you have overlap, but some of that one will detect and some of the other will not will detect. So you may pick up 80% out of the 100. And if we add a third test, you may move that up to 90%, right? You can't do 40, but 2 or 3 you can reasonably make as part of your routine testing protocols and increase the chances of finding a genotoxic chemical. So all of that is introduction. All of that is background to the operational aspect of genotoxic short-term tests, essentially changing the informational content or the structural integrity of DNA. What I would like to propose now that we discuss is what I call regular genesis. Means to look for chemicals that affect DNA secondary or tertiary structure in such a way as to affect the binding of regulatory proteins. Okay, so we're not causing mutations, we're not causing loss of function, we're not causing lethality, we're just changing the structure of the DNA with the understanding that that will affect binding of proteins. Let me spell this out in a little more details. This is all prior knowledge, small molecules that bind to DNA, we know that. Such binding can cause changes in the secondary or tertiary structure of DNA. Regulatory proteins bind to DNA, we know that. Distortion in the structure of DNA can make the binding tighter or looser. And such alteration in regulation can have effects on microbial physiology, right? So it's a search for chemicals that will affect the structure of DNA, the secondary or tertiary level, with an ultimate result of affecting the binding of regulatory proteins, which means you make or you don't make a particular protein product. And of course, the bottom line is that we will hope and assume that it works the same in humans. So this is once again a screening test and scale up to animals and then people. I want to discuss DNA structure. Should be familiar to everybody. Here is your sugar phosphate backbone. One here, second strand over here. In between, you have bases. You have the hydrogen bonds connecting the bases. This essentially says the same thing, sugar phosphate, sugar phosphate, sugar phosphate. Attached to each sugar, you have bases. Note, as you all know, specific base pairing, adenine to thymine and guanine to cytosine. Note that a more realistic picture is that this structure is in the form of the famous double helix, two strands twisted around each other in a helical fashion. And we can look at this structure in terms of different levels. All right, this is vocabulary. All right. Primary structure is defined as the sequence of bases, and that's the whole world now is the sequencing everything under the sun. You have NGS, next generation sequencing strategies, and so on. Secondly, by definition, you have secondary structure, which refers to the properties of the double helix, specifically of what's called bDNA, classical DNA, Watson-Crick DNA. Some of these we mentioned before. The back, you have base pairing, which is very significant in terms of information content. Backbone is on the outside, base pairs on the inside. That's shown here and shown here and shown here and so on. What is not shown in these previous pictures are the base pairs are flat and planar. You have a smooth backbone line, trace that down nicely. There are no irregular structures. There are 10 bases per turn. So if you start, let's say, at this bulge and you go around on a single strand, 360 degrees around to a point directly above where you started, and then count the base pairs, we will have exactly 10 base pairs between this point and this point. So that's another property of bDNA. And finally, bDNA is characterized as having a right-handed helix. That requires a little explanation. And for that explanation, I'll give you a model to think in terms of, namely, suppose you have a building, a ramp structure, physical structure with a spiral ramp, helical ramp, and you stand at the top of that on a pair of roller skates, and you step off and you go round and round and round and round down from the top to the bottom. And as you're doing that, somebody observes you from directly above. You will be observed to be going in a clockwise direction. All right, that's the definition of a right-handed helix. So this you kind of sort of get the picture, not quite as clear. This is a little more helpful. You can get that clockwise sense, and maybe this separates it out and you can see this going around and round. So this is clockwise direction that defines a right-handed helix. So all of that is secondary structure. Tertiary structure returns to features of the whole genome. You can have not only linear DNA, but you can have circular DNA. Within the circle, you can have supercoiling. In the DNA, you can have bending of the DNA, twisting of the DNA, stretching of the DNA, and we'll illustrate all of these points. First of all, changes in secondary structure. You have zDNA. zDNA is, first of all, a left-handed helix. That means same, you have a ramp and you have the roller skates, you observe from above, and you're going now in a counterclockwise direction. The backbone zigs and zags, that's the Z and the zDNA. There are 12 bases per turn, and the bases are turned and flipped. So you have some irregular structures. We can see an illustration here. This is yet another presentation of DNA structure with filled in atoms and molecules. Here's a familiar bDNA. Note this backbone structure, nice, smooth, round sugar phosphate backbone. Whereas in zDNA, you have this irregularity, this zigging and zagging. Right? It's the same DNA, sugar phosphate backbone, base pairs in the middle, everything we know about DNA, but the overall appearance is dramatically different, especially if you look at this surface and think of it as a landing place for regulatory protein. This is very different from what you see over here. So zDNA is a very different target, and some proteins will bind to zDNA and not to bDNA, and so on. Other kinds of changes at the secondary structural level, you can have what's called cruciform DNA. You have this little looping on this strand and parallel looping on this strand. You can have triple-stranded DNA, either by insertion of another piece of DNA and form these kinds of triple bonding. Or sometimes it can be within the same double-stranded DNA, but it sort of folds back and comes back again, and you have connections between three strands. There's a lot of current excitement with regard to what's called G quadruplexes. All right, again, within a single strand of otherwise bDNA, you have a series of guanines that can be bonded to each other to form this quadruplex, 4 guanines. Look at it this way. This is all continuous single strand of DNA, but you have these quadruplex structures, and then you have 2 or 3 or 4 stacks of them. We look at it this way. Here's bDNA to the left, here's bDNA to the right, and here is this quadruplex. You realize that if this is a series of guanines, this is going to be a series of cytosines, and you can have a structure with these cytosines. It's called an I motif, a little different appearance, but again, an unusual structure in DNA. You can also have changes in tertiary structure of the DNA. We spoke about, right, starting from a picture of linear DNA, this is now going to circular DNA, and you can have supercoiling, twisting of that circle, right? So it's still a continuous circle, but now you have these twists in it, and it's shown in electron microscope. It's a real observation. You can have bending, curvature of the DNA. This is our familiar friend now, straight linear DNA, but you can have curvature and more curvature and even dramatic curvature. And this is a protein and clearly have many points of contact affected by the curvature. You can have twisting of DNA. This is, again, our regular familiar DNA. Picture yourself holding it firmly in the left hand and twisting it with your right hand. You can twist it tightly and have it overwound, and have it twisted the other way and have it underwound. And once again, thinking in terms of this as a landing site for a regulatory protein, clearly it makes a difference. Finally, you can have stretching of the DNA. This is a fist pulling this DNA outwards, and it gets longer and longer and longer, and you have, again, dramatic distortions in the appearance of the DNA and functionality of the DNA. Putting it all together, 2 projects I'm going to discuss. First of all, I created a website. This is the website of my operation, the Leifer Institute for Molecular and Digital Pathology, limdp.org. Take a look. And the purpose here is to put together a listing of chemicals that cause changes in DNA at each of these levels that we have discussed. So if you go into tabs at the top and press on ligands, you get the description of the things we just spoke about. If you press on ligands list, the next tab, you get this outline. And if we go at a higher magnification, you see all the things we just discussed: secondary structures, zDNA, G-quadruplex, I-motifs, cruciform DNA, and so on, or tertiary structure, curvature, supercoiling, linear length, which means stretching. All right, and as an example, those that affect DNA curvature, I've organized it so you have ligands that decrease curvature in this list and ligands that increase curvature in this list, and you have the literature references and where possible URL links to the literature. So as a more actual example, we'll list the ligand, we'll list its role in affecting the structure of DNA, and we'll give you the references that you can go to. Thinking beyond this, right, what I just described shows the effect of chemicals on the structure of DNA. What comes next is to look for the effects of these changes on protein binding. And if there is an effect to make binding increased or decreased, to look for biological relevance. It has to be a protein that's physiologically important and in the end medically important, and of course all kinds of exciting stories follow from that. As an example of biological relevance, some recent work on zDNA. Here's bDNA, familiar picture. Here is this distorted zDNA. Here's RNA polymerase. And in the normal procedure of transcription, you have an initial double-stranded RNA form. And that double-stranded RNA becomes a trigger for an interferon immune response. Here is ADR1, a protein recently discovered that binds specifically to zDNA. It also binds to double-stranded RNA at this point in the process to make it essentially not able to function as double-stranded RNA, particularly in terms of the interferon response. So if interferon is, let us say, problematic in terms of inflammatory, too much inflammatory response, too little inflammatory response, you have a modulation of that response by this protein binding to zDNA. I should also point out to you that there's some work from the Kim lab that found small molecules that can convert bDNA to zDNA. So coming around full circle to today's talk, you have chemicals that affect DNA with unusual structures in DNA with biological consequences. Just a couple of quick papers. zDNA relationship to disease. People are getting onto these ideas. P53, the tumor repressor, effect of DNA structure. The paper talks about quadruplex and cruciform DNA and triple-stranded DNA. You have more tumor repressor. Different paper talks about bending, twisting, and stretching DNA. So all of these aspects are ripe targets for the effect of chemicals. You have a naturally occurring molecule like the polyamines that can bind to and affect DNA structure. You have environmental molecules we saw in the Ames assay studies. Add to that list heavy metals. There's even a new journal called Exposome, which now addresses all of these factors in the environment which can cause changes that are physiologically relevant. So now coming back to regulogenesis, my goal was to develop a genotoxicity test to look for chemicals that affect DNA secondary or tertiary structure in such a way as to affect the binding of regulatory proteins, which everything we've been discussing. An assay, short-term genotoxicity assay in light of Ames assay parlay model, as we discussed. Some background, everybody knows black operon RNA polymerase binds to operator site and allows transcription of the gene to make the enzyme beta-galactosidase. It's a repressor protein that binds to a promoter site which blocks the polymerase. It sits between the operator and the beta-galactosidase gene and blocks transcription. And you have a chemical inducer, IPTG, which pulls the repressor off the operator and thereby allows transcription. The assay is based on using IPTG concentration, measure it and see how much is needed to pull the regulatory protein off the DNA. Operationally, you incubate E. coli in the presence of IPTG. You take samples, you measure enzyme activity, repeat with increasing concentrations of IPTG. That's the basic assay, and then you test with or without test compound. So here's your basic experiment. Enzyme activity is a function of IPTG concentration. Call this straight line in this region. You can measure inhibition. This is enzyme activity as a function of test chemical presence or absence of BUDR, bromodeoxyuridine. So here is your control. None added here is BUDR. Decrease in slope means for the same amount of IPTG, you get less enzyme compared to control, which we assume means tighter binding because of a change in DNA. Similar for cadmium. Cadmium also inhibits decreased slope. Can also have stimulation. Spermine is a little different assay format. You have a fixed IPTG and we're varying the format, same idea. And you get now an increased slope. Increased slope means easier to pull off, and therefore you get more enzyme activity. And if I have two test compounds together, you can get enhancement. If this is your control, call it 100%, BDR inhibitor takes it down to 70%, cadmium alone takes it down to 80%, but if I put in both of them together, I really knock out enzyme activity, so you have an additive effect. You can also have a reversal effect. Again, this is my control. I have BUDR inhibitor cuts it down to 66%. Spermine, the stimulator, raises it to 117%. And if I have BUDR plus spermine together, let us say this 66 is increased to 85. So you have a reversal of that inhibitory effect. Same story here. Cadmium inhibitor, spermine stimulator, together we raise the 72 to 88 and reverse the effect. So I'm suggesting that there are chemicals in the environment which will affect DNA structure in such a way as to affect the binding of critical regulatory proteins, and suggesting a screening program worldwide to find such chemicals. Obviously, it's important. Regulation is critical to cancer. Regulation is critical to development and to aging. And what is, to me, the most exciting observation is this story of inhibition and stimulation. In other words, if you have now some exposure to some chemical that may cause, let's say, an increase in curvature of DNA, and that's causing a medical problem, can I treat the patient with some chemical that will reverse the curvature and cure the patient? On the one hand, exciting to think about, on the other hand, testable, and we would like to look into that. Putting this all together, we have what I call diseases of DNA structure as a new category, a new paradigm, a way to think about pathology. It may even be a transient effect. As in development of the fetus, the mother was exposed to something she ate, something in the environment, something was a food additive, something in the medicine that she was given. that affect development. Development means gene expression at a particular time. So even if you very briefly block or overstimulate that particular process, you can have an effect on development. It may be due to internal molecules, as in the case of polyamines, so you have the whole world of metabolism within the cell and how it may affect DNA structure. And mostly as the Ames assay and the Nepal assay and a lot of the things we've been discussing, environmental variable factors, things that people are exposed to. And therefore, we would like to develop and continue the development of a testing system, a short-term system, as a screening system to find chemicals that may cause diseases of DNA structure. Thank you very much. Appreciate it.
So thank you, Dr. Zev, for your enlightening speech. Now the session is open for the discussion. Any questions from audience? Okay, so thank you, Zev, and thank you one and all. So here we are closing the session of day 3. So tomorrow we will start the meeting of day 4 at 8 a.m. Dubai time. See you all. Good night.